Good morning. Good morning. How are you?
Fine, thank you.
मैंने कहा मैं टाइम से ज्वाइन कर लूं, सबसे हेलो हाय कर लेंगे। फिर एक बार प्रोग्राम शुरू होता है तो नमस्ते नहीं होती है।
ये टाइम बहुत बढ़िया रहता है।
नमस्ते तो हो जाती है, फिजिकली तो मिल लेते थे, अब वर्चुअली।
डॉक्टर प्रतिमा का नाम है इसमें, प्रतिमा मित्तल में फोन कर दूंगी।
मैम मैंने कॉल कर दिया मैम को, मैंने कर दिया मैम, मैम आ रही है।
क्या इनको डॉक्टर प्रतिमा मित्तल को फोन कर दिया?
जी मैम, जी मैम।
हाँ थैंक यू
मैम अभी ज्वाइन कर रही है, मुझे लिंक
का सीन और कॉफी का कप देखकर ऐसा लग रहा है कि हम भी वहां पहुंच जाए। बैकग्राउंड और कॉफी इट्स सो बिल्कुल याद आ रही है, लग रहा है कि ये छोड़ो वहां पहुंचो।
ऋतु ऋतु
यस मैम।
ऋतु आपको ना 2 पीपीटीज मेल की है दुष्यंत को,
मिल गई मुझे,
है ना? मिल गई। एक तो डॉक्टर अंजू रस्तोगी की है, एक वैलिडिक्ट्री के लिए है।
मिल गई।
अल्पना मैम, मैम एक बार लिंक फिर से शेयर कर दीजिए, मैम को शायद दिक्कत हो रही है, प्रतिमा मैम को।
मैं कर रही हूँ। डॉक्टर हारा से बात की तुमने?
हाँ मैम, सर से भी कर रही हूँ, वो लोग एंटर कर रहे हैं मैम, उन्हें क्लिक करने में दिक्कत हो रही है शायद।
लिंक आपको मिल गया सर? प्लीज यू एंटर इन द मीटिंग। आई एम फ्रॉम गाजियाबाद से डॉक्टर अर्चना शर्मा बोली। हाँ सर ठीक है सर।
सुनील गुप्ता सर को भी कॉल करेंगे।
हाँ भेजा है सर, आप देखिए, नहीं है तो मैं भेजती हूँ, व्हाट्सएप पे भेजती हूँ। ओके थैंक यू।
सेशन होगा ना,
अच्छा
मैम हारा सर से बात नहीं हो पा रही है, सर का फोन उठ नहीं रहा है।
हेलो,
गुड मॉर्निंग मैम।
गुड मॉर्निंग। एक्चुअली मैं नेट से नहीं ज्वाइन कर पा रही हूँ, मैंने फोन से किया है अभी। तो
मैम लैपटॉप पे भी आप जूम खोल के वो जो आईडी मैम ने दिया उसे टाइप कर देंगी तो आप एंटर कर जाएंगी।
अच्छा अच्छा ठीक है, मैं करती हूँ कोशिश, है ना। अभी तो मैं इसमें तो ज्वाइन कर ही लिया है मैंने।
यस मैम।
गुड मॉर्निंग मैम।
गुड मॉर्निंग, गुड मॉर्निंग। हाउ आर यू?
गुड मैम, नाइस टू सी यू मैम।
थैंक यू बाला, हमें तो मजा आ गया इलेक्शन होके। चलो,
कचला यही कह रही थी कि ऐसे मुझे ज्यादा मजा आया।
हाँ वही तो बात है ना।
गुड मॉर्निंग डॉक्टर प्रतिमा।
गुड मॉर्निंग, कैसे हैं मैडम?
मैं ठीक हूँ मैम। आप अपने आप को व्हाट्सएप से मेल कर दोगे तो आप अपनी मेल से ये वाले
मैंने
में
करा है यार, वो ना तुम्हारा फोटो के साथ है, शायद कुछ चक्कर है। मैं एक बार
नहीं
दोबारा
लास्ट में फोटो से कोई टेंशन नहीं है, वो आ नहीं रहा होगा ना शायद आपके व्हाट्सएप उस पे।
हाँ उसमें, हाँ मैं 1 मिनट करती हूँ दोबारा से, है ना? हाँ
वरना मैम लिंक टाइप कर देंगे ना तो भी एंटर हो जाएंगे।
वो टाइप करना तो बड़ा मुश्किल है यार।
अब शालिनी
करती हूँ,
व्हाट्सएप
कर
बिना उसके भेज दो, बिना फोटो के, ऊपर की फोटो के।
हाँ वो बिना फोटो के व्हाट्सएप होगा ना तो हो जाएगा।
अच्छा मैम, ओके।
इसी में भेज दो, सेफ मदरहुड में।
यस मैम।
किसको भेजना है?
डॉक्टर प्रतिमा।
मैंने भेज दिया, उनको मेल भी कर दिया। आई थिंक उन्होंने ज्वाइन भी कर लिया।
मैम वो मैम ने फोन से ज्वाइन किया है, मैम लैपटॉप से नहीं कर पा रही हैं ज्वाइन।
मैंने दोनों जगह मेल पे भी
चलो
ज्वाइन
मैं
भेज दिया
कर
है और उस पर भी भेज दिया है।
ओके डियर, थैंक यू।
वेलकम मैम।
कॉल कर देना।
कॉल थोड़ी करनी है, मैं ये ज्वाइन करना है।
कॉल भी कर दिया मैंने, उनसे बात कर ली है।
ये कर रहे हैं। हेलो शालिनी,
मैम
लैपटॉप पे नहीं कर पा रहे हैं, इसे मोबाइल से केवल।
मैम अर्चना शर्मा मैम ने अभी लिंक शेयर की है दोबारा से।
सेफ मदरहुड पे?
जी मैम, जी मैम।
उसमें रजिस्टर
मदरहुड पे भी शेयर किया, पर्सनली भी शेयर की, डॉक्टर हारा को ईमेल पे भी कर दी, व्हाट्सएप पे भी कर दी।
नहीं मैम, नलिनी मैम का भी फोन आ रहा है, नलिनी मैम का।
अर्चना नहीं हो पा रहा लैपटॉप से, क्या करना है?
मैम फोन से एंटर कर जाइए, मैम फोन से एंटर कर जाइए आप, लिंक क्लिक करके डायरेक्ट।
फोन पे ही तो बोल रही हूँ, तभी तो बात हो रही है।
तो आपकी वीडियो नहीं दिख रही मैम हमें।
आ रही है मैम की वीडियो?
आप भी गई?
हाँ जी मैम।
ठीक है, मेरे को नहीं दिखी।
नीता दी मैं विजिबल हूँ?
हाँ बिल्कुल विजिबल है। गुड मॉर्निंग।
गुड मॉर्निंग। लेकिन ये मोबाइल से हूँ, लैपटॉप से नहीं हो पा।
अभी बना देना, चलो बना के जाओ, जा रहे हो ना?
नलिनी,
हाँ
तुम अपना ईमेल आईडी मुझे व्हाट्सएप करो तो मैं तुम्हें ईमेल पे दूंगी।
अच्छा।
नहीं तो नलनी, ये वाले सेफ मदरहुड वाले पे ना तुम ये जो है ना ये अपने को मेल कर लो और फिर इसको क्लिक
तुम
कर
एक
देना।
काम करो, तुम अपनी मेल आईडी मुझे व्हाट्सएप करो, मैं तुम्हें दे रही हूँ, फिर वहां से मेल से ज्वाइन करो। चलो।
अच्छा, डॉक्टर पंकज के फोन से करवा रहे हैं अपनी ईमेल आईडी।
मैम नलिनी मैम, ये जो मैम ने आपको शेयर किया ना, उसमें नंबर आ रहा है 86260150 करके, वो नंबर टाइप कर दीजिए मैम, लैपटॉप पे जूम खोल के आप एंटर कर जाएंगी डायरेक्ट।
हो गया? नंबर फिर से बोल दोगी?
मैम
फोन पे आ रहा है,
सेफ मदरहुड पे है मैम, 862
हाँ 162
601
601
503
503
17।
और आईडी?
आईडी मैम यही आपकी आईडी है, यही आईडी है।
जो ईमेल है ये आईडी है आपकी।
जो नंबर
किसकी? हमारी डीआर नलिनी।
हाँ आ तो गई मैम। गुड मॉर्निंग मैम। नहीं ये तो फोन ही दिख रहा है मैम का। Good morning, sir. Good morning, sir.
Good morning, Dr. Pratima.
गुड मॉर्निंग, गुड
How are
मॉर्निंग।
you?
गुड सर, गुड।
and with you is new Dr. Preeti. Good morning.
नमस्ते सर, गुड मॉर्निंग.
नमस्कार, नमस्कार.
प्रतिमा जी नमस्ते.
Thank you for
नमस्ते
inviting me.
प्रीति, कैसे हो? एक्चुअली आई एम ऑन फोन, है ना, नेट उस पे नहीं हूँ तो मेरे को सबकी फोटो नहीं दिख रही अभी.
क्यों?
पता नहीं, इससे हो नहीं रहा मेरा ना, नेट इससे कंप्यूटर से नहीं हो रहा. सब
कंप्यूटर पे क्लिक करके
मैडम हेमा
रजिस्टर करना पड़ेगा.
नमस्कार,
प्रतिमा जी
डॉक्टर
पहले.
विनीता नमस्कार,
नमस्कार
शालिनी
हरा.
नमस्कार, and डॉक्टर माला
नमस्ते प्रतिमा जी. हाय माला.
हेलो, हाउ आर यू?
बस ठीक है.
नाइस टू सी यू हेमा.
डॉक्टर माला.
आफ्टर दैट मीटिंग.
गुड मॉर्निंग सर.
मैम ईयरफोन्स लगा लीजिए.
गुड मॉर्निंग सर.
Good morning everybody.
गुड मॉर्निंग मैम. डॉक्टर हेमा, गुड मॉर्निंग.
नमस्ते.
गुड मॉर्निंग डॉक्टर हारा. गुड मॉर्निंग.
नमस्कार, good morning everybody.
गुड मॉर्निंग.
हेमा मैडम नमस्कार. How are you?
बस today our day is made. Hara, I'm seeing after a long time.
Yeah.
Same
I
here.
know.
And also listening his voice after a long time.
हाँ,
Long
डॉक्टर
time.
हारा has not been coming to webinars. I think most of
नहीं
the
नहीं प्रतिमा जी बहुत कर रहे हैं, अपने कर रहे हैं. अपने बहुत सारे कर रहे हैं. मुझे रोज लिंक आती है उनकी.
अच्छा, पर हमारे पास नहीं आई कोई भी.
हाँ, बहुत कर रहे हैं वेबिनार.
चलिए, गुड.
Corona times have taught us all this.
Yes.
Connect virtually.
नेट पे नहीं खुल रहा, वो कंप्यूटर पे नहीं खुल रहा है, फोन पे ही खुला है.
प्रतिमा जी रजिस्टर किया है ना आपने?
हाँ, रजिस्टर किया है. वो तो डेलीगेट वाला था ना.
नहीं, इसमें भी पहले रजिस्ट्रेशन मांग रहा है फिर रजिस्टर कर रहा है.
अच्छा, पता नहीं, रजिस्ट्रेशन नहीं.
आप एक बार ट्राई करिए, उस पे
हाँ, मैं
क्लिक
करती
करिए.
हूँ. फोन पे तो वैसे ही हो गया डायरेक्ट.
हाँ, नहीं क्लिक करिए उस पे, मेल पे ले जाइए उसको.
हाँ, आ गया रजिस्ट्रेशन मांग रहा है.
हाँ, तो उसको कर दीजिए, उसके बाद फिर आपका लॉगिन हो जाएगा.
ठीक है.
5 मिनट. 8 जीबी आउ जीबी नेट टिकट ऑनलाइन.
मैम अब अगर सभी लोग आ गए हैं तो क्या हम स्टार्ट कर सकते हैं अभी?
आ गया. थैंक यू. आई जॉइन फ्रॉम हियर.
प्रतिमा जी फोन वाला ऑफ कर दीजिए.
हाँ, मैं करती हूँ.
प्रीति जी बताइए, क्या शुरू कर सकते हैं?
बिल्कुल शुरू कर दो, नहीं आगे के सेशन लेट होंगे.
ठीक है मैम. ओके, स्टार्ट है तो.
And today start.
Yes, go ahead. Shani, go ahead.
यस.
बैटरी बंद करा.
Good morning and a very warm welcome to all the esteemed members of the Gynae and Obstetric Society. And without wasting much of time, I will like to proceed to the session. And before starting the session, I would request all the delegates to kindly keep posting the questions in the chat box, and we will take the questions after the sessions. So I will like to introduce our first chairperson, Dr. Pratima Mittal Madam. Madam is a professor and consultant in Department of Obstetric and Gynecology at Bardhaman Mahavir Medical College and Safdarjung Hospital. I welcome you, ma'am. Then Dr. Hara Patnaik sir has a renowned practice in gynae and obstetric at Odisha. Sir had been ex-special secretary Health and Family Welfare in Odisha. I welcome you, sir. The next chairperson is Dr. Mala Srivastava Madam. Madam is a senior consultant, professor, trained in endoscopic and robotic surgeries, presently working in Sir Gangaram Hospital. I welcome you, ma'am, to the session. Next is our Nalini Garg ma'am. Madam is a pioneer and founder member of GOGS. She is past president, vice president, secretary, and treasurer of the GOGS. Welcome, ma'am. The next is Vinita Mittal ma'am. Madam is an esteemed member of GOGS and director of Bardhaman Nursing Home. She is a past president of GOGS. Welcome, ma'am. I now request our first chairperson, Pratima ma'am, to kindly read the CV of our first speaker, that is Dr. Hema Devakar ma'am, so that we can start the session.
Good morning. First of all, I would like to thank the organizers. All of you have done such a wonderful job. I attended the conference yesterday and it was really, thought-provoking and very nice topics you have taken, and the cultural program also was wonderful. And I have given the responsibility of introducing Hema. That is, I think she's one of the most well-known person in the internationally, and we all know that she is a Foxy ambassador to Figo. And she is vice chair Figo GDM working group, and besides that she has been president of Foxy 2013. She is consultant at Divakar Specialty Hospital, Bangalore. Her work, so much work she has done in the community about the Manyata and about the Emo care, everything she has done, so much of work, and and her trainings have been wonderful. And as she's such a wonderful orator, I have listened her, I think about 25 years ago. And that even at that time, I was so impressed by her oration skills. And she's a great human being. And her passion for work, for the Manyata, she's doing so much of work for Manyata. And passion is really unparalleled to anybody. And besides that, she is very, very dedicated, and her leadership qualities are wonderful, and she's a great friend. So I welcome you, Hema. You are talking on GDM and NCD. GDM today and NCD later. So Dr. Hema, please.
Namaskar. The best part of the introduction is the last part where you said she's a very good friend. Thank you so much, because human relationships, I will count it above absolutely anything else that we have ever achieved, because together we can is what we believe in. And Pratima ji, the passion has turned into a purpose, and therefore relentlessly we are moving on to the best that we can do of the GDM today and NCD tomorrow. So just permit me a second to share my slides, and of course for the community of the Foxy friends who bring us together yet again to discuss some important initiatives. As you see here, the one and only person from the diabetes space that we see here is Dr. Sunil Gupta. Amidst so many OBGYNs who are here on this program, Preeti, Hara, Malaji, everybody, this is a small example of the mismatch of the ratios. If you have a woman with pregnancy, with high blood sugars, you can't always have the luxury of seeking help from our diabetology colleagues, because the numbers do not match. For 30 million pregnant women, taking a ballpark figure of 10% being hyperglycemic, it translates into at least, at the minimum, 3 million pregnant women every single year. And how will just a couple of thousands of diabetologists handle? So the responsibility squarely lies on the shoulders of us as the OBGYNs, who are the primary point of contact, because if she's pregnant, she will come to us, or any healthcare provider who is taking care of the pregnancy. And we have to take on the responsibility not only for the short-term issues of the pregnancy care and delivery, but you have to tag her for her rest of the lifetime, because what starts in utero for that baby will translate into something happening to that baby in its early childhood and adulthood, and of course also to that mother who was diagnosed as GDM. She is very, very likely to turn into type 2 diabetes as the years go by. So the three principles that we want to operate on is try and fulfill the dream of getting these women who embark on the pregnancy before they embark on the pregnancy, pre-pregnancy care. That has to be optimal, because there are many, many, many undiagnosed in the population who are very sweet. As how we were having a sneak preview before the start of this program, I said sweet connections, because this is all about diabetes. So there are many sweet women in the population who have never been tested for their sugars. So the optimization of the pre-pregnancy care is one important thing. When she gets pregnant, if her sugars are high, try your best by any which manner which you know, and we seek help from Dr. Gupta and other diabetologist colleagues, Cheshaya sir, and the team who have so strongly collaborated with us on how to strive to get her into a normoglycemic situation. And take home message, take home baby, take home mother, it doesn't end there. It in fact begins there for the NCDs. And therefore, we said there's no green color in this slide because GDM is amber today. It is already flashing an alert light to us. And NCD is a red that we may see tomorrow. So the GDM and NCD link, the hypertensive disorders and the cardiovascular disease link, the obesity in pregnancy and everything that happens in pregnancy is a marker for what can happen to her in the rest of her life. And it's just look at the numbers in Southeast Asia. SEA is Southeast Asia. The hyperglycemia is like we are ranking very, very high up. So we have a huge problem on our hand. So just for the numbers, 80 million diabetics in our country, both men and women. Half of them are women. So 40 million diabetics are in the population. Many more may be undiagnosed, but at least 40 million are there. Half of them, that is 20 million, have had the pregnancy diabetes and they have moved on to the adulthood diabetes. That means if we would have nipped it in the bud and given her the alert, maybe we would have contained these numbers. So it's GDM today and NCD tomorrow, because the lifetime risk of type 2 diabetes may be 20 times higher for those who have GDM, and 50% of these will have impaired glucose metabolism within 10 years after having gestational diabetes. Early pregnancies in our country is a common thing. So if she's 22 years and she's having a GDM, by 32, she's a full-blown diabetic. And we have many, many more cases brought to light in the COVID situation as well, because they have been tested for that because of the pandemic that is now around us. So same with the children born also, they're adding on to tomorrow's NCD population, and we have to get a handle on this as early. So Poshan Abhiyan from the government, the nutrition has been a strong focus, because malnutrition, when we call it, can be undernutrition or overnutrition. A woman can produce a low birth weight baby or a macrosomic baby. Both of them are going to be in trouble, because the environment in utero is the one which programs the baby for increased risk of adulthood obesity, cardiovascular disorders, and diabetes. And thus it gets transferred from the mother to the child in the womb, the Abhimanyu theory. And then it just keeps on propagating from generation to generation. In that sense, we cannot communicate it to our neighborhood, but the mothers can communicate to the next generation. So if you have to nurture the future generation, then you have to take care of your pregnant women. So the Barker's hypothesis on low birth weight, Peterson's hypothesis and macrosomia, all of them speak to the end point that this will lead to is the development of NCD tomorrow if you don't take care of the GDMs today. So malnutrition is inextricably linked with the non-communicable diseases. WHO is reporting that 1 in 3 people around the world suffer from some effect of malnutrition. Undernutrition causing more than 3.5 million deaths, overnutrition producing chronic non-communicable diseases, micronutrient deficiencies, which is a big thing now as per the recent WHO recommendation as recently as 2020 April, 2 billion women and people worldwide by inadequate diet of micronutrients, again a forerunner for the malnourished population snowballing into NCDs tomorrow. So what is our best time to act upon this? Preconception, of course, is the best time. So all mothers enter in the best of the optimal circumstances, and in pregnancy is the second best time to invest. Miss the bus there, then adolescent and early childhood, or at least in early adulthood, you have to get a handle, because maternal malnutrition campaigns and universal prenatal health care really should be promoted even in these parts of the world. So as I said, in the life course, just look at the vertical axis of NCD and look at the topmost line saying no intervention. If you don't intervene at any stage in the life course, that's where your NCD numbers are going to go and stand. Whereas you come to the mother and infant combination, if you have done your best there, that's your early intervention, and you will still have NCDs, but you'll have definitely far more smaller numbers. So don't miss the opportunity. Pre-pregnancy is the green zone. Reducing the traditional maternal mortality and infant mortality, morbidity, etc. Yes, that's okay, but don't forget the far-reaching implications. Please address the intergenerational prevention of NCDs, of diabetes, hypertension, cardiovascular diseases, how important it is, undernutrition, obesity, and the birth weight, which defines the further the course of the NCDs that men and women may have. We've seen here that low birth weight men, 40% chance of an NCD by the time they get to 60 years of age. Similarly, women who produce very small babies or very large babies, you'll see at both ends of the spectrum, the NCD rate is really, really high. This is evidence-based. This has got a strong literature support, and the weight at birth defines the projections of NCDs. And of course, if you do not guide them to lifestyle, the changing BMIs will also escalate the NCD. So in a nutshell, we want to say, yesterday, Pratima ji said, the Manyata, I really urge my champions that what we are doing in Manyata is tackling yesterday's problem. Okay, the emergency care and saving lives and etc. We have to quickly, on a fast track, move on with a sense of urgency to tackle the high-risk pregnancies and do the best for them to prevent the situation of cardiovascular diseases, hypertensive disorders, diabetes, and obesity, which may be, well, the epidemic that we as OBGYNs will be left to handle. So certain pregnancy-related complications, we know they predict the future chronic disease, and we have to strive every bit. So one last time, because so many times we have deliberated, and still there is a confusion about how to test and how to treat. So Sunilji will be telling about the oral hypoglycemics, which have come into a gray controversial zone and creating some confusion. So it's really important to hear him out. Universal testing. Don't spare a single pregnant woman. Test her for sugars at booking. And if that is normal, then in the mid-pregnancy with 75 grams non-fasting. So irrespective of she's had a heavy meal or she's coming starving, you can give her the 75 grams. And 2 hours later, just take one blood sample. If the value is more than 140 milligram%, label her as a case of hyperglycemia. So out of 100 women that you may test, 10 will turn positive, 90 are clear, but you need to test them again mid-trimester. So what do you do with those 10% of women? Medical nutrition counseling, which leaves much to be desired because we push all this diet counseling and all under the carpet. We need to do better on them and get 80% of these women under control just with instructions of diet and exercises. And 20% of them who are not in control will go to the next level of what Sunil is going to speak about, either the oral hypoglycemics or insulin. But your target is you have to get at the blood sugar levels that you have set in the range. So these easily doable tests are the Jugaad Indian method, but they're evidence-based. So single-step test has been approved by FIGO as well. So counseling cards for pregnant women, nutritional, medical risks, all these are listed, but the long-term complications have to be kept in mind, and we have to sensitize. Think nutrition first. That has to be the new mantra for every clinician. And all of these which will add and blow up the situation and create more problems, you have to pay attention to guide the patients to contain all of these peripheral epigenetic issues. Much is spoken about, but we know the situation of the women in our own country who neglect their health, low awareness, stigmatization, inadequate resources, poor service qualities. That is where we are trying our champions to move towards the quality healthcare in private and public sector. Women are not empowered often to make decisions about what food they have to eat. They eat the least and they eat the last in many of the families, rural India perhaps. The male partners are often the ones who bring in whatever has to come into the house and dictate the diet norms in the family, if I may say. Community health workers will influence a lot. So the key message from the celebration are perinatal nutrition and other factors, fetal programming, the genetic background, portraying into the adult chronic diseases, and something that is so preventable, high risk in the preconception, interconception, pregnancy. We just had a panel discussion with stalwarts participating in that. It's not the adolescent who is just going into reproductive age and it's the first pregnancy and she's pre-pregnancy. Pre-pregnancy is also in between pregnancies. She's finished her first pregnancy with dismal outcome, but before she embarks on the next pregnancy, you have your chance to do your best so to contain the NCDs. I'll close with this last thought. What is the missed opportunity? She's 22 years old. First delivery, 3.9 kilo baby. Everybody in the family is happy because she's so thin, but she's produced a wonderful baby. Nobody has tested her for anything. 11 years later, she's now 33 years old and she has a second pregnancy. BMI is 30. At 12 weeks gestation, we say single step. So we've done the single milligram percent with HbA1c of 8.8. Not assessed pre-pregnancy. And of course, 11 years back, we didn't have this universal testing concept. And this young lady is prone to several complications, not only in pregnancy, but also well beyond that. So it is a call to action, dear friends. We have to now walk the talk. We have to push the caregivers and the women themselves to understand these risks and do better for themselves. Inter-pregnancy, please focus on their weight loss initiative. Don't let them lose. So the National Diabetes Prevention Program, that's the next dream. Digital diabetes clinics and National Diabetes Prevention Program. This will be our further mission to make it cost effective, to make all of us available on artificial intelligence platform 24/7. She knows what to eat. She knows how to manipulate her dosages, but she is in normoglycemic situation. Don't leave her postpartum. Tag her for the rest of her life. And even on behalf of FIGO, we call for a universal approach, discussing think nutrition first, bringing home the risks of obesity, the NHSF5 data, even for Karnataka, the obesity has scaled up like anything. So it's a new emerging problem. So we need to give the gift of life free from non-communicable diseases to the next generation, so that we thank God for helping us move in this direction, recognizing the implications of how best we can manipulate the in utero situation, so that the generation next will be happily and proudly thanking us for what we have done to nurture a healthy generation next. Namaskar.
Thank you, Hema. I think you have given a very comprehensive and crisp and relevant, top points which you have discussed, talking about increased number, talking about the fetal origin of NCD and malnourishment, pony initiative. You have covered almost all the important points, and best is the clear message. We as a gynecologist have to follow the life course approach. Start in the during pregnancy for the fetal origin. Think of fetal origin. Talk of the adolescent. Talk of the preconceptional care, and take care of the pregnant woman. Diagnose universal screening, and of course that only will help us preventing NCD in future. Thank you, Hema, for a wonderful talk. Thank you.
Thank you.
Thank you so much for such an enlightening talk. I will now request our Hara sir to kindly introduce our second speaker to the members.
रिस्पॉन्ड नहीं कर रहा है, उसमें लीव भी नहीं कर रहा है, ये गोल गोल घूम रहा है.
Namaskar. Again, thank you UPCOG, thank you Ghaziabad, and thank you Safe Motherhood Committee, Foxy, for giving us the opportunity to have this program in a hall called Ganga, and early morning at 10 o'clock. And after the excellent presentation by Dr. Hema Dibakar from GDM to NCD, now it's the turn of a illustrious diabetologist, Dr. Sunil Gupta ji. And Gupta ji, namaskar. He is a well-known personality in Nagpur. We have come across to get his advice on many issues. He will be speaking on management of hyperglycemia in pregnancy. His CV, as it reads, speaks that he is a great academician and diabetologist from Nagpur. He is the CEO and MD of Sunil's Diabetes Care and Research Center in Nagpur. He has 194 publication in national and international journal, speaks volume of his academic work, 14 national oration and president oration. Wow, Sunil ji, great job. 6 national and 6 international fellowship. That is another feather on his cap. Conducted more than 2,000 programs all over the country. Presently, he is the honorary treasurer of RSSDI India, and he also got many awards. To speak one, he is Bidharb Gaurav Puraskar and Outstanding Young Indian Award. I must have a great clap for this personality. And let's hear from Dr. Sunil Gupta. His advice to all gynecologists sitting here and listening regarding how we are going to manage hyperglycemia in pregnancy. Dr. Sunil, the stage is all yours.
Thank you, Dr. Harprasad. It was a wonderful introduction, and rarely I get a rare honor of getting such a wonderfully explained introduction of mine, and I feel really moved on this. So nice of you. Thank you very much. Can I just take 30 seconds to share my slides? I feel no, this is not mine.
This is all brainchild of the great lady, Dr. Priti Kumar. Hats up to this lady, Dr. Priti. Congratulations again. Dr. Sunil, sorry to interrupt you.
I'm just trying to open my my presentation. It's there, but it's not coming on.
I took that opportunity to thank my friend, Dr. Priti. Yes.
Sunil sir, first of all, open your slides.
Yeah, but I have already opened. I'm
Then click on share screen button.
Coming on the, I'm coming. It's already open. Yeah, it has come now. It has come. It has come. It takes little time, I think. Can you see it now?
Yes, sir. We can, sir.
Yes.
Is it okay?
Yes.
So, so thank you very much once again, and I take this opportunity to speak on this platform. It's a workshop, so I'll be little more into practical aspect of the whole therapy here. Thank you very much, Dr. Priti Kumar, Dr. Alpna, and Dr. Archana, and the team of UPCOG. And thank you, Hema Madam, for always being with us to guide us for practical aspect of this pregnancy diabetes. Wonderful deliberation. Congratulations to you once again. Every time we try to learn something more from your deliberations.
Thank you.
So my talk is going to be on introduction. Monitoring I'll cover a little bit, and then the pharmacotherapy. Postpartum, I don't think I'll get time. I always show this slide that GDM is a window of opportunity that you are taking care of two generations. The mother who's likely to become diabetes in future, and the child born to this mother of gestational diabetes are likely to become in adolescent and adult life likely to develop all non-communicable diseases, which include diabetes, metabolic syndrome, obesity, and other things. I feel this classification is known to everyone. When we talk about pharmacotherapy, it differs from the type of diabetes. When it is a pure gestational diabetes appearing in the second and the third trimester, then possibly 80% of your GDM will do well only on diet therapy, medical nutrition therapy, and you will be able to achieve the goal. But when it is diabetes in pregnancy, which could be either pre-existing type 1 or type 2, or becoming pregnant, gestational diabetes, or those who are being diagnosed for the first time in the first trimester, usually with type 1 or type 2, and they all with the management strategy will differ, and that is why I have shown this slide to you. So higher is the blood glucose at the time of conception or the first trimester, higher is the risk of having most of these complications. Maybe it is congenital malformation or stillbirth, or so you have to see to it that your mean blood glucose doesn't go above 105, and that should be a target. If you have hyperglycemia at the time of conception and ovulation, And in that situation, the risk of congenital malformation is high. In third and fourth and sixth, fifth and sixth week, one by one, you'll have risk of having most of the congenital malformations. And that is why we should try to achieve the goal of less than 6, or ideally 6, less than 6.5 HbA1c before you get conceived. And that is why very nicely one of the chairperson has quoted that it is the preconception counseling which is also important, because we are getting more and more type 1 and type 2 now young women, they are becoming pregnant, especially type 2 and obese young women, and even women with PCOS. So you have to see to it that your HbA1c is as normal as possible. Recommendation less than 6, less than 6.5 acceptable. If you have increased risk of hypoglycemia, then less than 7 is acceptable. So we also have now, fortunately, national guidelines for management of gestational diabetes in 2014. They have been again upgraded in 2018. And glycemic goals, what we see is, let us see now, this is very recent. I am fortunate to receive the American Diabetes Association 2021 recommendations, which are actually published just yesterday. So I took little time to go through it and have incorporated those slides. So this is an absolute updation of every one of you as well as me. So pregnancy in women with normal glucose metabolism is characterized by fasting blood glucose lower than in the non-pregnant state due to insulin dependence glucose uptake by the fetus and the placenta. So baby is being fed continuously as well as the placenta while the mother takes meal intermittently. So the overnight fasting will actually reduce fasting blood glucose almost by 10% versus the non-pregnant state of the same women. Similarly, by mild postprandial hyperglycemia and carbohydrate intolerance as a result of a diabetogenic placental hormone. So you have hormones. So postprandial hyperglycemia mimics basically a hormonal related insulin resistance, usually HPL and placental hormone, and they may cause postprandial hyperglycemia, while fasting hyperglycemia is because of the hepatic glucose output in non-pregnant state, but it is usually lower in pregnancy. So whenever it is a pure GDM, fasting may remain normal and you will have a postprandial hyperglycemia, and your therapy, whether it is insulin, whether it is oral drug, should be on the basis of self-monitoring of blood glucose, what you are supposed to do during the after the diagnosis. In pre-existing diabetes, glycemic targets are usually achieved through a combination of insulin and medical nutrition therapy. So before we go to the insulin therapy, let us understand some important aspects of insulin physiology in pregnancy. One, I told you that the fasting might remain lower and postprandial spikes will be there. Second thing, early pregnancy is a time of enhanced insulin sensitivity and lower glucose levels. And many women with type 1 will have lower insulin requirement and increased risk of hypoglycemia in the first trimester. At around 16 weeks, insulin resistance begin to increase and the total daily insulin doses increases linearly by around 5% per week through the 36 weeks. This usually results in doubling of the daily insulin doses compared with the pre-pregnancy requirement. I'm talking about type 1, to some extent type 2. The insulin requirement level off towards the end of the third trimester. So after 36 weeks, the insulin requirement may get stabilized till delivery. A rapid reduction in insulin requirement, very important. Rapid reduction in insulin requirement during the course can indicate a development of placental insufficiency. And that is why it is very, very important to understand this physiology. So glucose goal reflecting this physiology, the fasting and the postprandial blood glucose is recommended to be achieved metabolic control in patients with diabetes. Preprandial testing is also recommended. So first is fasting and all three post meal, that is first monitoring we are supposed to do. Pre-meal, that is pre-lunch, pre-dinner, also recommended when you are on insulin pump or on the basal bolus therapy, where you have multiple doses of insulin you are taking. Postprandial monitoring associated with better glycemic control and lower risk of preeclampsia. These are very recent data of January 2021 recommendations. We are talking almost 15-20 days prior to the recommendations. So ADA recommends fasting should be between 70 to 90. Earlier in last 2020 recommendation, they have not given the lower figure, but this time they have added lower one. So now it is 70 to 95, 1 hour 110 to 140, and 2 hour postprandial 100 to 120. Government of India guidelines or DIPSI guidelines says fasting should be less than 90 and the 2 hours should be less than 120. But now you have got a lower guidelines also on the basis of the data available to us. So that is included. Now, there is another monitoring system which is called as time in range. That how much period of your 24 hours where you are under therapy or pharmacotherapy, either diet or insulin or pharmacotherapy, how much total 24 hours time is in time in range, that is being calculated and assessed by the ambulatory glucose profile. This has again been included in the guidelines now, that the time in range that is being defined as between 63 to 140 in 24 hours should be more than 70%. That means in 24 hours, more than 70% of the time, the women should be in this range. That includes 2 hour, 1 hour fasting, everything. The recent one more paper which I have gone through, which doesn't have not come into recommendation, is they say 80% and not 70%, but at least minimum 70%. Below range, that is low blood glucose, less than 63, should not be more than 4%, should be less than 4%. Below range of 54, that is severe hypoglycemia, should not be more than 1%, and above range, that is more than 140, should not be above 25%. So total 100% of the 24 hours have been divided into 70% in range, 25% above range, and this. So if you adjust, if you get this time in range through CGM, I feel we possibly achieve the best glycemic control, and it will also reduce the glycemic variability or glycemic the glycemic variability related. You have glycemic variabilities spikes in the lower blood glucose. You have sometimes to 150, 180, sometimes you go to 60 and 50. So it's called as glycemic variability. If you reduce glycemic variability, possibly some of the unwanted and undiagnosed outcomes can be taken care by maintaining time in range. With this, I feel I'll be very brief here in future because these are some newer things which have come. So medical nutrition therapy, exercise, oral drugs. My talk is on pharmacotherapy. So metformin, glibenclamide, acarbose, these are three which are being advocated. Government India has advocated and recommended only metformin. So let us talk about ADA 2021 metformin on the basis of data available. Metformin was associated with lower risk of neonatal hypoglycemia, less maternal weight gain than insulin. But one should know that metformin readily crosses the placenta. Any drug which crosses the placenta, we have to be careful. And this is almost sometimes more than the maternal level. Nearly half of the patient on GDM who are with GDM were initially treated with metformin, but they could not achieve good glycemic control and they required additional insulin. So it crosses placenta. It is relatively weak a glucose lowering agent. Tofu trial has come out with the data of the babies who are born to those mother who were on metformin versus born to those mother who were only on insulin therapy, and they said that there is a risk of central after 7 or 9 or 10 years of age. There's some more data from PCO group. They also say that 4 years that they have higher BMI, and 5 to 10 years showed that there is higher BMI. So more and more data is coming, and it has also come into recommendation about metformin. Metformin is being also studied in the MITI trial, and very fortunate to share some of the data on MITI trial, which has just been published in 2020, 2 months back. And then also there is another, this is MITI trial is on type 2 individual, that's pre-gestational diabetes. The MIC trial is on gestational diabetes, where metformin started after 20 weeks of gestation. In MITI trial, the type people were already on metformin before conception or during in the first trimester. There's another trial on type 2 diabetes, which is MOMPOT trial, which will be published later. And let us check on something learn from MITI trial. So around 500 women, 250 on metformin, 250 on placebo. So compared with the women in the placebo group, metformin treated women achieved better glycemic control, required less insulin, gained less weight, and had fewer cesarean sections. So MITI trial has basically come out with a good outcome as far as these points are concerned. Compared with placebo, metformin exposed infant weighed less. Metformin exposed infant had reduced adiposity measures, and there is higher proportion of small for gestational age. That is a final message from them. What they say, they found that several maternal glycemic and neonatal adiposity benefit in the metformin group, along with reduced maternal weight gain as well as insulin doses and improved glycemic control. The lower adiposity and infant size measurement resulted in fewer large size, so less macrosomia, but a higher proportion of small for gestational age. Understanding the implication of these effects on infant will be important to properly advise patients who are contemplating the use of metformin during pregnancy. And that is what the question I feel Dr. Hema has raised during her deliberation about metformin. So RCT comparing metformin with other therapies for ovulation, that is PCO, have not demonstrated benefit in preventing spontaneous abortion or GDM. So metformin doesn't prevent GDM. Metformin has not shown to spontaneous abortion, and that is why there is no evidence-based need to continue metformin in such patients or PCO who have already attained pregnancy. And we say that after 3 months or 12 weeks, we can withdraw metformin, and we should come out of that obsession of continuing metformin after delivery. There are some women with GDM requiring medical nutrition therapy due to cost, language barrier, comprehension, or cultural influences, may not be able to use insulin safely or effectively in pregnancy. Oral agent may be an alternative in these women after discussion of the known risk, and possibly it's better if you mention it in your data that why you have given metformin. However, due to potential of growth restriction or acidosis in the setting of placental insufficiency, these are contraindications. Those who have placental insufficiency, metformin should not be used in women with hypertension, preeclampsia, or who are already at a risk of IUGR. So metformin is contraindicated these patients. In India, we are using it aggressively. Many of you are using it. We don't mind continue using it. The only thing is we have to be a little careful of these contraindication as well as explaining the risk of these children. Sulfonylurea, we have only one slide because we are in India, we are not using glibenclamide as aggressively. It is known to cross placenta and have been associated with neonatal hypoglycemia. And the concentration also goes around 50 to 70%. It is associated with neonatal hypoglycemia and macrosomia than insulin or metformin. There is no additional benefit versus insulin, and there is also has not shown to be superior, and the long-term benefit is effect on offspring is also not available to us. So we at this moment of time should not worry about sulfonylurea and should not unnecessarily give. About insulin, GDM who failed to respond to meal plan for 2 weeks are more than 90 fasting and 2 or more than 120. So if you are given a medical nutrition therapy, fail to achieve 90 or 95 and 2 or 120, you should switch over to insulin. These are some FIGO guidelines, again, almost on the same line as ADA, that 20 weeks you can give. Absolute indication for insulin therapy, those who have already significant diabetes-related morbidity, high HbA1c, patient with ketonuria, associated renal or hepatic dysfunction, significant obstetric morbidity like macrosomia, IUGR, or hydromnias, expected deterioration of glycemic control, or women on steroid, they all should be given insulin as a preference. If you have HbA1c at the time of diagnosis more than 6.5, fasting more than 125, 2 or more than 200, diagnosis of HIP in the first trimester, almost all cases of type 2, pre-existing type 2, and all type 1 will need insulin therapy, so should not try oral drugs. These are some of the I feel I have already discussed about metformin, so I'll not go in this thick slide. Acarbose, metformin, I'll skip this. In US, they use oral drugs quite regularly. And if you see here, insulin, of course, is around good number. But in any use of pregnancy, if you see, even insulin is being used, as well as sulfonylurea is also quite nicely being used they use glibenclamide very aggressively. I feel this again a data from US, which says around 75% on insulin, many of them on oral drugs. So for insulin, women with type 1 or type 2 should be prescribed low dose aspirin, also 60 to 150 milligram per day, from usual dose around 81 milligram per day from the end of the first trimester until the baby is born, to reduce the risk of preeclampsia. Insulin is a preferred drug versus metformin or glibenclamide, and but in some cases there is good safety data available. Glyburide and metformin fail to provide adequate glycemic control, so around 50 to 75% of the patient, 50 to 75% will respond. Rest of the 30 to 50% may need additional insulin if they are kept on these drugs. Some important message for HbA1c. People do have this question that whether HbA1c has any role in diagnosis and whether it should be used. Due to increased red blood cell turnover, A1c is slightly lower in normal pregnancy than in non-pregnant state. Ideally, A1c's target should be less than 6, and if it can be achieved without increasing risk of hypoglycemia. But if the target can be relaxed to 7, less than 7, if to prevent hypoglycemia. When used in addition to pre and postprandial SMBG, CGM. So again, there is always a debate whether we should use only CGM. CGM cannot be, continuous glucose monitoring is not a cup of tea at this moment of time in all pregnancy. In selected cases, you can do that. So you still have to rely on SMBG. These are again 2021 guidelines. So you have to have on pre and postprandial SMBG. CGM can help to achieve HbA1c better. When used in condition to SMBG, targeting additional pre and postprandial targets, CGM can reduce macrosomia, neonatal hypoglycemia in pregnancy complicated with the type 1 diabetes. So in type 1 diabetes, CGM, those on pump have certainly helped. CGM metrics may be used as an adjunct, but should not be used as a substitute for self-monitoring of blood glucose to achieve optimal pre and postprandial glycemic targets. So commonly used estimate of A1C and glucose management indicator in calculations should not be used in pregnancy. So we have some another part, I feel, that is for physicians. Which insulin is safe? I'll be very brief. Before starting insulin, you should know that insulin being secreted in 2 forms. One is a basal insulin, which is constantly being secreted whether you take meal or you don't take meal in non-diabetic or in all the normal non-diabetic pregnant women, or even pregnancy or non-pregnant state. And the bolus insulin is when you take breakfast, lunch, dinner, or small snack. That time your insulin being secreted from the beta cells in a bolus form. So insulin has to be, when we try to replace the insulin, it should match the physiology of your system. And that is why physiological insulin replacement remains the goal for pregnancy. So you also have, so you should control all. If it is a pure gestational diabetes, it will be postprandial hyperglycemia, possibly you need prandial insulins. And if you have fasting hyperglycemia also, then you will need basal insulin. There are also newer insulin which are ultra fast acting. So I'll just be very brief that when you use analogs, action is better, peak is being covered better, and there is no late evening hypoglycemia. If you have fasting hyperglycemia, you might need additional basal insulin therapy. These are insulins which are approved, which is regular insulin, which is human insulin. Aspart comes by the name of Novorapid and now of YASP, and Lispro-insulin. They are short-acting insulins and rapid-acting analogs. Detemir is the only
जनरल है उसको 3 दिन से बुखार आ रहा है.
And then you can also have insulin, and which can be used as intermediate acting insulin. There are also combinations, but I'll always prefer going for basal bolus therapy. Doses, we have some good data available that if it is a early mild GDM, may need, those who are requiring insulin may need insulin around 10 units, less than 10 units per day, GDM around 23 units per day, and pre-pregnancy, pre-gestational diabetes type 2 less than 52 units per day. Important message is not the dose, because it has to be individualized and you might get different patient with different doses. Dose increases by around 1.5 to 2 times from the diagnosis till delivery, and that has again come into the recommendation of ADA that by the time of delivery, every week you might need to increase the doses in type 1 diabetes. Same has been shown in type 2 diabetes. This is the per kg body weight distribution. You can take a screenshot, and many of these patients with either it is early GDM, this is mild GDM, GDM, and the pre-GDM might need insulin on those lines. This is quite 17-year-old data, but and important is that the pre-dinner dose was higher than the breakfast dose. So we possibly need post-dinner monitoring also. Some of them may need additional metformin to achieve better control along with insulin after the insulin failed to achieve good glycemic control. Twice versus 4 times a day, we always preferred 4 times a day insulin therapy if someone is requiring basal bolus therapy. Insulin dose has to be individualized. Mathematics may help you to guide, but you have to individualize the therapy on the basis of SMBG. Pre-existing type 2 diabetes, possibly the only data available from Asia is on type 2 diabetes, around 100 pregnancies. First trimester, they required around 0.5 unit per kg body weight of the pre-pregnancy weight. And by the end of third trimester, it went up to around 0.8 unit per kg body weight. So if you just compare that the gradual increase in the insulin resistance causes increasing dose of insulin till delivery, which varies from 1.5 to 2 times at the time of delivery. So this is what has been also documented and published in Indian literature. I already told you that we have to monitor post-dinner also, and pre-dinner as well as post-dinner also. Some of the women might need difficult cases of brittle diabetes, difficult cases with severe hypo and hyperglycemia, not getting control multiple doses. You may switch over to insulin pump, and I'll not go into detail for the want of time, but we had 2 such patients, one type 1 and one type 2, who were put on pump and have responded very well. Intrapartum follow-up, the target, very important message is you should try to keep a blood glucose between 70 and 120 at the time of intrapartum phase, so that you prevent neonatal hypoglycemia. Many of the GDM women might not need any extra insulin during seizure or during intrapartum phase, but those who are on high dose of insulin might need to be put on insulin infusion. And by putting on them on insulin infusion, you can adjust the doses every half an hour and control the blood glucose. Postpartum, so insulin resistance decreases dramatically immediately postpartum, and insulin requirement need to be evaluated and adjusted, as they are often roughly half the pre-pregnancy requirement of the initial few days of postpartum. And the contraceptive plan should be discussed and should be implemented. Screen the woman at 4 to 12 weeks postpartum and using a...
Sorry to interrupt you, sir.
Madam,
Actually, we are getting... Sorry, Dr. Sunil.
Yes.
I'm sorry to interrupt. We are getting a little late. Can it be a little fast?
Yeah, madam, this is the last slide. I will skip breastfeeding. So if the glycemic control can be maximized to the extent that the fetus no longer recognizes that its mother has diabetes, then the treatment of mother during pregnancy may become the first step in prevention of obesity and diabetes in the offspring. Primordial prevention. I feel we have to now speak on those lines, that we should achieve as good control as we can. And now 10th of March has been recognized as a National GDM Day, and everyone should do good awareness program on this day. Thank you very much for your patience listening. I'm sorry I exceeded time, but it was possibly important to cover those points.
Thank you, Dr. Sunil, for those wonderful presentation. In fact, you have the most updated data with you, and very practical tips you have given. Sorry, Dr. Preeti, we have overshot the time. I think I will like that next chairperson to introduce the next speaker, so that we can go ahead with the presentations and deliberation webinar. And my regards to all the stalwarts of Paxi. Yeah.
Hello. Good morning. Good morning,
Good morning, Preeti.
Good morning, ma'am.
Preeti.
Good morning.
Shalini, everybody, good morning. Good morning.
Madam, good morning.
Good morning, Usha ji.
Good morning.
Madam, namaskar.
Hi, Rishikesh. Namaste.
Namaskar.
Good morning. Good morning, everyone.
Great.
Good morning.
Good morning, Usha
Great.
ji. Good morning.
Good morning, Rupma.
बहुत मजा आया.
Can we start this?
I think we'll
Yeah,
give
we are already late, sir.
we are already late. Let Dr. Bala Srivastava
Yes,
introduce the
yes,
next speaker.
yes.
Go ahead with the proceeding and question answer at the end. Dr. Bala.
Sure.
Thank you, sir. Thank you, sir. It's my
हेमा जी,
privilege
ऋषिकेश.
and pleasure.
Pardon?
It's my privilege and
बहुत अच्छा
pleasure.
लग रहा है हेमा जी और ऋषिकेश सबको देख के. So nice.
Thank you, ma'am.
So nice.
Good morning.
प्रतिमा, good morning.
Namaskar,
Good
madam.
morning.
I think everybody should mute except Dr. Mala Srivastava. Then only Dr. Priti Kumar will switch on. Right. Yeah.
It's my privilege and pleasure to introduce Dr. Priti Kumar. Dr. Priti Kumar
Please,
is the
everybody,
chairperson.
mute yourself. Please, mute.
Dr. Priti Kumar is the chairperson of Safe Motherhood Committee of FOGI. She is the director of Sunflower Medical Center, Lucknow, Vice President, Lucknow OB-GYN Society. Madam has been the organizing secretary of AICOG 2020 Lucknow, and she got the appreciation award by FOGI for
कोई बोल रहा है अभी पीछे से. Please mute कर लीजिए सब लोग.
Thank you, Malaji. I think we are already running short of time. Can we start the session? Thank you so much for the kind words, Malaji.
Organizing secretary also of North Zone Yuva Foxy. Dr. Preeti, you have such a long list of achievements that we will take at least half an hour to speak about it. But I'll cut short the time. I'll request you to go ahead with crosstalks on clinical management of hyperglycemia and pregnancy.
Thank you so much,
Dr. Preeti Kumar, to carry on.
Thank you so much, Dr. Mala. Thank you so much. First and foremost, I would like to thank the organizers, especially Dr. Archana Verma ji, Dr. Archana Sharma ji, Dr. Vinita, and both my dear Dr. Alpana and Dr. Alpana Dio. And thank you so much, Dr. Usha Sharma ma'am. UPCOG is very, very close to our hearts. Thank you all the chairpersons, especially Dr. Hara sir, Dr. Pratima Mittal, Dr. Mala Shivasto, Dr. Nalini, and Dr. Vinita. So I think we have already overshooted the time. So I'll try to cut down the panel because we have the oration. So I'll quickly start with the presentation. We have two stalwarts here with us today. And as I mentioned, UPCOG is always very close to my heart because I got the first oration of my life in UPCOG, and that was Dr. B. Ragnyoti's oration. So that is very close to my heart. And today we have a panel of very esteemed faculty members, Dr. Hema Divakar and Dr. Sunil Gupta, and you are hearing them for last, I think, 13 minutes. So we are going to take them on board for discussing some of the very important problems in hyperglycemia and pregnancy. This is Dr. Hema Divakar, right now the FIGO of NCD committee chair of FIGO. And initially she was the vice chair of hyperglycemia and pregnancy committee of FIGO. Now she talks about the generation next. You can see at the center, her mother is standing with Dr. Hema. She talks about the generation next, and she's the icon and an international figure when we talk about the NCDs. The second one is Dr. Sunil. You have been hearing him for the last 20 minutes, and Dr. Hara has introduced him. I'm very fortunate enough to get associated with Dr. Sunil. I must tell you, he's the next president of DIPSI. He will be taking charge in February, and I will be most probably collaborating with DIPSI once again to have some more sessions for our Foxians for the hyperglycemia in pregnancy. So Dr. Sunil, welcome to this forum of Safe Motherhood Committee. So I'll not take much of the time, and we have a few more stalwarts sitting here like Dr. Manju Shukla and Dr. Vinita Das, madam, who are again joined in the management of hyperglycemia. So we'll take a few questions because we have just 10-15 minutes. So we'll take a few questions. Dr. Hema, you just now mentioned that 40 million, almost 40 million women are suffering from hyperglycemia in pregnancy, and out of these 20 million females are having hyperglycemia in pregnancy, and out of these 5 million are from itself a country, India. So we need to talk about the generation next. We need to talk about the transmission of hyperglycemia and pregnancy in multi-generational transmission. We have to stop this. And that is why we talk about the David Barker hypothesis of fetal origin of adult diseases. And when we talk about hyperglycemia, sugar is the component, what we talk about. And this stimuli for a period of time can affect the fetal tissues, can affect the fetal organs, and it can cause a permanent derangement in the mother as well as in the fetus. So quickly coming on to this first question, Dr. Hema said optimization of sugar level is must. Optimization, optimization. And this is what Dr. Sunil also mentioned. So here comes a case of 36-year obese old female with BMI of 30, a PCOS type 2 diabetes, a known hypertensive for 2 years, because quite often now we are seeing diabetes in early age. And she's hypertensive for 2 years. She's on Aten 50 and married for 6 months. She comes to your office for a follow-up. Her blood sugar level has been controlled, well controlled on metformin. Dr. Sunil has talked a lot about metformin, the pros and the cons of metformin, and she wants to have the baby. But she's worried. She's worried how can we prevent these complications with diabetes in the pregnancy. So, Dr. Sunil, the question to you is, what should you advise to this patient, and what should we tell her regarding the anti-diabetic medications? We have talked about the nutrition, we have talked about the lowering of the weight, reducing the BMI, we have talked about the control of sugars. Just a next question to you, Dr. Sunil. I just wanted to ask you, you just now mentioned that the HbA1c of 7 is optimum. We can go ahead with the pregnancy planning at a level of 7. Sometimes we get a level of 7.5, but when we do a blood sugar fasting and PP, they are normal. So what do you think? What should we emphasize on? Should we emphasize on, because now what we talk about is time and range that you just now mentioned, that we have to focus because HbA1c may not be that very important marker. So I just want to ask you, is the blood sugar fasting PP more valid if the patient come to us, or should we rely on this HbA1c of 7? Dr. Sunil sir, can you take up this question?
Can we go to the previous slide?
Yes, sir.
Yeah, the previous one is the case. Yes,
sir.
So she's an obese lady with PCO. So what we have to do is, one is the preconception counseling, that she'll have to be shifted to safer oral anti-diabetic, safer drugs. One is that achieve the euglycemia of 90 or 95 fasting and postprandial 120 on multiple doses of insulin therapy, which is basal bolus therapy, along with metformin, because she also has PCO and obesity. So we'll have to, that because MITI trial has shown that otherwise metformin seem to be quite safe when it comes to, but along with insulin, she can certainly use metformin here in this case, considering PCO also. So we have to achieve ideally less than 6 and not 7. We should try to achieve at least 6, if not possible 6.5. 7 is the worst situation. So we should try to forget 7 at this moment of time and try to achieve as much possible as we can. 7 usually is for type 1 diabetes, where you have very difficult and brittle diabetes, sometimes very difficult to achieve in type 1 diabetes. But type 2, I feel we will be able to achieve in combination with metformin less than 6 or 6.5. And they should be achieving this before the conception one. Why we are saying, if the time is given, I feel we should give it 2 or 3 months time to them to achieve good HbA1c control. We have pointed a very important question here, that if the fasting and postprandial is normal, HbA1c will take 2 to 3 months to come down. But we had a discussion with Professor Yaznik in 2 days back in one of the meeting. It was a public awareness meeting on this, and the David's hypothesis has also been Barker's hypothesis also been discussed, and also we have discussions on some important point. So what we have come out is that we should try to achieve euglycemia much before, because even the quality of ova is also important. Because if you have a good quality environment and ova at the time of conception, that will also have its impact on the fetal outcome and fetal environment. And that is why we say HbA1c target should be less than 6 or 6.5, despite even fasting postprandial normal. So it is worth keep waiting for.
Sir, the next question, how frequently should you test HbA1c in these patients? Let us be very practical, because next question I'll put up to Dr. Hema. How many of your patients really want to switch over to insulin before conception when they are on metformin? So Dr. Sunil sir, how frequently should you do HbA1c in these patients where you want to optimize the result of blood sugars?
I feel after pregnancy, every 1
month. No, not
month
before, sir.
This patient,
2 to
3 months. every
So
2 to 3 months.
So this patient came to you in a pre-conception period for a counseling. So what should we advise her? Advise her HbA1c every 2 to 3 months.
Ideally to, but it will, see, when we talk about HbA1c, the first month is around 60 to 70% of the blood glucose, 2 months is around 80%, 3 months is almost 90%. So even if
So what about the sugar? So what about the sugars? How frequently should we advise sugars in these sugar testing?
Ideally, if she's on basal bolus therapy, daily 4 to 6 times per day.
No, sir, she's a patient, she's on metformin, she has come to you for counseling. What should we advise her? How frequently should you get your sugars done? How frequently should you get your HbA1c?
Madam, when we are switching our patient from metformin and insulin basal bolus therapy, ideally every day they should monitor blood glucose, and then those blood glucose which are getting early control, 120 already achieved post breakfast, you can start monitoring it little less.
Sir, I got your point. You said if you have to, you're shifting the patient on insulin, then this is the monitoring protocol. Dr. Hema, your question is, how many of your patients really, if you see an Indian scenario, how many of your patients?
Madam,
really
100%. Let us not
how many
get
of your
diverted.
patients?
100%.
Yeah.
They should go
How
on
many of?
insulin.
So let us have Dr. Hema's opinion also. How many of your patients really switch over to insulin?
Okay, it's just Preeti. I would also request you. This is crosstalk. So let's go back to the first slide because there are some few important points which I want to tell my colleagues here. The case one, just because see, she's already 36 years old. So with the diagnosis of PCO on the scan, they have gone around to so many OBGYNs for 4-5 years, chakkar marte, but we are losing the opportunity to test her glucose tolerance at that point in time and institute early lifestyle management and not see to it that her BMI is 30. Hypertensive is there's lots to do. So when Dr. Usha Sharma, and Pratima Mittal, the importance of history taking, no matter whatever the health she's come for, but you need to put these things in order because in her journey into her marriage and her reproductive, someday or the other, if she wants to conceive, then you have lost the opportunity if you've not done these things before. That's point number one. Second thing is with base, likely that many of them would be on metformin already, which the literature has also shown. Even if she conceives for the first 3 months, she can't continue to take metformin. So we are not debating about what she should be taking, but we are debating about the target she should achieve. You know, about you have only told about the hypertension, but you have not given us what is the HbA1c and fasting postgraduate. The targets are met already with the metformin that she's already. This is crosstalk. So we talked to our diabetologist and checked with him that first 3 months, hey, if the lifestyle modifications are getting her well under control.
Please mute rest of the participants. Please mute your mic. Yeah.
So why rush and do anything about it? Because always there is a possibility, it may just be borderline. With the nobody has ever told her about diet and exercises. So we get into control. Then she
please mute participants. Please mute yourself. Just we'll have 10 minutes more because we are already late.
Yeah.
Let us
so
have
there
some
are a lot
input.
of things. And then the question, Preeti, about if I jump to the insulin instruction, and I know that even with metformin is allowed for the first 3 months, but I'm not giving her the option, I'm straight away putting her on insulin, she will change her consultant. 90% of the times
So
this
is I wanted to point out because it is very important the patient is not willing to take insulin. Ideally, yes, we have to shift them to insulin, but if they are not ready to take the insulin, then definitely the point of control is you have to achieve the target.
Madam, see, that's what we discussed, that if someone doesn't want to take insulin on her own risk, the first choice is insulin along with metformin. If she achieved without insulin, fasting 90 and postprandial 120, not 140 is written there, it's 122 hours. If she achieves these targets along with HbA1c and doesn't want to take insulin, metformin can be continued, which we don't deny, but we have to mention it. But insulin.
Okay, so we got the point. Better to shift on insulin. If she doesn't want to take insulin, definitely we can achieve the glycemic controls on metformin. Sir, any additional test that you want to do? Any addition? Because she's type 2 diabetic, she's hypertensive, she's obese.
We have to get retina evaluation done. We have to do for kidney profile. We have to get for thyroid. We have to get for other micro and macroangiopathy, coronary artery disease. She's 36. So everything has to be mentioned, has to be.
I ask one question.
Yes, sir.
Dr. Pai.
Yes, sir.
Sorry. But I wanted to say that majority of the patients we do PCOD treatment, these patients are having, we put them on metformin and they conceive, and then we continue them on metformin for 3 months because we are worried that they'll miscarry, etc. Now, is it correct to continue them on metformin?
Sir, coming to that point, sir. Next slide. Next slide. We are coming to that point, sir. So, Dr. Sunil, sir, you just rightly pointed out we need to investigate them for retinopathies, renal dysfunctions, and of course the cardiac, because they have high risk of developing cardiovascular risk. So, especially the elderly patients, obese patients with cigarette smoking and dyslipidemias and hypertension, they have high risk. We have to go ahead with the echo and EKG and get the physician's opinion. Now, sir, any contraindications, like any particular, the patient is diabetic, any specific contraindications that
I'll be very brief. Proliferative diabetic retinopathy, autonomic osteoporosis, poor ejection fraction, recent coronary artery syndrome or ACS, severe uncontrolled hypertension, severe brittle diabetes, which is not getting controlled and achieving good. These are the absolute contraindication, first 4, and then the relative contraindication failed to achieving good control.
So anything related to HbA1c, if the targets are something more than 10, you should not allow the pregnancy to the patient to conceive.
Try to achieve, because you have insulin with you, you can reduce blood glucose from even HbA1c of 22, you can bring to 6, not an issue.
Okay, sir. So next question what Dr. Rishikesh Pai just now asked. Dr. Sunil, sir, again, because we need to emphasize on this point, you have clearly mentioned in your talk, metformin in first trimester, what Dr. Hema said, you can continue with metformin if patient is not willing for to take insulin. Even the ADA guidelines, sir, because this is what GOI guide. So I'll come to your this thing consensus. GOI guidelines that metformin should be added only after, and we are lucky that Dr. Vinita Das madam is here because she was a part of making, and even Dr. Hema Divakar was there as the part of making of these guidelines. GOI guidelines clearly mention that you should use metformin only after 20 weeks of gestation. Before that, as Dr. Sunil said, insulin is the first drug of choice. On the contrary, what Dr. Rishikesh Pai just now asked, if a patient is on metformin and she is taking is a PCO and she's taking metformin, this can be continued for 3 months. So there are 2 different guidelines. One is saying that metformin can be continued for 3 months, and the second guideline, GOI guidelines, say that metformin should be added only after 20 weeks.
Preeti, before Sunil responds, can I just make a comment also in continuation with Dr. Rishikesh Pai's?
I want the comments. I want the comments from both Dr. Sunil and Dr. Hema both.
Yeah, but I want to go first because see, the main thing, Preeti, is we keep our eyes very strongly on the target values to be met. If the fasting is so and so, and if the postprandial is whatever Dr. Sunil has defined, and she's in the pre-pregnancy state, and she's a PCO, and her targets are met with lifestyle and diet and exercise alone, we are fine with that. And all the things are in range. If not, for PCO, she's given metformin. With that also, the sugars are in the target range. Then also we are fine with that. What the government of India has said is, PCO patients, or for any other reason you have given her metformin and she embarks on a pregnancy, for the first 3 months, it's a given. It's a recommended practice that we do continue till 12 weeks because all the fertility specialists also guide us to continue till 12 because of the very reasons that Rishikesh Pai mentioned. Between 12 and 20, there is no data to reaffirm the safety of metformin in case as how the pregnancy advances. The sugar levels rise, the targets are not met, and she is on diet and exercise anyway, but you're not allowed to continue the metformin for meeting your targets between 12 and 20 weeks. You have to jump to the insulin. But if the first trimester reading is all right, and after 20 weeks her sugars rise, you are still allowed diet, exercise, metformin as the first bracket. If it's not under control, then we add insulin because millions of patients just moving on to it. So 12 to 20 is the gray zone, Preeti. The first trimester and 20 weeks later, that is fine. Vinita ji will also agree that we struggle to find some data between 12 to 20 weeks. We don't have the data on the table. But as OB-GYNs, we know that the first 3 months, it's a very common norm in millions of PCOS patients where metformin has been given and proven safety is there. And if the sugars are normal, might as well continue metformin for the first 3 months, 12 to 20, keep track of her sugars. If they are not normal, you need to add insulin. You can't use metformin in that window. That is what.
Sunil sir, your last comment. Your first drug of choice is always insulin. But
Madam, please, don't take it otherwise. Yes, we are going in a wrong direction. PCO, there is no question, there is no doubt, there is no debate. PCO without diabetes PCO, metformin 12 weeks.
So please mute participants. Please mute yourself.
I feel everything is very, very clean and simple to understand. If you have PCO with diabetes, without diabetes, continue for 12 weeks, no doubt, no debate. If you have a type 2 diabetes without PCO, without obesity, without insulin resistance, I feel prefer insulin. If required, patient not willing, start metformin, see the relative contraindication, go ahead with the metformin also, but write it down in the piece of paper. Now you have MITI trial, which has been even, madam, now Hema madam, MITI trial has used this metformin even from the 12 to 20 weeks. They continue pre-gestation, pre-pregnancy and continue till delivery metformin. So you have safety data available. The only thing is small for gestational age babies.
Okay,
which again will be a question mark in future. So there should not be any confusion for all delegates. Metformin is a safe drug we have available for GDM after 20 weeks, for PCO, obese, type 2 diabetes, even before conception, at conception on first trimester, 12 to 20 weeks, they can continue along with insulin, but PCO, they have to withdraw it. There is no data available in favor of metformin after 12 weeks if you have PCO.
Okay, thank you so much, sir, for bringing that out. It's very important because most of us are using metformin, but I'm not going to, which are the cutoffs for blood sugar where you should use insulin and when you can use metformin. Quickly going on to the second case, perhaps we'll take this as a last case because we don't have much time to discuss more. Because this is very relevant because this is concerned to the testing protocol. So this is Mrs. X, 32 years, BMI of 29, 1+2. That means first was IUD and she had 2 first trimester losses and she suddenly conceives before a proper evaluation could be done. There is no significant history that can correlate with the sudden IUD or losses. She's apprehensive about her present pregnancy because she had 3 pregnancy losses previously, and she has a family history of diabetes as well. She reports at 8 weeks of gestation. Dr. Hema, is still in this case, single step test justified, or should we go ahead with what recommendations are with 3R GTT? Because we are propagating single step test for all the patients, universal screening. So we'll like to have the opinion of Dr. Hema and then Dr. Sunil sir. Which test for hyperglycemia?
Preeti, the choice you're giving me is anyhow to challenge with glucose. Okay, whether you challenge with a single step test or you challenge with the 3 readings of the blood sugars at fasting 0 and 1 hour 2 hours. That is the choice you're giving. So the concept is that if you challenge with glucose and if her body cannot handle it, she cannot handle it. So whether you do a single step test or whether you do a complete GTT, you will land up with glucose intolerance findings. Okay. In this patient, I would be more apprehensive even to challenge her even for the first time, because she's obese, she's got her first the IUD and pre-pregnancy, the interval period, she should have been checked. That would have been the safest thing. Now she's already entered her pregnancy. In case she's a missed case of hyperglycemia, and I'm again putting salt on the wound and trying to challenge her with glucose, I'd be a little apprehensive. So if I can do a testing without challenging her for glucose and just checking her HbA1c fasting and post meal, and if that is sky high, then she's already an established case, which we have missed pre-pregnancy. So we'll start her on treatment immediately. If I'm in a rural area and I cannot do all of these, then at least I challenge her to prove or disprove whether her body is intolerant to glucose or not, and then move ahead from there.
That's
Thank you,
how I
Dr.
would.
Dr. Sunil, sir, your opinion on this case, sir?
And I fully agree about what Seema madam said. Let us, this is very clear guidelines.
Okay, okay, sir. Okay, sir. So can we move immediately to the last? I just want to go ahead with the last part because postpartum follow-up was not covered by. Yeah, Dr. Hema, can you just throw light on use of minocytols and DCI in these patients, because literature is somewhere dicey whether you should use these salts in the. And then Dr. Sunil, sir, your comments are very valuable for this.
Actually,
Because
some
Dr.
of
Hema,
these,
you have done a lot of studies on this on this molecule for the management of GDS. So your comments and then Dr. Sunil's comment.
Yeah, actually some non-pharmacological treatment in that group, what supplements you can give there, the vitamin D3, myoinositol, D-chiroinositol, this is a group which is emerging as maybe they will benefit. Out of the myo, D-chiroinositol and vitamin D3, if you compare, vitamin D3 is emerging as a frontline runner that if you do give it, then your prevalence of GDM itself is slashing by 48%, as shown by our study as well as Dr. Anup Mishra's study from AIMS. So we have to explore this further. But what I feel is, since more than 80% of our women are anyway vitamin D deficient, so to plug in the deficiency, if we embark on giving them vitamin D3, even for the purpose of combating the vitamin D3 deficiencies, and document our data of how our background GDM was before supplementing vitamin D3, and now we are giving them, and then lesser and lesser number of cases of GDM are unfolding, it'll be a good way forward. But myo-D-chiroinositol, the infertility practitioners have also used it in combinations for better quality of ova, as Sunilji said. So all those, but it has been done in smaller numbers. Ours is one of the largest studies with the myo-D-chiroinositol and vitamin D3. But unfortunately, both the arms of us, we compared vitamin D3, myo-D-chiroinositol in one arm and vitamin D3 alone in another arm. Both the groups showed a 48% reduction compared to the background prevalence. So there, the vitamin D is what we want to position it as a universal supplementation going forward, because it is useful for many other reasons. Yeah.
Dr. Sunil, sir, your comments on this molecule, because you are dealing with so many GDM in your practice. Are you using these molecules in your practice?
I mean, D we started recently, but I feel myoinositol I'm not using. But I fully agree with whatever maybe what Hema madam has said. I feel we'll go with that. We save
Okay,
time.
so this is the last case, and this is very important because we quite often see such cases. A 32-year-old para 2 plus 02 vaginal deliveries, one alive and healthy, and second is fresh stillbirth at town. She's diagnosed case of GDM detected at 24 weeks of gestation and was put on MNT exercise and tablet metformin, 500 milligram BD, and she has been well controlled with sugar, fasting, and PP. A little bit fluctuation of postprandial of 132. Sometimes it shows 120 or 126. She's now 32 weeks of gestation under regular follow, but she has moderate polyhydramnios. Now, patient and consultant both are worried because the last was a stillbirth. A polyhydramnios, almost sugar levels are normal. What next? Should we continue with this, or should we increase the dose of metformin? Why this? If the sugars are normal, why there is a this kind of obstetric complications occurring in this patient?
Preeti, one important information we want in this case is, has the serial growth monitoring scan been done, and what is the abdominal circumference?
Yes,
because that
is
one hallmark that we sometimes use to manipulate additional doses of insulin, even in 2 units or 4 units of insulin, for a tighter control of the absolute value of the sugars, because abdominal circumference is one of the earliest indication of the glucose intolerance disturbing the metabolic milieu of the baby.
So that is normal, Dr. Hema. It's just the polyhydramnios that the patient is having. Rest of the things are normal, absolutely normal. Dr. Sunil, sir, such kind of obstetric complications.
Yes, any patient coming with any complication, we should add, instead of increasing metformin, I'll prefer going for insulin and we'll be more closely. Maybe sometime we'll put her on CGM, and also there are some intermittently spikes coming up and giving rise to, because that has been uncontrolled area of glycemic variability. Usually it is glycemic variability which gives this.
One last thing, Preeti, I would like to add to what Sunilji is telling. You have given us only 2 values of sugar, okay?
Yeah.
If you're really going to add insulin, you will do a continuous monitoring for a while, and also, yeah, you need to be sure of really how your sugars are going, yeah?
Dr. Hema, many of the centers, they don't have the continuous monitoring of glucose levels. So
because hypoglycemia, Preeti, hypoglycemia is another threat. So we cannot just keep, adding insulin randomly with just based on one value, especially when it is already in the target range, and still you are trying to add something more to make it more stricter. Yeah.
So Dr. Sunil said if there is any obstetric complication, there may be some glycemic variability. So to check that better, we could use insulin. And Dr. Hema says, no, blood sugar is important. You may or may not. You need a
abdominal circumference is normal, na?
Yeah,
there's
normal,
no complication.
Normal. Polyhydramnios itself is one of the, I think, obstetric complications. Yeah.
And madam, 132 is also high actually.
Yeah.
It is less than 120. Then we have not monitored post breakfast, post lunch, post dinner.
Yes. We have to monitor and then decide. Yeah.
So I think any obstetric complication which is occurring is the indication that we should better shift these patients to insulin rather than putting them on oral hypoglycemics. Dr. Sunil sir, just last, I think we are already very late. Just last comment on postpartum follow-up.
Very small message what madam has commented, Hema madam, that sometimes small doses of insulin 2 to 3 units, 2 or 3 times a day will certainly help.
Yes. Yes, sir. Sunil sir, this is the last slide. Your last comment on the postpartum follow-up. How should we follow up these patients? And Dr. Hema, your comment on contraception. Which is the best contraception for these patients?
I feel 4 to 6 weeks after delivery, and then 6 months, and then once in a year is the protocol. 6 weeks, 6 months, and 6.
So should we follow with blood sugar fasting PP or HbA1c?
No, it should be ideally glucose tolerance test, or even even HbA1c should not be used for diagnosis in first 3 months. Very important message. People do use HbA1c for diagnosis in first 3 months, which is not valid in postpartum phase. After 3 months, you can certainly be.
Okay, that's why Preeti, I said tag. All of them are so active on social media, tagging people. So you tag these women for their life once every year. So they must absolutely come back, because there's a wonderful opportunity for us to contain the development of type 2 diabetes. And then also breastfeeding should be encouraged, because that also decreases the incidence of type 2 diabetes and decreases the incidence of obesity as well. And contraception, yes, the IUCDs are definitely not contraindicated, and we are strong promoters of PP-IUCD, because before she moves out, it is better to plug and play.
Hema, what about OCPs? OCPs?
OCPs, yeah, OCPs also can be used, but after 6 to 8 months, yes, they can be used, because low dose estrogens, for a short while, it should not make any difference. But there are other, the injectables with progesterones only, and then the IUCD containing progesterones, PP-IUCD, and condoms. These are also, but she should use a contraceptive, because spacing is really important.
Thank you so much, Dr. Sunil sir. Dr. Hema, I'm very sorry because we had less time, so we had to hurry up with the presentation. Thank you so much. And
wonderful, Preeti.
On behalf of Safe Motherhood Committee, we all pray for the good health, strength, and protection in future. And
Preeti,
wish you all a happy new year.
Something, it is very good. I would suggest that you, as a Safe Motherhood, how these pediatricians have a vaccination protocol.
Yes,
you
sir.
should have a pregnancy protocol.
Yes,
Which is you tell everyone what they should do in their practice, and it should be uniformly practiced.
Yes, sir.
And it should be not more than 3 pages.
Yes,
no, that's what we're doing in Manyata, Rishikesh. Pregnancy protocol, we are very, very strongly implementing that.
So that all the 39,000 people follow the same protocol. The biggest problem in India is fragmentation. Major fragmentation in everything that we do in our life.
So you, me, and Preeti are the forerunners in the Manyata flag, which we are flying high, which defines the antenatal protocols, which can be followed by everybody, every time, everywhere.
All the professors, please get together. Go to a hill station. All the professors in gynecology go to a hill station, all head of department, and get together and form a single everything single. Exams are different. Questions are different. Examination pattern is different. Teaching pattern is different. It's really pathetic. I think you all need to come together. And like see RCOG, what they are beautiful organization. Everything is standardized. Why can't all of you standardize everything?
Yes, sir.
When I was a resident doctor, I was not taught properly. Otherwise, I would have become a good obstetrician. This is not fair. All the residents should be taught. They are not taught properly. They are not given surgery properly. They are not
The
given.
dear professors, we promise to join you at the hill station for sure. We are coming.
It's your responsibility to do it.
Yes, Dr. Rishikesh has been focusing on this point
right
from the Manita program.
We will move on to the oration now.
Yeah, please. Thank you so much. Thank you, Dr.
Ma'am, can we move on to the oration now, please?
Yeah, please. Thank you so much. Thank you.
Namaste.
Thank you so much for a very, very, very wonderful discussion, ma'am. We don't want to leave it, but we have to move ahead.
Thank you, Sunil sir. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Thank you, Dr. Preeti. Thank you, Dr. Mala. Thank you, Dr. Hema. Thank you, Sunil sir. Thank you, Pai sir. Thanks, everyone.
Thank you, Dr. Preeti, for a wonderful session. We really enjoyed the session. Now good morning all to my seniors and teachers and all the delegates. I take privilege to invite the esteemed faculty to chair the prestigious oration, Professor Meena Mukherjee oration. I take privilege to invite the elegant, smart, sober Professor Anuradha Khanna ma'am. Ma'am is ex-HOD, Department of Ops, Gynae, BHU. She has been president of WOX, organized UPCOG in 2009, AICOG in 2012, and was chairperson of Unforgettable UPCOG 2019. She has lots of awards to her credit and more than 120 publications in national and international journals. We have with us handsome, charming person, Dr. Rishikesh Pai sir. He is the president-elect 2022-23, and he is medical director of Bloom IVF Group. Has a special interest in infertility, endoscopy, IVF, FIXI, egg freezing, and genetics. He is the teaching faculty at many institutes, including Eastern Virginia Medical School, USA. Has more than 30 awards to his credit, including Lifetime Achievement Award for Outstanding Research in Reproductive Health by ISSRF 2019. Please, everyone, keep yourself on mute. He is editor of more than 16 books, and we are sure to see memorable events in his tenure. We have with us Dr. Rukma Idnani ma'am, a well-accomplished, confident, and a dependable person. She has been HOD, Ops and Gynae in LLRM Medical College, principal at Saraswati Institute, and presently acting as advisory to many colleges. Ma'am has lots of awards to her credit, including President's Gold Medal for Best Girl School of MBBS, has been president of UPCOG, and has been a guide to lots of post-grad students. Professor Vinita Das ma'am, she is a very simple and a composed lady, and always remembered she's the best teacher I know. Has been ex-dean faculty KGMU and ex-HOD Department of Ops and Gynae KGMU Lucknow. She is the recipient of Havett Medal KGMC and several gold and silver medals. She has lots and lots of achievements, awards, and publications to her credit. Ma'am, even today, whenever I go for a cesarean, I always remember you. Dr. Vinita Mittal ma'am, senior gynecologist of Ghaziabad, is attached to Ghaziabad Society since its inception and has nurtured it till now. She is the pride of Ghaziabad and has organized a wonderful cultural evening for all of you yesterday. Now I take the privilege to invite Anuradha Khanna ma'am to shower her blessings upon us. Anuradha Khanna ma'am. Ma'am, you are on mute. Anuradha Khanna ma'am. Yeah. You unmute yourself, ma'am.
Good morning, everybody. I'm audible?
Yes, ma'am.
Okay, thank you. So it is my profound privilege that I'm a part of this prestigious UPCOG held at Ghaziabad. I'm thankful to the all society members and especially Dr. Alpana Kansal to you because you remain always in touch with me. And this conference is in 1986 established, and now we can see how much it is being flourished. Everyone wants to become the participant and become a part of UPCOG. My best wishes to all of you. Yesterday I couldn't attend because of some health problem with me, but this is wonderful going on, and my all best wishes to all of you. Oration, and I'm very happy to see how the people are growing, and now all the practitioners are also become the academician. That is the best part I like, and they are having publications also. So this is very good. They are doing the thing in such a beautiful way that I hope this is going to be benefit not only to us but to our patient, so that they will have a proper right treatment. And everyone is attending the conferences, though there are so many webinars. But still, I've seen all my Varanasi Obs and Gynecology Society, they are attending here and there. And thankful to you, to all of you, and from the Lord Shiva city, Varanasi, blessings to all of you. Har Har Mahadev.
Thank you so much, ma'am. Thank you so much. Ritu, can we have the previous 3 slides, please? Yes. I take privilege to invite Dr. Vinita Das ma'am to throw light on Dr. Meena Mukherjee's life history. Next slide, Ritu. Yeah, this one. To throw light on Dr. Meena Mukherjee's life history, as she has been very close to her. So, and during our postgraduate days, there was not a single day when Dr. Meena Mukherjee was not mentioned in the rounds. So over to you, Dr. Vinita Das ma'am.
Good morning, everyone. I'm really honored and thankful to the organizers for giving me this opportunity to talk about Dr. Meena Mukherjee. I'm really indebted to her. She has got a very special space in my life. She had been the godmother of my husband, my son, my nephew, and surgeon of my mother-in-law. She looked after very well throughout my pregnancy. So this is what I owe to her. Now coming to her tenure, she did actually her name is Shri Dr. Mrini Moi Mukherjee, but she was very popularly known as Professor Meena Mukherjee. She did her post-graduation in obstetrics and gynecology from King George's Medical College at that time. And not only in obstetrics and gynecology, she did triple MD. She did MD in medicine and MD in radiology. And after this, she joined as a faculty in King George's Medical College. She worked as an able clinician and the luminous academician, and she authored a book of obstetrics and gynecology in Hindi. Then she joined GSVM Medical College, Kanpur. And after that, she went to MLN Medical College, Allahabad, as the head of the Department of Obstetrics and Gynecology. Serving there for quite a long years of the time, she came back to King George's Medical College in 1981 as head of Department of Obstetrics and Gynecology. And then later on by Professor Chandravati, the oration was instituted in her name in UPCOG, which is what we are going to hear today through Dr. Anju Rastogi. So I'm against saying that my tribute to Professor Meena Mukherjee. Thank you so much, Alpana, for giving me this opportunity.
Thank you, ma'am. Thank you so much. Now, today's topic of oration is how to solve the enigmatic puzzle that is amenorrhea. And I take privilege to invite Dr. Rukma Indani, ma'am, to introduce Dr. Anju Rastogi, who has been her student. Dr. Rukma Indani, ma'am.
Morning, everybody. First of all, I must congratulate Ghaziabad Society for organizing such a wonderful webinar, and especially my thanks to Alpana Kansal. She was after me every day. Madam, please remember you have to be present on the oration of Dr. Meena Mukherjee. So I'm really thankful, Alpana. And it is a proud privilege for any teacher to introduce a student, Dr. Anju Rastogi. I'm really proud of her because I'm introducing her on this platform to speak on oration on the enigmatic puzzle of amenorrhea, which we think is a very important topic. And now I introduce Dr. Anju Rastogi. She's a director of Aman Test Tube Baby Center. She has been a graduate from the Maulana Azad Medical College 1984 batch, throughout a position holder, and she has done a post-graduation from LLR Medical College. I have guided her thesis. She has received many medals and academic achievements. She is practicing on infertility, on ultrasound, IUI, IVF for the last 27 years, and she has treated more than 10,000 couples successfully and delivered 2028 IVF baby so far. She has taken active participation on the various conferences, national and international conferences, and she has also received a Merit Ratna Award for contribution in the field of infertility. So I'm really proud of my dear Anju to introduce you on this webinar. So please, Anju, just start your. Thank you so much.
All the best, Anju.
Thank you so much, ma'am. Thank you, Dr. Nani, ma'am, for your kind words. And it is an honor for me to have you here for my introduction. A very good morning to all the dignitaries, chairpersons. Am I audible and clear?
Yes, you are audible, Dr. Anju. You are audible.
Okay. I'll just start sharing my screen.
Sure.
Screen, Gagan. A very good morning to all the dignitaries, chairpersons, seniors, friends and colleagues attending the webinar. I want to thank the organizers and have no words to express my gratitude to my honorable teachers, Dr. Sharma ma'am, Dr. Kirti ma'am, Dr. Nani ma'am, for giving me this opportunity to deliver this prestigious Dr. Meena Mukherjee oration. So, is my screen visible?
Yes.
On the right hand corner, there is an icon. You have to click it to make it full screen.
Yes, sir.
Like a cup.
Make it full screen.
Small little icon is there. See on the right hand side. Down. Near the magnification.
Yeah, I think it's okay now.
Yeah.
So the topic given to me is how to solve the enigmatic puzzle that is amenorrhea. Although it's a vast and a very complex topic, but I had tried to make it short and as simple as possible. So the title given to the topic is very appropriate as there are few problems in gynecology present a diagnostic challenge to we clinicians. And more important is that some of the diagnostic possibilities, if not diagnosed and treated early, can cause serious ill effects. Amenorrhea patients, when approached logically and systematically, diagnostic evaluation is not very difficult. So before coming to the definition of amenorrhea, we need to know that amenorrhea literally means absence of menses. So it's a symptom and not a disease. And in general, the first menses should occur after the initiation of pubertal growth. So in brief about pubertal growth, it starts with the acceleration of growth, that is growth spurt at the age of on an average 9 years of age, to be followed by breast growth, that is thelarchy, and then the appearance of pubic and axillary hair, that is adrenarchy, and to be last followed by menstruation. So in approximately about 20% of girls, adrenarchy may precede thelarchy by a short interval and should be kept in mind. And menarche can occur as early as 10 years of age and rarely occurs later than 16 years of age. So keeping these facts in mind, we come to the definition of amenorrhea. The primary amenorrhea is no menses by the age of 14 in the absence of growth or development of secondary sexual characters, while secondary amenorrhea and no menses by the age of 16 regardless of the presence of normal growth and development of secondary sexual characters, while secondary amenorrhea is women who have menstruated previously but menses do not occur for an interval of time equivalent to 3 previous cycles or total 6 months. So when coming to the classification of amenorrhea, we have physiological and pathological. Physiological is pre-puberty, pregnancy and lactation related and menopause, while pathological amenorrhea may be primary or secondary. So before going on to evaluation of amenorrhea, we must know what are the basic principles involved in the menstrual function. At least 5 basic factors are involved in the onset and continuation of normal menstrual function, that is normal female chromosomal pattern, that is 46XX, coordinated hypothalamo-pituitary ovarian axis, that is so-called HPO axis, is very important. Then a uterus with a functional endometrium, presence and patency of the outflow tract, and active support of the thyroid and adrenal glands. So, accordingly, the many causes of amenorrhea can be categorized according to the level of disturbance, that is disorders of the genital outflow tract and uterus, disorders of the ovary, disorders of the pituitary, and disorders of hypothalamus and central nervous system. So amenorrhea can result from congenital or acquired disease at any level described and can involve more than one mechanism in some conditions. So this is how this flow chart shows us that environmental factor followed by CNS, then hypothalamus, anterior pituitary, ovary, and uterus are involved in having normal menses. So now coming in evaluation of amenorrhea. The evaluation of amenorrhea begins with careful medical history and physical examination, which provide valuable diagnostic clues. History and examination can exclude certain possibilities and also help us ordering investigations for a final diagnosis. As a gynec, most of us are doing an ultrasound in our clinic. So an ultrasound should also be performed in these cases, and we must exclude pregnancy and cryptomenorrhea at the outset of the evaluation of these patients with primary amenorrhea. So coming to the medical history, I will emphasize few of the important points here. Primary amenorrhea speaks for itself. Cyclical pelvic or lower abdominal pain can be caused by developmental abnormalities like imperforate hymen, transverse vaginal septum, or cervical atresia in obstructed menstrual flow, that is cryptomenorrhea. Onset of amenorrhea following curettage or other uterine surgery suggests the possibility of damage to endometrium. Women with PCOS present with infrequent irregular menses dating from menarche or early adulthood with gradually progressive hirsutism. Women with hypothalamic amenorrhea, onset relates to the events resulting in severe nutritional, physical, or emotional stress. Women with hyperprolactinemia or premature ovarian failure notice a gradual increase in intermenstrual period followed by amenorrhea, which may be accompanied by increased prolactin, hyperprolactinemia, and hot flushes in premature ovarian failure. Continuing with the history, the past medical history is also important. General health and lifestyle can identify a severe or a chronic illness such as diabetes, renal failure, inflammatory bowel disease, previous head trauma, psychological or physical stress. Specific history relating to weight loss or weight gain and frequency and intensity of exercise is highly relevant. Headaches, surgery, vomiting, behavioral changes, or visual symptoms may suggest a CNS disorder. Progressive hirsutism or viralization is an indication of hyperandrogenism. Symptoms of galacturia must be asked for. History relating to the time and duration of treatment with oral contraceptive pills, dipomedroxyprogesterone acetate, GnRH agonist, and medicines which phenothiazines, amphetamines, benzodiazepines, antidepressants, and dopamine antagonists, which can provide important diagnostic clue to the patient. So from the history, we can see that detailed history can always give us very important clues to the diagnosis. Then after history, we come to the physical examination of the patient. The overall body habitus, height, weight, and BM are important, as a short stature less than 60 inches and sexual infantilism suggests gonadal dysgenesis. Low body weight is frequently associated with hypothalamic amenorrhea resulting from poor nutrition or physical or mental stress. Obesity or increased waist-hip ratio are associated with PCOS. We must look for the signs of hypo or hyperthyroidism, that is skin texture, pulse rate, exophthalmos or tremors of the hand. Presence of goiter or thyroid nodule give important indication of thyroid disorder. Presence of acanthosis nigricans suggests insulin resistance or possibility of diabetes. Acne and hirsutism are indication of hyperandrogenism. Signs of viralization must be looked for. Careful examination of the external genitalia is very important. Examination of breast is very important. Why? Because this is an indication of estrogen production in the body, and we must look for galactaria at this point of examination. We must do abdominal examination to rule out masses resulted from hematometra or ovarian neoplasm. Careful examination of the external genitalia and lower genital tract is important. Presence of pubic hair growth reflects the androgen exposure. Must check for appropriate tenor stages of breast and pubic hair. Whenever feasible, speculum examination should be performed as patent vagina and normal cervix excludes Mullerian agenesis and vaginal agenesis at this point of examination. In girls with primary amenorrhea having an absent or infantile vaginal orifice, rectal examination should be done to detect any distended hematocolpos. So we can see that after a proper history and physical examination, we can make important clues to the diagnosis. So now we come to the further evaluation of our patient at various levels. And we start from the lowest level, that is evaluation of the genital outflow tract and uterus. In those with primary or secondary amenorrhea having a patent vagina and vaginal visible cervix, chances of genital outflow tract abnormality is very small. Other only possibilities that can be considered are cervical stenosis or intrauterine adhesions, which may result from surgical trauma or infection. The patients presenting with absence of uterus may have two options, that is Mullerian agenesis or androgen insensitivity syndrome, which in this flow chart we can see that can be differentiated on the basis of presence of normal pubic hair in Mullerian agenesis, whereas scanty or absent pubic hair in androgen insensitivity syndrome. So after evaluation of the outflow tract, we come to the next level, that is evaluation of the ovarian function. After ruling out outflow tract abnormalities, attention is now focused on the next level of reproductive system, that is ovary. Abnormalities of ovarian function are the most common overall cause of amenorrhea and include a wide variety of disorders resulting from simple chronic anovulation to complete ovarian failure. So the assessment of ovarian function is done by measuring serum estradiol, endometrial thickness on ultrasound, progestin challenge test, and serum FSH measurement. Random serum estradiol concentration greater than 40 picogram per ml suggests the presence of functional ovarian follicles. Endometrial thickness reflects the level of estrogen production, and measurement of serum FSH concentration is an indirect measurement of ovarian function. A low or normal FSH indicate the presence of functional ovarian follicle and is seen in chronic anovulatory patients like PCOS, pituitary diseases, hypothalamic dysfunction, whereas a high serum FSH is a reliable indication of ovarian follicular depletion or ovarian failure. So a value of serum FSH more than 20 international unit per liter are clear indication of ovarian failure. So coming to the common causes of chronic anovulation, these patients are associated with normal estrogen and FSH levels, and the most common cause is PCOS, followed by thyroid disorders, prolactin disorders, obesity, and stress and exercise. Anovulation is due to dysfunctional HPO excess in all these conditions, and measurement of TSH, prolactin, estradiol, and FSH give us the final diagnosis and the treatment to be followed. Coming to hyperprolactinemia, which is among the common causes of secondary amenorrhea, which it may also result in delayed puberty and primary amenorrhea also at times. Random measurement of prolactin less than 20 nanogram per ml rule out hyperprolactinemia, and further evaluation with imaging, preferably MRI, is indicated in patients with prolactin more than 100 nanogram per ml to exclude pituitary tumors and hypothalamic mass lesions. So we have two categories of patient for ovarian dysfunction. One is ovarian failure. So how to evaluate the patients with ovarian failure? These patients have low estradiol levels and consistently high FSH level. All patients with 30 years of age with ovarian failure must have a karyotype to see chromosomal abnormalities, which may be numerical or structural abnormalities or mosaicism. An important point is that women with Y chromosome gonadectomy is indicated due to high risk of malignancy due to occult malignancy in occult or hidden testicular elements. In women with more than 30 years of age with ovarian failure can be regarded as premature menopause. Whenever we talk about premature menopause, we have to keep three things in mind. One is chromosomal abnormalities. Second is fragile X premutations. And the third is autoimmune diseases. Fragile X syndrome is the most common inherited cause of mental retardation and autism. And women with premature ovarian failure have 1 to 7% chance of this premutation. And the important thing is that they have a high risk of children with fragile X syndrome. When we talk about premature ovarian failure, autoimmune screening becomes very important because Addison's disease, that is autoimmune adrenocortical insufficiency, has the strongest association with premature ovarian failure. Presence of anti-adrenal antibodies most easily demonstrated against 21 hydroxylase enzyme, that is CYP21, strongly suggests autoimmune uveitis as the cause of premature ovarian failure. Antithyroid antibodies should also be measured in women with premature ovarian failure, which will identify the women at risk of developing autoimmune thyroid disorders. So the patient with premature ovarian failure, we have three important diagnostic tests. One is karyotyping to look for FMR1 premutations and anti-adrenal antibodies, that is anti-CYP21, to make a final diagnosis. After ovaries, we come to evaluation of the pituitary function, which is diagnosed with presence of low estrogen levels, which should cause a compensatory increase in FSH release. But due to pituitary dysfunction, this increase in FSH does not occur. So this indicates that central feedback mechanism is in HPO axis is not working. Most women with hypogonadotrophic hypogonadism have normal FSH and LH concentrations, and extremely low levels are seen only in patients with large tumors or in patients with anorexia nervosa. Coming to imaging as a part of investigation, when there is no clear explanation for hypogonadotrophic hypogonadism, for example, significant physical, emotional, or nutritional stress, or for hyperprolactinemia, further evaluation with imaging is indicated to exclude tumors and to differentiate between pituitary and hypothalamic causes of amenorrhea. And the method of choice is MRI with contrast. After pituitary, we move on to evaluation of hypothalamic dysfunction. So when imaging reveals no mass lesion and there is no reason to suspect other specific pituitary pathology, the diagnosis is functional hypothalamic amenorrhea. And there is suppressed abnormal pattern of pulsatile hypothalamic GnRH secretion in these cases, leading to absent follicular development and low levels of serum estradiol. In most cases, the probable cause of amenorrhea can be identified as extreme emotional stress, acute weight loss, chronic malnutrition, or strenuous physical exercise in hypothalamic dysfunction. So coming to the cases who are associated, amenorrhea is associated with signs of androgen excess. Here, the measurement of testosterone, DHEAS, and FSH help us defining the cases where the testosterone is more than 200 nanogram per ml, ovarian or adrenal tumors are suspected. DHEAS more than 700, adrenal hyperfunction is suspected. While DHS in the intermediate range of 500 to 700, we have a suspicion of late congenital adrenal hyperplasia, where measurement of serum 17-hydroxyprogesterone level help us making the diagnosis. Patients of PCOS have very lower or no elevation of androgens in spite of the presence of signs of androgen excess. So now coming to the etiology of the amenorrhea. The primary amenorrhea is most common cause is ovarian failure in about 36% cases, hypogonadotrophic hypogonadism in 34% cases, to be followed by PCOS, and then congenital lesions other than ovarian dysgenesis in about 4% cases, whereas the secondary amenorrhea is most commonly associated with PCOS, followed by premature ovarian failure, weight-related amenorrhea, and then hyperprolactinemia. So now we come, after discussing all the history and physical examination and investigation, we come to some specific causes of amenorrhea. So starting again with the lower level, the disorders of genital outflow tract and uterus. And here comes the Mullerian agenesis, that is Mayer-Rokitansky-Kaiser-Kosser syndrome, is among the common causes of primary amenorrhea in this category. Patients have normal symmetrical breast and pubic hair development. There is no visible vagina. There are no symptoms of cryptomenorrhea because the rudimentary uteri contain no functional endometrium, and it is important to look for urological abnormalities and skeletal malformations in the cases of MRKH syndrome patients. Coming to another important cause is androgen insensitivity syndrome, which is also known as AIS. This is the third most common cause of primary amenorrhea after gonadal dysgenesis and Mullerian agenesis. The gonadal sex here is XY, that is male, while the phenotype is female. In these patients, testes are functioning normally and produce both testosterone and anti-Mullerian hormone, but end organ insensitivity to androgen leads to development of female external genitalia because of the absent androgen action. Breast development occur due to peripheral conversion of testosterone into estrogen unopposed by the action of androgens. Cervix and uterus are absent due to the action of anti-Mullerian hormone, and vagina is short and ends blindly. One important point to emphasize here is the serum testosterone in these patients is well above the female range and more often in the male range or above the male range also. Risk of developing malignancy in cryptorchid testes has to be kept in mind. So then coming to gonadal dysgenesis, which is the most common cause of primary amenorrhea, that is in about 30 to 40% cases, which is caused by structural or numerical sex chromosomal abnormalities or some common genetic mutation. But important thing to be kept in mind is but approximately 25% of patients with gonadal dysgenesis may have normal 46XX karyotype and may have some subtle genetic abnormalities which cannot be detected most of the times. By far, the most common cause of gonadal dysgenesis is Turner syndrome, which may be associated with classical 45X karyotype or with mosaicism forms. If these Turner syndrome patients are not recognized by their poor growth during childhood, patient with Turner syndrome present near the time of puberty with primary amenorrhea and absent secondary sexual characters. We come to another important presentation, that is Sware syndrome, which is another cause of gonadal dysgenesis. But we do get to see these cases in our clinics. In last 6 months, I have seen 2 cases of Sware syndrome. So these are not all that uncommon also. Here, the gonads are dysgenetic and streak form and therefore produce neither AMH nor androgen. None of these androgens or anti-Mullerian hormones are secreted in Sware syndrome, and they generally present after the time of expected puberty with delayed sexual maturation and primary amenorrhea. Presence of pubic hair reflects with normal adrenarche. Gonadectomy is indicated in these cases due to the fear of malignant transformation. So if we compare Sware syndrome with androgen insensitivity syndrome as both present with primary amenorrhea and male karyotype, that is 46XX, androgen insensitivity syndrome, cervix, uterus and vagina are absent while they are well developed in Sware. Pubic hair is absent in AIS while they are present in Sware syndrome. And another important point is the measurement of testosterone, which is well within the female range in Sware syndrome, while they are in the higher or male range in androgen insensitivity syndrome. As we discussed earlier, that sometimes patients presenting with gonadal dysgenesis may have normal karyotype, that is 46XX. After discussing ovarian failure, we come to premature ovarian failure, which is defined as hypergonadotrophic hypogonadism and amenorrhea arising before the age of 40. Important causes of premature ovarian failure include numerical or structural chromosomal abnormalities, fragile X premutations, autoimmune disorders, radiation therapy, chemotherapy, or history of surgery in ovaries. All the patients with premature ovarian failure must be screened for immunophilitis by measuring antibodies against 21 hydroxylase enzyme. So asymptomatical adrenal insufficiency has to be kept in mind patients presenting with premature ovarian failure. Another important entity is functional ovarian failure, which is also known as resistant ovary syndrome or Savage syndrome, where ovaries do not respond to gonadotropin in spite of good number of follicles seen in the ovary on ultrasound. So after ovary, then we go to higher level, that is disorders of the anterior pituitary. Benign adenomas of pituitary are the most common cause of pituitary disorders. They may be functional prolactin secreting adenomas or non-functional adenomas and managed according to their size and symptoms. Sheehan syndrome, when we talk of pituitary causes, we have to talk about Sheehan syndrome, which is caused by acute infarction and ischemic necrosis of the pituitary gland resulting from postpartum hemorrhage, and is a common cause of hypopituitarism in underdeveloped or developing countries. These patients are diagnosed, the diagnosis is made very late. So we have to be conscious of the entity called Sheehan syndrome. Then from pituitary, we move on to another high level, that is hypothalamic amenorrhea, which is the diagnosis of exclusion, have low or normal FSH level in spite of low level of estradiol production, absence of any cellular mass in MRI, or frequently associated with extreme physical, nutritional, or emotional stress are diagnosed with hypothalamic amenorrhea. When we talk of hypothalamic amenorrhea, we have to talk about Kallmann syndrome, which is caused by congenital GnRH deficiency associated with anosmia or hyposmia. It is an X-linked disorder and present at puberty with delayed growth and sexual development. So another, in brief about hypogonadotrophic hypogonadism, patients present with normal height, normal external and internal genitalia, although infantile, low FSH and LH. MRI is done to rule out intracranial pathology. 30 to 40% patient may have anosmia and diagnosed as Kallmann syndrome. Sometimes constitutional delay is also an important diagnosis, which is to be kept in mind because constitutional delay is also a common cause of primary amenorrhea, where the girls are under stature and have delayed bone age, which is measured by doing X-ray wrist joint. They have a positive family history and diagnosis is made by exclusion and follow-up. Prognosis is very good. Usually no drug therapy is required and reassurance is usually sufficient to treat these girls. Coming to the weight-related amenorrhea, we know that anorexia nervosa and bulimia nervosa associated with eating disorders are well-known causes of primary as well as secondary amenorrhea. Exercise-associated amenorrhea is common in women who participate in sports, for example, competitive athletes and in ballet dancers, and it's a hypothalamic disorder caused by abnormal GnRH pulsatility resulting in decreased level of gonadotrophins, that is FSH and LH. So, coming to the general principles of management of amenorrhea is that attempts to restore ovulatory function in an ovulatory patient, and when this is not possible, as in gonadal dysgenesis or premature ovarian failure, HRT in the form of estrogen and progesterone is given to hypoestrogenic amenorrheic women to prevent osteoporosis and atherogenosis. Women who are normal estrogenic amenorrheic women, periodic progesterone should be given to avoid endometrial cancer. If Y chromosome is present on karyotyping, gonadectomy is indicated in these cases. So the treatment depends on the underlying cause, the need for regular periods, trying to conceive, and need for the contraception. So to summarize, we can say that although the workup of amenorrhea may seem to be complex, but carefully conducted physical examination with history, ultrasound, bioassay of hormones help us making a diagnosis quickly. Frequent re-evaluation and reassurance of the patient is important part of the evaluation of these patients. So I end my subject here and again want to thank the organizers UPCOG 2020 for giving me this prestigious oration. As it is my first oration, I hope I have done justice to the subject. Thank you everyone. Thank you so much. I hope I finished in time.
Yeah, Dr. Anju. Thank you so much for the beautiful oration. I now invite Dr. Rishikesh Pai, sir, to say a few words of wisdom, sir. Dr. Pai, sir.
बोलिए नहीं बुझ नहीं पाई
नहीं अभी दिख तो रहे थे डॉक्टर पाई.
He's there, ma'am. He's there.
हाँ, he's there.
Hello.
Yes.
You are audible, sir.
Oh yeah, hello. Fantastic lecture by Dr. Anju Rastogi. We really learned a lot from her, and it's a like an honor for me with the doyen of UP, Dr. Usha Sharma is there, and and all my friends and my colleague Dr. Anuradha Khanna. I still remember the AICOG how she had made it.
Yes.
Rukma Indani, Dr. Vinita Das is our professor, one of the great professors of India. And Dr. Vinita Mittal, all of my co-chairs, and I'm really privileged that I have been co-chairing this session with Dr. Mrunmayee Mukherjee oration. I came to know about how great she was as well. So it gives you a lot of information of people who have been such great people in their own areas. So thanks a lot, and it's been a very great lecture by Dr. Rastogi. Thank you.
Thank you, sir. Thank you so much.
Thank you so much, sir.
And I invite Dr. Vinita Mittal, ma'am. Please say a vote of thanks to all. Ma'am, you are on mute. Unmute yourself, ma'am.
I'm really honored and privileged to be chairing the session with the stalwarts. Thank you, ma'am, Dr. Ushan, Dr. Indrani, Dr. Pai, and Dr. Vinita Das. And Dr. Anju, it was like an iceberg, but you've almost uncovered the 84% of the iceberg with your lecture.
Thank you so much, ma'am. Thank you.
Everyone, Dr. Kiran Pandey, namaskar, and Dr. I can see Dr. Usha Sharma तो हम लोगों की वो हैं. Thank you so much for being here. I thank everyone, all the chairpersons I've been co-chairing with, and the speaker, and Dr. Indrani Rukmi and Dr. Alpna Kansal and Dr. Archana Sharma for such a lovely oration. Thank you so much.
Thank you, ma'am. Thank you so much. Now we move on to oration, Dr. D. Kuti oration. And I invite Dr. Manisha Gupta, who is going to coordinate the oration. Dr. Manisha? Dr. Manisha?
Yeah, thank you, good afternoon, everybody. I, Dr. Manisha Gupta, on behalf of UPCOG 2020 in Ghaziabad, welcome you all to the prestigious Dr. D. Kuti oration. So it is my proud privilege to invite our chairpersons who are stars of galaxy of gynecologists and obstetricians, and really don't need any introduction, but still as a protocol, I'd like to introduce Dr. Manju Shukla. Please, can we have the next slide, please? Next slide. नहीं, इससे पहले वाली. Dr. Manju Shukla, who is a retired professor. Please, इससे पहले वाली. हाँ.
अरे मंजू की है.
KGMU Lucknow.
मंजू की slide है.
Sorry, ma'am.
मंजू की slide है. हाँ ठीक है. Go ahead.
हाँ जी. She was the past president UPCOG, APGL and LOGS, National Trainer Contraceptive Technology, and also Infection Prevention, the National Trainer Quality Assurance, and she has organized many conferences, national and international, presented papers, chaired many sessions, guided thesis of MD candidates, and has received Lifetime Achievement Awards from Muslim Educational Society, IMA, and is a Chief Editor General of UPCOG. Next slide. Now I would like to introduce Dr. Kiran Pandey, who really doesn't need any introduction. We all know. Please, next slide. She is the head of the department since 2004 in GSVM.
Before Manju ji.
Next slide.
Next slide, previous slide, previous.
इससे पहले वाली.
Yes, this one.
She's a governing ICOG Governing Council member 2021-22 and President Kanpur Menopause Society, and she has chaired many associations like IMA WDW Wing and also IMA President, and she has recently given oration, the prestigious Usha Saraya oration in Just Tumors International Conference at POGS, organized by POGS, and also Usha Saraya oration in AICOG 2020. Then she has organized many workshops, training programs, conferences, and seminars, both national and international, and has many publications and chapters. She has authored many chapters to her credit. And apart from the research in the field of cancer in collaboration with IIT Kanpur for the last 5 years, she has also organized many awareness camps for the prevention of cancers, and she is a recipient of many awards like Corona Warrior Award conferred by Mayor and various Society of Kanpur, received Mahashakti Samman Award on International Women's Day 2019, Certificate of Appreciation for Excellent Contribution in Family Welfare 2017 and 2018, President Appreciation Award from Adolescent Health Committee at AICOG, and
award. It's okay, Dr. Manisha. Please move ahead.
Next slide, please. इसके बाद now I'd like to introduce Dr. Bharti Maheshwari. She is professor and head Department of Obs and Gynae, Muzaffarnagar Medical College, and also a chairperson Foxy MTP Committee 2018-20. She has done fellowship in medical education by MCI and FIME, Governing Council member-elect ICOG, Joint Secretary UPCOG, Vice President Meerut Obs and Gynae Society, author and editor of many textbooks of Obs and Gynae, and she has many publications. She had chaired many sessions and has also held the chair of National Coordinator MTP Committee 2015-18, an executive member Endocrinology Committee, Public Awareness Committee, and Medical Education Committee. Next, please. Now I would like to introduce Dr. Tarini Taneja, who is Director, Taneja Test Tube Baby Center, Muzaffarnagar and Delhi. She is a chairperson-elect Delhi State SR and President-elect UP State OBGY and Society. Also is part Delhi chapter, and she has held many posts like President IMA Muzaffarnagar and OBGY Society. Then she is Vice Chairperson DMA Women's Wing Delhi, and she is a President NGO Manzil-e-Rahat with sole goal to prevent female feticide Muzaffarnagar. She has held many camps and many awareness camps to prevent female feticide and has been awarded by many awards for the same. She has many publications to her credit, and she has authored many chapters also. She has received various awards, out of which Wanda Foxian Award and Award for Family Planning Work by Government of Uttar Pradesh and many others. Next, please. Now I'd like to introduce Dr. Urmila Singh, who is Professor Unit Head, Department of Obs and Gynae, KGMU, Lucknow. She is the additional Proctor KGMU and Vice Dean Faculty of Nursing College of KGMU. She is member of governing body of Uttar Pradesh Medical Council and NMC. Her areas of interest are reproductive child health, gynae oncology, and operative endoscopy. She is recipient of many awards, out of which Doctor of Millennium Award 2000, then Dr. Manorma Diamond Jubilee Award 2011 and 2016 for contributing to the IMA. Then Vishish Chikitsa Seva Bhushan Samman in 2016 by Governor of UP, and then Mantri Chikitsa Vigyan Samman 2019. She was the organizing scientific chairperson of Foxy Justosis 2019 conferences, and similarly has organized many conferences. She has held many posts in logs and and Indian Cancer Society, and she has presented many papers in national and international conferences. Next, it is my proud privilege to introduce our own Dr. Shashi Arora. Next slide, please. Who is a graduate and postgraduate from KGMU, Lucknow. She has received training in laparoscopy, gynae, endoscopy from Germany, and advanced training of IVF under Dr. B.N. Chakravarti. She is HOD of Department of Obs and Gynae and IVF and Vice Chairman of Tertiary Care 310 bedded Yashoda Hospital at Ghaziabad. She has held many posts in our local gynae society, Ghaziabad Gynae Society. And apart from the holding many posts, she has done many awareness programs and held many antenatal camps in rural areas and remote villages, and has trained doctors from several parts of India. Thank you all. Now, I would like to invite Dr. Manju Shukla to enlighten us about life of Dr. Kutti. Dr. Manju Shukla, please.
Good morning, good afternoon, rather. We are very late in starting this oration. It is my proud privilege that I have to tell something about our teacher, whom we were so frightened and so this thing I can't tell you. She has done her graduation from South Medical College, and then she joined Provincial Medical Services. Then she went to UK and did her MRCOG. From there, she came to KGMC and joined as a reader in the Department of OBGY. And she was heading the department from 76 to 81. Then she handed over the charge to Dr. Meena Mukherjee. And she has keen interest in infertility. And every patient she used to think that if Dr. Kutti will see me, then I will become pregnant. तो डॉक्टर कुटी पूछती थी क्या मेरी उंगलियों में स्पर्म रहता है क्या जो ये सब प्रेग्नेंट हो जाता है खैर तो उनका वो बहुत नाम था and she was very disciplined. She used to come on rounds at 8:30 a.m. Before that, we used to be prepared for her rounds, and there was a line of patients whom she used to see in the morning in gynae department. She was a pious soul, and she was a devotee of Swami Shivanand. So after she took voluntary retirement from KGMC, she went to join the Shivanand Ashram in Rishikesh, where she used to see many patients in a charity hospital. Because in UP, Dr. Kutti was a big name. I'm so proud to introduce and to chair the oration of Dr. Kutti, my teacher. And she expired on 9th August 2000 in Rishikesh. Our Shraddhanjali to her, because chairing with me, many are her student Kiran, Urmila, Shashi, and
student.
बस बाकी तो so now I hand over the session to Kiran Pandey to introduce.
Thank you, ma'am. Now I would like to ask, please, Dr. Kiran Pandey. I request Dr. Kiran Pandey to say a few words. I know she has many memories of Dr. Kutty, which she would like to share. Please, ma'am.
Good afternoon, and many congratulations to organizers and chairpersons and secretaries, all both Archanas, both Alpanas, including Dr. Vinita. So, and I would like to pay my regards to respected Chief Patron Padam Shri Dr. Usha Sharma ji, our patrons Dr. Chandravati, Dr. Meera Agnihotri, advisors, and Foxy presidents. Thank you for giving me this opportunity to chair this prestigious Sureshan. As Manisha has said very rightly, before I come to my responsible duty of introducing Dr. Neena Gupta, I would like to just share a few words about her. It's my proud privilege also that I have also been, in 2012, I had delivered this Dr. Devki Kutty oration. And basically, as Manjuji was saying, we all have very emotional attachment to her. She was in true words of Manjuji, she was a very pious lady. She was my mentor, my chief guide, co-guide. And in fact, I would say that she has been my guide throughout the life. Whatever I am is because of him. Her principles we have been following, and I am very proud student of her. Many, just like Manjuji said, if just 1 minute, if you give me, I like to, there are not many memories, time will not permit, but I'll share one memory. There was a patient who was having post-cesarean intractable PPH repeatedly. We were doing each and every possible thing which was possible at that time. And she was a nulliparous patient. We could not do anything. And in the end, somehow my seniors, that time I was a junior resident, somehow I've heard my seniors saying that डॉक्टर कुट्टी को दिखा देते हैं, एक बार वो उनको इसको पेशेंट पे हाथ रख लेंगी तो ठीक हो जाएगा. It was so, मतलब for me at that time it was very, I couldn't understand all this. But actually what happened, to cut the story short, when Dr. Kutty came, she just blessed her, she sat with her, did not do anything, just keep on assuring, and asked us to stop all treatment, which was very, matlab, at that time, I couldn't understand why. But from next day onward, the patient did not bleed even a single spotting, and she went home as such perfect in health. I remember that day, and I remember her in so many incidences are there, but I'll cut it short. But I do just want to say that I have this honor and privilege, and I'm really emotional for it. Well, to introduce Dr. Neena Gupta is another very important privilege which has been given to me. She's professor in my department next to me. And whatever she's going to talk, the most important thing, she has been working with me in this COVID era as my right and left both ends. She has been working and taken charge of the COVID major responsibility. She has been taken along with me. So I'm really happy that she's going to talk about it now. She is, of course, done MBBS from KGMC, MS from SN Medical College, Serious Residency from Safdarganj College, and she is joined as a assistant professor and now professor in the GSBM Medical College. She is owner of President's Guide Award by Honorable President of India. She's master trainer of various programs. She has conducted public awareness program on many important issues like osteoporosis and PMD camp. She has achieved certificate of appreciation by IMA on International Women's Day. Got felicitation for eminent teacher by Professor Murli Manohar Joshi. Nodal Officer of Mahila Shakhtikaran Summit GSVM Medical College, the program which is being run by the state government Mission Shakti. More than 55 papers published, more than 35 papers presented, and she's chairman, panelist and speaker in various conferences, and she's president of Clinico-Pathological Committee. So besides that, I can again say she's a very talented academician, and I'm sure I wish you success today, that a very good oration she will be presenting you, in which she would be presenting all the work has been done in our department. So Dr. Manisha, I would hand over the mic to you for further proceedings.
Ma'am, I would now like to invite Dr. Neena Gupta to deliver her oration. Dr. Neena Gupta, please, ma'am.
Perfect.
Good afternoon, everyone. First of all, I want to deliver my heartfelt gratitude to UPCOG, who have given me lifetime opportunity for delivering such a prestigious oration on a very interesting topic. Indeed, this oration is actually our gratitude and to the divine D Kutti, ma'am. This oration is tribute to divine D Kutti, ma'am, who made a difference in lives of thousands of patients. Coming to my topic, delivering COVID care with safety of health workers, a challenging task. Coronavirus outbreak, really a nightmare for everyone. Sequence of events were very fast and more frightening. Right from its emergence around December 31, 2019, on 11th March, WHO declared COVID-19 a pandemic, including 114 countries, with global deaths due to COVID-19 over 1 lakh by the April 2020. India declared first diagnosed case on 30 January 2020. Till 30th November, worldwide, number of cases, COVID cases, more than 6.5 crore, and number of deaths more around 15 lakhs. In India, number of cases more than 94 lakhs and death over 1 lakh. And while in UP, number of cases more than 5 lakh with death around 7,829, while in our GSVM Medical College, number of cases 2,637 and number of death 612. While in our Department of Obs Gynae, COVID wing, number of cases were 407, while death in only 3 patients. So there was a hue and cry amongst the general population and doctor, because it was a newly emergent unknown disease, which is highly contagious with no adequate treatment available. So WHO took initiative to keep health workers safe, to keep their patients safe. WHO Director General said that no country, hospital or clinic can keep its patients safe unless it keeps its health workers safe. WHO Health Worker Safety Charter is a step towards ensuring that health workers have the honor and respect they deserve. The training is required for them, and the safe working condition is their right. So our primary aim is to treat our COVID patients and all our other patients, and to protect our corona warrior. It's not moving. Yes. 5 actions to protect health workers are: to improve their mental health, to protect them from physical and biological hazards, to advance national program for health worker safety, to connect health worker safety policies to existing patient safety policies, and to protect health worker from violence. Most important step was to appoint a responsible officer. At our GSVM Medical College, our ex-principal Dr. Aarti Lal Chandani, respectfully known as Iron Lady, and our own respected Dr. Kiran Pandey ma'am, HOD Obs Gynae, appointed nodal officer for COVID maternity. They appointed me as a COVID nodal officer, and we created a powerful team consisting of senior and junior faculty of our department. Starting from the whole department, measures were taken to decrease COVID-19 infection in healthcare workers. We divided the whole department into COVID wing and non-COVID wing. We made the SOPs for COVID wing. Initially, there was a lot of pressure from administration, especially from DM Kanpur. We discussed our problem also, and within 10 days of its official announcement, COVID wing was handed over to Gynae department by 11th May 2020 with fully equipped infrastructure facilities like triage area, holding area for COVID-19, positive cases and suspected cases, separate OT labor room for COVID and confirmed cases, donning and doffing room, with total capacity initial 20 bedded and later on 30 bedded. During initial outbreak, there was a sense of apprehension and anxiety among healthcare workers. So there was need for psychological counseling. And we arranged for a special calibration by psychiatrist of GSVM Medical College to cope up with this stressful crisis and to overcome our mental barrier. Psychological training held at Obstetric and Gynae Department, GSVM Medical College by consultant of psychiatry, Dr. Ganesh Shankar. Definitely this improved the mental health and psychological well-being of healthcare workers, but other things like appropriate and fair duration of deployment, working hours, rest break, and minimizing the administrative burden were other important things which we dealt very efficiently after delegating our administrative duties along with the proper duty roster, define and maintain appropriate safe staffing levels. So we posted sufficient number of paramedicals and doctors in each shift. Second important thing was education and training program for health workers at all levels. Extensive revision, reinforcement, and test training for proper use of PPE, infection prevention, and other topics was held in our department. This slide showing number of doctors and employees who were trained for primary and revision training, 132 doctors and 111 employees. And just before their COVID posting, test training was done where we used to see their efficiency, how efficiently they are doing donning and doffing and what mistake they are doing at that time. To correct that mistake and this revision and extensive training, there was a purpose that all the knowledge should imbibe at their spinal level. Skill taught were technique of donning, doffing, use of N95 mask, revision of hand washing methods, sanitization, proper body disposal guideline, biomedical waste management, etc. But only training was not sufficient. We also ensured the availability of PPE at all time as relevant to the roles and tasks performed in adequate quantity and appropriate fit and of acceptable quality to protect our health worker from physical and biological hazards. This slide showing different type of PPE, like medium kit is required for all OPD staff and advanced kit is for ICU and at the time of operation. But merely availability of kit is not sufficient. Separate room are recommended for donning and doffing. At our COVID wing, we are having donning and doffing room as per protocol. Apart from this, to decrease viral load, facility of shower each time after doffing is also available in our COVID wing. These things seems to be very basic and basic things, but to maintain these things in a government setup is a big deal. There should be provision of opening doors with feet or elbow without touching the handle. And at the time of construction of our COVID wing, we ensured the provision of door closer at donning and doffing room. In OT, only essential items to be kept inside the COVID OT cover all monitors, cables, anesthesia, workstation, machine, operation table, patient trolley with transparent plastic sheet, changed every time after case, use disposable equipment as far as possible. Minimum required personnel should be present inside the COVID OT, and we obeyed all the protocol. Other measures which we taken to decrease viral load were, we divided the COVID wing into administrative zone and main COVID zone. Administrative zone including duty room, doctor duty room and sister duty room, and main COVID zone was the area where actually the COVID patients were lying. And sealing of doors and window between the two areas by simple brown tape. This measures not only decrease the viral load, but also decrease the exposure time of healthcare worker to the COVID positive patients. Other measures which we followed were exhaust with flapper to reduce the viral load. Ideal is HEPA filter, but it was neither accessible nor feasible for us. Ideally in OT, there should be negative pressure in COVID. Normally in OT, there are positive pressure. So this negative pressure we achieved by the exhaust fan. The quantity should be of air which was thrown out by the exhaust should be greater than the supply of air quantity so that negative pressure is achieved. The pressure should be 2.5 Pascal and preferably 5 Pascal, and 12 air exchange cycle per hour is recommended. These things we could not measure, but we used to use this exhaust with flapper well advanced when the patient is shifted to the OT before starting our operation. Sanitization was done twice a day in COVID wing, and while sanitization, we ensured to protect our instrument and equipment because 75 alcohol is recommended for wiping off solid surface of the equipment, and they should be covered while doing sanitization. All floor, wall, OT table and stretcher to be cleaned with 1% sodium hypochlorite solution. So there is provision of separate labor room and OT for confirmed and suspected cases. And with so much of preparation at our COVID maternity wing, till 30th November, we did 166 cesarean and 80 normal delivery. Number of neonates tested positive of SARS-CoV-2 out of 246 delivered baby, only 9 neonates were COVID positive. The percentage was 3.65. All senior and junior doctors took active participation in treating COVID positive patients right from their admission, briefing, pre and post operative round, during cesarean and delivery, and after at the time of discharge, taking their feedback. Fortunately, we are having more than 400 positive feedback of COVID positive patients. Chemoprophylaxis guideline for COVID was also followed for healthcare workers. As per ICMR guideline, HCQs 400 mg twice a day was given on day 1, followed by 400 mg once weekly for 7 weeks. And ivermectin, as per UP government guideline, 12 mg on first day, repeat dose on 7th day and 30th day in a month. And if any healthcare worker comes with close contact of COVID positive patients with some breach in infection prevention practices, then ivermectin 12 mg OD for 3 days. This slide showing prophylaxis taken by healthcare worker at our COVID wing. 60% of doctors took the prophylaxis and 45.7% of paramedical workers took the prophylaxis. Some of them taken only HCQ prophylaxis, some of them taken only ivermectin prophylaxis, while other taken HCQ plus ivermectin prophylaxis. Most of the doctors, they took HCQ plus ivermectin prophylaxis, while most of the paramedical workers, they took only HCQ prophylaxis, which was basically provided by the government supply. Other measures taken were gargle, steam inhalation, and CADA. Electric kettle and steamer was provided to COVID wing. by us personally. It was not provided by the government. And we put these two things, steamer and electric kettle, at a designated place. And every time after doffing, healthcare worker used to do steam and do gargle and take steam within 5 to 10 minutes of doffing. Evidence-based benefit of steam inhalation says that steam inhalation reaches the back of the paranasal sinus, where actually COVID virus rests. And merely drinking hot water is not sufficient. At 50 degree Celsius, this virus becomes disassembled, that is paralyzed. At 60 degrees Celsius, this virus becomes so weak that any human immunity system can fight against it. At 70 degrees Celsius, this virus dies completely. Steam inhalation at temperature of 55 to 65 degrees Celsius might be beneficial in helping SARS-CoV-2 virus infection in the upper airway mucosa and possibly preventing further spread. This slide shows evidence-based benefit of gargling. In upper respiratory tract infection, gargling can reduce the viral load in the throat and oropharynx, although it cannot eradicate the virus. Throat gargling habit with saline might be suggested for high-risk population, quarantine people, and medical staff. Throat gargling and even steam inhalation are virtually a cost-free modality, might benefit the general population during current COVID-19 pandemic. Gargle and steam inhalation done by healthcare worker at our COVID wing was 100%. How could we say that this was 100%? Because for monitoring of compliance, we made COVID prevention group on WhatsApp, including all medical and paramedical workers on COVID duty. Each time after their shift, every doctor and paramedical staff gargle and does steam inhalation and send picture to COVID prevention group. This slide showing gargle and steam inhalation is done by every medical and paramedical worker each time after duty. Other things are proven benefit of Kada. Ministry of Ayush recommends to drink herbal tea, Kada, made of tulsi, dalchini, kali mirch, dry ginger, and munakka resin once or twice a day. At our COVID wing, many healthcare workers practice taking Kada at home, but standard ingredients were not present. Some of them taken Ayush Kada, others taken homemade and Giloy Kada. So comparable scientific data not available. This photo is showing our postgraduate residents are taking Giloy Kada at their hostel provided by their mess as ordered by me, as I am also working as a warden PG Girls Hostel. And in this COVID pandemic, I not only worked as a professor and administrator, but I tried my best to act like their guardian at their workplace and at their residence. 14% of COVID-19 cases reported in WHO are of healthcare worker. According to data provided by IMA on 1st October 2020, 515 doctors died after contracting COVID-19 while treating patients, but actual number could be much higher. This slide showing COVID positivity rate at our COVID wing in healthcare worker. In doctor, it was 0.23% per 100 duty days, and in paramedical workers, it was 0.45% per 100 duty days, which was very less and without any death in healthcare worker. This slide showing how we calculated the COVID duty days. Total 65 doctors participated in COVID duty, and their duty days per doctor was calculated, and it was multiplied by the number of doctors, and total number of duty days was 1,773. In the similar manner, we calculated the duty days of paramedical staff. Total 70 paramedical staff participated in COVID duty, and their duty days was 2,877. And this slide shows how we calculated the corona positivity rate in doctors, and cumulative infectivity rate was 0.23%. And we can see here that faculty, SR and JR3 who were actually involved in doing cesarean and doing delivery were not infected. Only 2 JR2 amongst 18 JR2, they were infected, and non-PGJR, only 2 non-PGJR who actually did not do any cesarean or delivery. They were involved in COVID testing, were infected. And overall cumulative infection rate in paramedical workers were 0.45% per 100 duty days. So we covered both psychological and physical aspect in treating our COVID patients and protecting our healthcare worker. Yoga and meditation was also done in COVID positive patient in COVID wing. So we have scientifically used various measures to decrease COVID infection in healthcare worker by decreasing viral load at workplace, by decreasing direct exposure time of healthcare worker with COVID positive patients, obeying standard protocol for PPE and infection prevention, chemoprophylaxis against corona, and judicious use of gargle and steam inhalation at workplace for deactivation of virus. When so much care taken, result came in form of reward, and we even succeeded to defeat corona with encouraging result till 30th November. 407 admission, 166 and 80 vaginal delivery, with only 3 mortality, only 1 due to corona and other due to antepartum eclampsia and ovarian cancer stage 4, with negligible infection rate in our healthcare worker. And also result came in form of a smile in the eyes of patients. So this success story of challenging tasks can conclude that implementation of knowledge is the starting point of success, and small steps in right direction can lead to great achievement. At the end, I would like to thank my principal sir, Dr. R.B. Kamal, and our whole team who supported me in this journey. I would also like to thank the organizing team, Dr. Ashna Verma, Dr. Ashna Sharma, Dr. Vinita, Dr. Alpna Agrawal, Dr. Alpna Kansal, Dr. Manisha Gupta. And I also want to thank our chairperson, Dr. Kiran Pandey ma'am, Dr. Manju Shukla, Dr. Urmila Singh, Dr. Umla Singh, Dr. Bharti Maheshwari, Dr. Tarni Taneja, Dr.
Thank you. I think Dr. Neena Gupta's some internet connection.
Thank you.
I think it
Thank
is
you.
complete also.
Thank you, Dr. Neena Gupta, for a wonderful presentation here. Now I would like Dr. Tarini Taneja, our President-elect, to say a few words. Dr. Tarini?
Yes. Dr. Manisha, thank you so much for this opportunity. First of all, congratulations, Dr. Neena, for such a literally highlighting about the safety of the health worker. And I'm really privileged, it's my privileged opportunity to hear this oration, Dr. Kuti oration. I'm really as a great fan of Dr. Kuti. So I've done my internship from Queen Mary's under her regime, and I'm really glad the Ghaziabad team has done a wonderful job. They had done a great first. Congratulations for them, and congratulations to our founder stalwart, Dr. Usha ma'am, Dr. Chandravati, and all team for taking starting the UP chapter, and now is taking height, as Dr. Anuradha Khanna already told. Dr. Anuradha Khanna, thank you so much. I'm really thank you for sharing this session. Thank you, everyone. Thank you so much.
Thank you, ma'am. Thank you so much. Now I would like to invite Dr. Bharti. Would you like to say a few words?
Yes, thank you and congratulations, Dr. Neena Gupta, and thanks all organizers for giving me this opportunity. And this was very good topic, and in fact, related to this topic, I would like to share that congratulations to Kanpur team and other medical colleges, those who are caring the COVID patient. And I am also a part of that medical college. We have done around 60 cesarean sections and around 10 deliveries, though it was in less number than many compared, and we have treated around 200 200 COVID positive pregnant patients. But fortunately, with our security system and what we have adopted, no resident has got infected, and even sometimes exposure time is around 2 to 3 hours. That continuously we have to do some emergency cesareans by one team. But fortunately, they have not infected. So this was a big success, that how we have to treat the COVID patients and without getting infections to our staff and nursing staff. Of course, one or two nursing staff. Those who were not so directly exposed, they got infection, though they are treated. So I think that how they are wearing the kit, how they are doffing off and other things, that is also matters. So that things should be emphasized. And it is really congratulations. And of course, this is a concept of a Professor Padam Shri Dr. Usha Sharma Madam with other legends, Dr. Chandravati Madam, Meera Gnotri Madam, and all Ghaziabad organizers. That's a big, superb conference, and a big congratulations. Thank you.
Thank you, Dr. Bharti. Now I invite Dr. Shashi Arora to say the vote of thanks. Ma'am, please unmute yourself, ma'am.
I would like to say something. At the outset, I would like to congratulate to Ghaziabad Society for the successful and wonderful conference of the UPCOG 2020. And it's my proud privilege to be here. Thanks to Ghaziabad Society, both Alpana and both Archanas. Thank you very much. And thank to Dr. Nina for the wonderful talk about the care and safety taking during the corona positive patient here. Thank you very much.
Thank you, ma'am. Thank you so much. Dr. Shashi Arora, please.
A very good afternoon, everyone. I'm feeling extremely privileged and honored for chairing this particular session, which is in the name of our mentor, great teacher, Professor Kuti. I bow my head to the great teacher, Professor Kuti ji, who not only taught the subject, but tried her most to make us good, caring professionals and human beings. My grateful thanks to the great teacher who's always tried to imbibe good medical ethics to all our students. I'm grateful to the august presence of most respectful Padam Shri Professor Usha Sharma ji, Professor Chandravati ji, Dr. Ednani, and other seniors. We all shall remain obliged to you for everything you always stood with your students and ensure that they are successful person in their future endeavor. I'm extremely grateful to the organizers of UPCOG for such a momentous and splendid show of the gynecologists and obstetrics professionals, especially during this pandemic, COVID pandemic. And this not only boosted the sagging morale of we all as a part of society, but gave renewed strength too. My special and sincere thanks to the respected teachers, Dr. Manju Shukla. Your presence mean a lot. All of us, you are it. Mean to all of us. You are a teacher who won the heart of all of your students. Fortunately, I am one of them. What we are today is all because of teachers like you, madam. My thanks to Dr. Kiran Pandey, Dr. Bharti Maheshwari, Dr. Urmila Singh, Dr. Tarini for chairing this very important session with me. I congratulate Dr. Nina Gupta for such a wonderful oration. It was very informative, clear, helpful for all of us, and that actually in boosting up our confidence in working in COVID area. Once again, my sincere thanks to the organizers, both the Archanas, both the Alpanas.
It's 1 o'clock.
For giving me this opportunity to be a part of this important oration. Thank you so much.
Thank you, ma'am. I thank all the chairpersons and the speaker, Dr. Nina Gupta, for the wonderful oration. And now I hand over the session to Dr. Alpana Kansal for the next. Thank you all.
Hello. Alpna. Hello, Alpna ma'am.
Please start, Rashmi. Please start.
Thank you, Alpna ma'am. A very good afternoon to my all the dignitaries and viewers. After an excellent and wonderful oration by Dr. Neena Gupta ma'am, now we go ahead with a panel discussion on gestational trophoblastic diseases. I like to start to offer my gratitude to Professor Kiran Pandey. Ma'am is an eminent personality. She is head of department, GSVM Medical College, Kanpur, ICOG Governing Council member.
I think, Rashmi, I was introduced only few minutes back, so you can leave it because we are short of time.
Okay,
you better
ma'am.
you introduce my co-moderator.
Okay, ma'am. Welcome, ma'am. We have a wonderful and smiling co-moderator, Dr.
Thank you so much.
Chief Assistant Professor, GSVM Medical College, Kanpur. She has US certified course.
Ma'am, please be short but stick it.
Critical care obstetrics and high risk. Yes, her interest of area is gynae oncology, high risk pregnancy, adolescent health. The panelist we have today, Dr. Alka Sethi. Ma'am is in former superintendent and consultant gynecology Cantonment Hospital, Jhansi. She delivered many guest lectures in many prestigious organizations. She conducted many workshops on PPH medical legal aspect. She involved in many awareness program on adolescent.
I think if the organizers agree, let's keep the introduction to the short.
Okay, ma'am.
Save time so that we are able to give messages about it.
Okay, ma'am. Dr. Shaheen, she is professor in charge in ART unit, JN Medical College, AMU, Agra. Next slide, Dr. Shaheen. And Dr. Smriti Gupta. Next slide. Next slide. Ma'am is an associate professor in Subharti Medical College, Meerut, and her area of interest is high-risk pregnancy. Next, Mrs. Sabah Asad, she is consultant obstetrician in Moradabad. Dr. Shalini Agrawal, consultant gynecology in Max Hospital,
Hello, ma'am.
Delhi. Dr. Shalini, next slide. She has a keen academician and involved in many public awareness program. Dr. Vinita, she is consultant obstetrician in gynecology, Ayushi Hospital, Allahabad. Next, Dr. Monica Agrawal, she is senior consultant, Apollo Heddle Hospital and Shanti Gopal Hospital. I
Hello,
welcome
ma'am.
all the esteemed panelists and hand over to Dr. Kiran Pandey, ma'am, and Dr. Pavika for further.
Thank you, Dr. Rashmi. The first thing I would, by the time Dr. Pavika starts sharing our screen, I would request the other participants.
Ma'am, hello. Ma'am, please allow me to share the screen. They are not allowing me to share the screen. Hello. Hello, am I audible?
You are audible. Rashmi, please see that.
Yes, they are not allowing me to share my screen.
Ritu, please let Dr. Pavika share the screen.
Yeah, thank you so much, ma'am. Thank you.
And in the meantime, when the screen is being shared, I would request everyone to keep their mic unmuted and to avoid the disturbances. Basically, which happens into the virtual programs, I have decided to put the questions by name. So please, one by one, whoever is being questioned answers. And if somebody wants to add on the thing, then please unmute. And after the question, you please mute yourself. That way, we will be able to give the answers very nicely. So with this, I start with it. Thank you, Dr. Pavika, who's
yes, ma'am. Yes, ma'am.
And I welcome all the panelists, and we will try to give a good, successful and good messages. Next slide, please. You can move around with I think this. Yeah, so let's come to what is basically all of you know already, the GTD or the GTN, which is
I request, please unmute yourself. Please mute yourself. Sorry, mute yourself. Mute yourself. Though it's a very disturbing, and sometimes you feel embarrassed also. Anyway, so GTD and GTN are basically a heterogeneous group of interrelated lesions that arise, we all know, from abnormal proliferation of the placental trophoblast. Just as to revise you, give an incidence. And the incidence is actually very less if we see the Europe and America, etc. But in India, it is very high. I really tried, and Pavika also tried to find out the incidence in India. We went through all the researches, but we could not. Maybe the reason is that in India, documentation part is we are actually lacking into. We do lots and lots of work, but we do not document. That's a tragedy, or you can say sad state of affairs. So we could not find the incidence in India, but we all know, like in this month only, we last 15 or 20 days, I would say we got 2 cases of GTN, which I will be showing you here also. And basically, out of all these, the hydatidiform mole is which encompasses the 80%, and invasive mole almost 15%, choriocarcinoma 5%. But the best thing about this GTN is, which gives us hope, and that is the cure rate is almost approaching the 100%. So it can be classified, just tell you this introductory few things. We all know it's a benign or malignant. Partial mole, complete mole, we have been studying from our MBBS period. Malignant choriocarcinoma, we have been also studying. Invasive mole, we also know. In malignant, this is maybe, I mean, at least I don't remember at my resident time when I was studying, but that was long back, at around almost reaching 40 years. So that time, intermediate trophoblastic, this group was not there, tumors, and which can be divided into ETT and PSTT, placental site trophoblastic tumor and the epithelioid trophoblastic tumors. So this is one group which is important to be understood. And the reason why this classification is that they have a varied clinical behavior, they have a different morphology, they have a different histological features, and their management protocol and follow-up is also different. So these are the important things. So let's start with the case 1. I think abhi bhi kuch logon ka mute nahi hai aur sounds are disturbing, sounds are coming. So Pavika, start with the case 1. Okay, thank you so much, ma'am. I'll also tell you we have a short time. Yes, we have to cut short little bit. Okay, thank you so much, ma'am. A 24-year-old patient, primary, with 2 months amenorrhea, came to our site with complaint of on and off bleeding and history of passage of grape-like vesicles. On general examination, significant pallor was present with respiratory rate of 20 per minute. Rest was within normal limits. On per abdomen was soft. Per speculum examination showed os was closed with slight bleeding present. On bimanual per rectal examination, uterus corresponded to 18-week size, and bilateral adnexa were mobile and non-tender. Well, I think Dr. Shalini, doctor, diagnosis is very clear. Dr. Shalini, are you there?
Yes, I'm so sorry, it was muted.
Okay, no
Okay,
issue.
right.
I mean, you know the questions,
Yes,
they will be coming
absolutely.
to, so that person unmutes itself.
Right,
Okay.
right, ma'am, right.
So
This is a
diagnosis
clear-cut case of a vesicular mole, a complete hydatidiform mole, because of the history which is being given by the patient of passing grape-like vesicles.
Yeah, this is the classical history. Thank
Right.
you. So it's a very clear cut. Next slide, please. I will keep this question, I mean, this case very short. So how will you work up in this case, Dr. Shaheen?
Good afternoon, everyone, and ma'am. So for this, we have to take proper history with detailed examination, and the main, other than apart from the other investigation, the main 2 investigation is serum beta HCG and pelvic ultrasound. Ultrasound,
next slide, Pavika.
typical features like honeycomb appearance is rarely seen, especially in the first trimester. But USG features suggest for complete molar pregnancy include polypoid mass between 5 to 7 weeks of gestation and a thickened cystic stroma spaces in villus tissues after 8 weeks of gestational age. So, and for partial mole, there may be a thickened cystic spaces in the decidual tissues and placental sites, as well as there may be a deformed sac, and the ratio of transfers to anteroposterior diameter of the sac may be greater than 1 to 1 is to more than 1 or to 1.5. So,
correct. And yes, and basically very rightly tell, the ultrasound and the serum beta SCG are the two strong pillars of the investigation. And as fetal anomaly, you have very rightly described properly the findings on ultrasound. A fetal anomaly also sometimes you can find. So next slide, please. So Dr. Smriti, can you take up this question? How will you do it? What is the ideal treatment?
Ma'am, she is already in the process of expulsion. We should complete it with the help of suction evacuation using a bigger size Carmen cannula and making sure of all the precautions. I think we'll be discussing that later.
Yeah. So, next question. So suction evacuation is the mainstay, as you have said. And if possible, because now because of the PCBNDT Act, it is not possible, but in foreign countries, actually they do prefer ultrasound guidance because it's a soft uterus. And sometimes in those cases who are a high risk cases, which we will discuss the factors, I will tell you in a few minutes. So hysterectomy can also be the choice. Next slide, please. So what precautions you will take when while doing the suction evacuation, Dr. Vinita?
Yes, ma'am. Whenever we are going to do the suction evacuation, if the os were closed, then we have to dilate the surface. But in this case, the os is already open and the vesicles are coming out. So we have to suction if we have the facility of USG, then under USG guidance, it is better. But if it is not, then we can do the process, try to do it very fast, because the chances of hemorrhage will be less if we will go fast. And during the evacuation, we should be able to manage the emergency hemorrhage. So we should have blood transfusion and be prepared for the emergency measures of because of the blood loss. After the evacuation, ma'am, we need to do during the process of expulsion, normally we should not go for the oxytocin infusion or the methylargometrin or the prostaglandin type of rectal things. In case of emergency hemorrhage, if the blood loss is going very fast, then we can use it. Otherwise, we should avoid them because the chances of embolism is there. And
next
after
slide, please, Pavika. Correct, but here you have pointed out a very important thing about the uterotonic. Actually, when I was studying these guidelines, I saw the NCC guideline. Just to tell the audience, NCC guideline says that we should start oxytocin when we are initiating the evacuation. We were also reading this because the uterus becomes contracted, otherwise it bleeds. But RCOG guideline, which has just now Dr. Vinita has told, that they say because of the fear of embolization, it should only be given once the completion of evacuation is expected, that it is also almost completing and the uterus becomes contracted. Chances of embolization are decreased. So next slide, please, Pavika. You take up this. How will you follow up, Dr. Monica?
Yes, ma'am. Ma'am, once we are done with the suction evacuation, now we have a diagnosis in hand, and we'll be following up the case with SCG measurement once a week till we get a normal readings of beta SCG for 3 consecutive weeks. Then once in a month for 6 months as per protocol, and then once in 6 months for the next 1 year. We should keep this patient for follow-up at least for 2 years, and we should be advising her contraception, mostly the barrier one, because IUD is usually not recommended because chances of perforation. Also, once the HCG has come down to normal, we can advise her with the OCT.
Yeah, next
also,
slide, please, Pavika. Are you there? Yes.
Yes, ma'am. Yes, ma'am.
Yeah. So very correctly, 1 to 2 weeks essay normalizes. Once it's normalized for 3 weeks, then we go for 6 monthly normals, up to 6 monthly normal we'll.
Ma'am, can I please add one thing?
Yeah, definitely.
Ma'am, when we were discussing about the precautions that we take, I would like to just point out one thing. This uterus is 18 week size. They say any HMO where the size is more than 14 weeks, we should be prepared for perioperative pulmonary complications. So we need to have a good anesthesia team also ready for that.
Very nice point added with it. Of course, we do. That is the embolus. Yeah.
Yes, ma'am. I was just continuing. Actually, we also look for the new any symptom of again, like during the follow-up, patient presents with vagina bleeding again. Any signs of cough, hemoptysis, metastasis. We should be looking for all these symptoms also. While
at every follow-up, the 3 basic things which were told to us. Yes.
May I add something? Ma'am, according to RCOG, we have to follow-up should be done if the beta HCG return to normal within 56 days. Then the 6 months should be counted from the day of evacuation. If the beta HCG is not returning to within 56 days of the evacuation, then the 6 months of follow-up should be counted from the day the beta HCG returns to normal.
So that is what means by Dr. Shaheen, that from the normalization of HCG means that it has become normal. And from that 6 months we are talking about it. We're talking from the date of evacuation.
If it returns within 56 days, then the 6 months may be counted from the day of evacuation.
Yeah, correct. So what is the role of prophylactic chemotherapy, Dr. Sabha? Do you give it or avoid it, or what is your opinion? Should it be given or not?
Ma'am, routinely the prophylactic chemoprophylaxis is not recommended in all patients following molar evacuation, just because of the toxicity of the drug and associated morbidities. And yes, if the patient cannot come for follow-up, or if the initial SCG level is very high and the uterine size is more than 16 weeks, or a multipara patient more than 40 years of age who refuse for hysterectomy, then in that case, we can think of prophylactic chemotherapy.
Pavika? Yeah.
Yes, ma'am.
You can consider these points.
Yes, prophylactic chemotherapy with methotrexate or dexamethasone should be considered only in high-risk group for post-Polygenian. As rightly said by somebody, age more than 40 years, beta HCG more than 1 lakhs, excessive uterine enlargement, thecal uteruses more than 6 centimeters, or when SCG follow-up is unavailable or unreliable. And I should stress here that hysterectomy does not prevent the metastasis. Even after hysterectomy, we have to follow the patient as per the protocol. We don't have to hysterectomy just only makes hum thoda sa interval we can increase between the follows, but we have to follow the patient even after hysterectomy also. Okay, thank you.
Thank you. So the next quickly come to the next case. That is another important thing. Dr. Pavika.
Yes, 28-year-old patient, para 1+0, came to our side with on and off bleeding per vaginum since 2 months with very severe anemia. She had delivered an IUD baby 2 months back at home and had complained of bleeding per vaginum, for which she underwent DNC by a local practitioner, and there she was also transfused 3 units of blood. But symptoms did not improve, which brought to her our side. On dental examination, again, significant pallor was present with respiratory rate of 20 per minute. Rest was WNL. On local examination, slight bleeding was present. On one bimanual examination, uterus corresponded to 20 to 22 week size, os closed, bilateral adnexa were palpable, mobile, appears to be soft and cystic, 6 into 7 centimeters on the right side and 5 into 7 centimeters on the left side.
Yeah, so what all you will consider for it? Dr. Alka, will you like to take up this case? Dr. Alka? Dr. Alka, are you there? Please unmute.
Thank you, Dr. Kiran, for including me. I would like to take more history from her, especially family history, contraceptive history, smoking, and her dietary history. And apart from that, I would like to know her symptoms, whether she's having fever, vomiting, any pain or purulent discharge. In that case, it could be an invasive disease. And because she's still bleeding even after DNC. It could be perforation also. And whether there is any cough, dyspnea, hemoptysis, which will go in favor of lung metastasis, epigastric pain or upper quadrant pain, that will go in favor of hepatic spread, and a neurological, which of course occurs later on. But these are the symptoms which I would like to ask. And then
Yeah, very rightly you said ki all the very detailed history, Dr. Alka, as you said, is required to really reach the diagnosis. We are dealing with the case at the moment of GTN, but otherwise, when a case comes, the most important point is that you have to take the detailed history, as you have said. So, what more we can think of this? What are the possible problem issues? They can be like even sometimes some lobe remains, or even patient has conceived in between immediately and aborted, or there can be infection which is chronically prolonged. Many a time patients do come with a history of slight bleeding, and as you said, purulent discharge or a history of infection or pain. So endometritis can be there. Rarely we can find uterine AV malformation. Even if the patient had a fibroid and with pregnancy, post delivery, you might have noticed in your OPD that later in the postpartum period, patient comes with the extra bleeding and bleeding, irregular bleeding. So, and of course, GTN is the one of the important diagnoses. So, thank you, Dr. Alka. Next, Dr. Shalini, what
Yes, ma'am.
important other points you can take? Matlab, what is the actually important key point which will make you think that it can be GTN?
In this particular case, this patient has undergone a DNC twice, not just once. She's come to us with severe pallor. She's been bleeding. She's been given blood transfusion. This indicates a more sinister pathology rather than just being a case of a small lobe or a small piece remaining inside. So that is one thing which should really arouse our suspicion that there could be a sinister, something like a gestational trophoblastic neoplasia, which is hiding inside out here. And we must rule it out by doing a beta HCG and ultrasound and things like that, and try and also get the histopathology of whatever curettage has been done. Like Dr. Alka said.
Unfortunately, what happens, the people do not send for histopathology most
That's
of
the
these
problem.
time when the patient comes.
Right.
Actually, if you see, as you very rightly pointed out, it is the history of irregular vaginal bleeding.
Right.
As somebody also said it, that after even 2 months,
Right.
she is still persistent bleeding. So this
Absolutely.
is the thing which puts your mind that there is a sinister pathology, as you very rightly said, and it can be a GTN.
Right.
So, Dr. Pavika, next slide.
So most common presentation is very rightly said, history of irregular vaginal bleeding, not even completely relieved by repeated DNCs, as well as hemostatic agents. So which women should be investigated for GTN after non-molar pregnancy? Dr. Sabha?
I think any woman with persistent vaginal bleeding after a pregnancy event is at increased risk of developing GTN. So if a patient present with irregular vaginal bleeding after delivery with some purulent discharge or some history of cough, hemoptysis, any neurological symptoms, and on examination the GC is not good, patient is pale, uterine size is more, or some nodule or mass is present in the vagina, so of course we think that it may be a case of GTN.
Yeah. What actually RCOG says just now, which are the guidelines have come into this September, everything what you said was very correct. The only thing is कि we were all used to think beta HCG. Now they say that a urine HCG test should be performed in all cases of persistent and irregular vaginal bleeding lasting more than 8 weeks after a pregnancy event. So this is a little change they have advocated, that urine pregnancy test is important, and later if it is found positive, then you do of course other tests. So next Dr. Pavika, what are the
Yes, ma'am. What are the high risk factors for post-molar GTN after a molar pregnancy? Dr. Shalini?
Yes, thank you, Dr. Pavika. I think this we have already just discussed it just now. Which
Actually,
are the patients?
non-molar. We were asking non-polar. Now, when you know that this is a case of a molar prayer.
Right. Yeah. Even in the molar pregnancies, if the beta HCG levels were very, very high, more than 1 lakh, if the uterine enlargement was way more, like we had in the first case, 2 months of amenorrhea and 18 weeks uterine size. So the uterine enlargement is much more. Thecal lutein cysts are present more than 6 centimeters. These are the patients of molar pregnancy who are likely to go into gestational trophoblastic neoplasia even after evacuation. One interesting thing which I found, yes, in this is that as when they do the cytogenetics, as we have read, a hydatiform mole can form by 2 different ways. It is a diploid type of variety. One of the commonest ways in which it forms is an empty ovum, and one sperm goes and fertilizes and then it reduplicates itself. This is the common variety. The uncommon one is when 2 sperms go and fertilize an empty ovum. It is this dispermic type of fertilization, they say, which they have found much more in those patients who go on to develop a gestational trophoblastic neoplasia. Of course, this is a theoretical concern only because we will not know how exactly it has gone on, but probably something is sitting over there. Yes.
So next, so how to finally confirm this diagnosis?
RCOG and in fact, FIGO has made it very easy for us. They say postmolar GTN. When we are doing that beta HCG monitoring, we are doing at weekly interval. So if on day 1, 7, 14, 21, if we are getting a plateau, that is neither increase or decrease of 10%, or we are getting an increase of more than 10% in 3 samples, 1, 7, 14, or we have a histological proven case of choriocarcinoma, or the beta HCG is still persistent after 6 months, then we label that person as postmolar GTN.
Very right.
Very right.
Next.
Okay.
This is being divided. So how shall we proceed now once we have a suspicion?
So the case in post-molar GTN, if we are suspecting, the main aim of to choose the best regime in the cases of post-molar treatment regime, and treatment regime should be chosen according to the scoring as well as prognostic score as well as staging. So for staging and scoring, we have to we have to do the test to score the disease. We have to take the detailed history, do the physical examination as well as test. So the test.
So what investigations you would like to do here?
Yeah, apart from beta HCG, we should go for chest X-ray, and in chest X-ray, we should try to count the number of metastases. And if it is positive, then CT scan should be done to confirm the finding of chest X-ray. Then X-ray, ultrasound of the liver to rule out liver metastasis, as well as if there is any suspicion of brain metastasis, we should also go for MRI or CT scan of brain to do the proper scoring and proper diagnosing. And LFT and KFT should also be advised.
Yeah, always LFT, KFT, even thyroid investigations.
And also the ultrasound to assess the volume of the tumor, as the volume is also make the scoring, take part in the scoring, and also the number of the metastasis.
So for that, Doppler pelvic ultrasound seems to be best. And the only thing which I would like here to emphasize is that if the chest X-ray reveals no evidence of metastatic disease, then there is no further imaging is recommended.
Yeah, no CT scan is needed. If the chest X-ray is normal. If chest X-ray shows something, then we have to go for
higher investigations
to see to measure the number, to confirm the number of metastasis. That is important in scoring.
So what happened, Dr. Pavika, in our case?
Yes, so in our case, we went all through the investigations, and beta HCG was found to be very much high, 225,000 milli-international units per ml. All investigations are within normal limits. Our transabdominal ultrasound showed a bulky uterus with increased vascularity and a hypoechoic heterogeneous lesion of about 7.5 into 5.7 centimeters. Query RPOC, query GTN, since beta HCG was very high. Bilateral adnexal showed cyst, test was WNL. Then we went for an MRI also. Then it showed a poorly defined mass of approximately 10 into 12 centimeters, iso-intense to the myometrium, with foci of high signal intensity deeply invading the myometrium, as well as perforating the fundo-anterior aspect of the uterine wall.
Actually, what happened when we did the ultrasound, patient was anemic also. So we had to I think hemoglobin report is not mentioned. We had to in between give 3 units of blood to bring her hemogram at a normal level. And patient was also not able to get the MRI done. There were some hitches. So it took 10 to 12 days, and by that time it grows very fast. So you can see the bulk of the tumor enlarge. So now once you know it is a perforating mole, how can we further take care of it? Pavika, you take care of her for
Yes,
1
sir.
minute.
Dr. Monica, please, what will be the further management in this case? Dr. Monica?
Yeah, this as like we saw the history and the case. It is a case of perforating mole. So, Dr. Pavika, what were the other like chest X-ray and all? I just could not.
Yeah, all investigations are within normal limits. We went for an MRI because we had some hitch. Should be kept for suction evacuation, or whether we should go for another investigation just to see whether the myometrium is intact or not. So we went for an MRI, and MRI showed this perforating the fundo-anterior aspect of the uterine wall. So what will be the further management in such a case?
See, it's a case of perforating mole, and as per investigations, I think it has not. There are no signs like it has perforated the mole. We should go for hysterectomy in this patient.
Yeah, very correct. Immediate, I mean, you don't have to wait for anything.
Yes,
And the
ma'am.
patient has to go for exploratory laparotomy and hysterectomy. Would you like to do something about ovary also?
No.
Just
Ma'am,
for the
No.
audience benefit, if you explain it.
Hysterectomy, and on follow-up, we follow the beta HCG with as the beta HCG will come
come
down,
to follow up.
equilibrium will regress automatically.
Yeah. So in this case, Pavika?
Yes, ma'am. Intraoperative findings, uterus was found to be 22 weeks size, and there was a mass on the superior aspect of the uterine fundus perforating it, as well as there was also a mass which perforated into through the anterior aspect of the cervix. Bilateral ovaries had thicker litanises. There were no evidence of any other metastatic disease found in the abdomen. Abdominal hysterectomy was done. Patient was given 5 units of PCVs along with FFPs. So, and patient's repeat beta HCG was done. It was after 48 hours, it was 50,000. And now she is presently is in follow-up, as has been registered at our Cancer Institute. And this is the diagrammatic representation. Ma'am, will you like to?
Yeah. You can see the two the arrows here. The anterior surface, there's a big perforation, and even on the superior where the artery is pointed out. All these places, there were big perforations, and the whole molar tissue was coming out. It was bad case in this sense. And I think, is there next slide also? No, before that, only one thing I would like to re-emphasize upon it. But sometimes what happens, even in this case, when I opened it, the ovaries were looking so huge, and they look really that they are pathological. There you have to resist yourself, because they do not need any interference, and they regress back to the normal when the beta HCG come. So for the general young postgraduates and practitioners, this is an important thing. How much they look that they are bad, please leave them, don't touch it, they will become all right. This was a real actually case, and now she is this JKCI is our JK Cancer Institute. So next we come to the third case.
28-year-old para 3+1 with previous 2 LSCS came with recurrent episodes of heavy bleeding per vaginum for the last 2 months with previous history of obetificin intake. She had also a history of DNC at a private practitioner, but she continues to bleed. She reported in the emergency ward of our department with complaint of bleeding per vaginum, and on per speculum examination, her os was open. So an emergency suction evacuation was done as a suspected case of incomplete abortion, but she bled profusely.
Actually, it was not done. It was planned. Tried to do it.
It was, but she
started bleeding.
Yeah, she started bleeding, but patient was at the same time also transfused 3 units of blood. So what will be the probable causes?
This was an interesting case in this sense. It was looking like absolutely that patient is going to abort, and the resident took it immediately that she will complete the evacuation. But as soon as she put the instrument, patient started pouring out like anything. So now, Dr. Vinita, what would you see? How will we?
Ma'am, as a first side, as you said, anyone can see it is an incomplete abortion. And this is really a very horrible situation when we see it as the OPD in our emergencies. I think the first we should think about any because it's a previous 2 section, there can be a scar pregnancy, which which has the adhered tissue at the placental side, and now this is bleeding continuously and heavy bleeding because of persistent activity of the placental tissue. Otherwise, it can be AV malformation, which can be injured or something like that because the DNCs have been done already. And injuries can be done by the previous practitioner here, if it has done. Uterine injury, the patient can be low because of the bleeding at the site of uterus. And at the end, if we have excluded all the local pathologies suspecting scar pregnancy, and we have already just hemostasis is already done, we have in our mind, suppose the persistent trophoblastic activity must be there. Like we can think about the trophoblastic tumor or neoplasia, something like that. But we can't say at first instant because at this stage we have just stopped the bleeding. Now further workup.
Yeah, Dr. Vinita, I agree fully with you. That's what the message we wanted to give, that this case actually does not seem to be on the first hand a case of GTN. It definitely, as you very rightly said, it can be a case of a scarred pregnancy. Next slide, please, Pavika. It can be adherent. The tissue has become adherent to the previous 2 scars and bleeding. And of course, repeated DNC infection, etc. can be done. An AV malformation also, which somebody pointed out in last one. That's these are the important things. GTN is probably you will think last.
So on investigations, then she underwent a transabdominal ultrasound, which showed highly vascular changes in the lower part of the uterus and the cervix. We went for a beta HCG, which was found to be 22,447, and all her investigations were found to be normal.
So here your case is a little different. You have a vascularity, you have a raised HCG, but not in the legs. Dr. Alka, what will you think? What can we do? And of course, there is the beta HCG is raised, so there is a increased trophoblastic activity. That's very clear.
Placental site trophoblastic tumor
Yes.
so can be thought of.
Yeah,
and,
very correct.
And
so how would you proceed for that?
I'll go in for further investigations, further evaluation of the beta unit. Especially beta unit has to be seen that all the beta units have to be done, and the core beta, especially glycosylated beta HCG is very important in this case. That will distinguish from GTN to choreo to malignancy. So after doing all this investigations and metastatic workup, then only we can proceed for further. And chemotherapy should be...
Ma'am, can I add?
Yes.
Ma'am, this is mostly case of PSTT. As we can see, the beta HCG rise is not much more. So in this case, HPL is very specific.
Yeah.
Human placental lactogen is a marker for PSTT. So we can go for HPL testing also, along with like the routine examination of patient. As we saw, I mean, the patient present with bleeding, we can go for a scan also to see a mass at the
Scan
placental
was
site.
done. Scan was already done.
Yeah, so HPL is a marker for PST.
Yeah.
I wanted to add.
No, correct. Dr. Alka, I would like to hear just think this core beta HCG. One thing very correct. There are many types of HCGs: core, intact, nigged, and fall. I mean various types, but they are not being done. In the routine beta HCG is not detecting them, and I really do not know where the facility of these glycosylated HCG doing testing is possible or not. So what practically what we are doing is we are taking as a clinical guideline. And another thing is this glycosylated hemoglobin, the HCG is more useful when we are differentiating between the quiescent GTN and the active. And PSTT and choreo both are actually active one. So here it will not be of too much value. So what we had to do, we had to do the clinical management of the patient.
So we went for 4 doses of injection methotrexate, and we also followed her with beta SAG, and which was quite fallen down from 22,000 to 989, and then weekly follow-up was being done, and then it came to be 81. But she did not relieve of her symptoms. Then again, we went for an MRI. This forced us to go for an MRI, which revealed diffusely bulky uterus with evidence of a large space-occupying lesion filling the uterine cavity, and the lesion was appeared to be hypointense on T1 and hyperintense on T2 images. So,
yeah, so basically symptoms did not relieve, though the important thing is though the beta CG fallen down responded well to the methotrexate. So,
Ma'am, did we have any histopathology at this stage?
We have not done anything yet.
Okay, when we had started, we did not get any products at that time.
No, we did not get any products.
Right, right.
Yeah.
Right,
yeah. So now, initially the only thing when she was bleeding, we did not get product. We just tamponade, bleeding control, got the HCG done, and this was the result. So now we have to plan the final treatment.
Right.
So what do you think in PSTT, Dr. Vinita? What would you like to do it? Will we continue with the methotrexate or something?
PSTT is a tumor that is normally chemo-resistant. So we have to proceed for the surgical procedure. If the PSTT is there and it is almost, as you said, it is filling up the whole of the uterine cavity, we should be planned for hysterectomy. And after hysterectomy, we can go for the histopathology, and then we will label it. If it is confirmed at PSTT, then further workup should be done. But hysterectomy is first to be done.
Thank you. So, Pavika, thoda sa jaldi kare because we have less time.
Yes.
So, very rightly, hysterectomy with lymph node dissection is recommended treatment because this move extends by the lymphatics. It invades. Metastectomy can be done if lung may, if you find a single or solitary metastatic lesions, then you can go for it. And of course, as Dr. Pavika already told you, after hysterectomy also, it's not that beta HCG level has to be monitored. So chemotherapy and further treatment has to be given in the
Hi.
Huh?
Please unmute.
Hello, please, Dr. Gauri. Somebody is there. Audience, please mute yourself. Audience, please mute yourself. Thank you very much.
So she underwent exploratory laparotomy and abdominal hysterectomy. Per operative findings, uterus was bulky, bladder was densely adherent to the previous scar site. Since she was a case of previous 2 LSCs, right ovarian thecal litmus was 7 into 8 centimeters. And on cut section, which is very important, myometrial hyperplasia was present, and there was 5 into 3 centimeters space occupying lesion in the uterine cavity at the cervico-isthmic junction, which is being shown on cut section.
Yeah, so you can see that when we opened the cut in the front, there was this solitary localized lesion, which might have latent perforated. So how it is different from other types? Dr. Alka. Dr. Alka, will you please, what are these specific things, points which are in PSTT, which are different from other GTN?
First of all, it's a locally originating tumor, and it is chemo-resistant. So local treatment has of more importance, and it is diagnosed quite late because it is only through MRI or any other investigative procedures we can do. That is the thing. So local treatment like hysterectomy was done. That should be done.
Yes, very rightly. It is a chemo resistant. It produces less ATG. These are actually being developed from the intermediate trophoblasts, and they are comparatively less. Incidence is not much, and they involve lymphatics more. This is also their important behavior. So many a times, if you feel that the lymph nodes are enlarged, then you have to do lymphadenectomy also. That you have to see for that. So initially they were being diagnosed very late. So in fact, if I remember the early time when the 100% mortality was there, but now it has been reduced once people have become aware. So Pavika, I think you explain that just in short, quickly.
Okay, so we classify it as intermediate trophoblastic tumor, and when the factors like interval from index pregnancy is less than 2 years, or there is superficial invasion, no necrosis, mitotic count is less than 5% high power fields, then we have done the basic primary management. We have to go for SCG monitoring along with imaging. But if any of the high risk factors like interval from index pregnancy is more than 2 years, deep invasion, necrosis, mitotic count is more than 5% high power field, then after even hysterectomy and pelvic lymphadenectomy, we have to consider for the patient for systemic therapy, and then we can go for put her on monitoring. So this is for non-metastatic, and metastatic again, along with hysterectomy, you have to give the basic chemotherapy regimen, IMACO, and again patient the follow with SCG monitoring or surveillance with imaging. So
I think the basic thing which we wanted to, which you have to understand, if the disease appears as late, interval between from the pregnancy event is very important. If it appears late, it is more problematic. If it appears earlier, then the score is less and we get a better result. So this has to be. Actually, this is a new entity. So Dr. Sabha, will you throw light on this?
Yeah.
In short.
Actually, it's a very rare trophoblastic lesion that is present, and most of the time it has been found that there may be some atypical, it is associated with some atypical features also. So if it is atypical placental site nodule, then it may transform into a placental.
How do you diagnose it first? How does it present and how do you diagnose it?
It is an incidental finding during curate or during endometrial biopsy, if it is found in histopathological examination, or during ultrasound, if there is some nodule is present, then
sometimes it presents as a bleeding, simply irregular bleeding also.
Yeah,
and when you do endometrial biopsy, very correctly said, then you are able to find it.
Yes.
So let's move it. I think it is a rare entity, so we'll not go much into it.
Okay.
We can take the fourth case, that is more important.
A 38-year-old patient, para 3, life 3, with last delivery 8 months back, presented to us with irregular vaginal bleeding. General examination, WNL except for pylori present. Per abdomen, soft, no organomegaly. On local examination, there was a friable bluish red color of mass, 3 into 2 centimeters on anterior vaginal wall. On per vaginal examination, uterus was enlarged, almost 10 to 12 week size, with slight tenderness, and it was mobile. So how will you? Ma'am?
Dr. Smriti?
Was any bleeding seen through the cervical loss, or only this mass was bleeding? Maybe
the mass was bleeding and cervical loss also, both places.
Okay. Here the findings are very much typical, as if it's a secondary in the vagina, because it's bluish anterior wall, beads on touch. So once we get a metastasis at any one site, we should do a complete metastatic workup to find out if any other site is involved. So apart from the routine, what we'll be doing, beta HCG, CBC, LFT, KFT, we should also do a thorough workup to rule out metastasis in brain by MRI, in lungs by X-ray. But in this case, just a normal X-ray will not suffice. If we have one metastasis, and even if X-ray is normal, we should go for CT scan of the thorax. We should go for CT scan of the whole abdomen as well as pelvis. We should do a complete thorough investigations, then do the scoring, and then later.
Yeah, very correctly. And if very rightly said, if the pulmonary metastasis is there, then only one should go for a brain MRI or CT. Right? The rest of you have to go for investigate for for the sites of all metastatic sites.
Yes, because in this case, ma'am, pulmonary metastasis is the commonest site. Vagina is second in the number. So if we are getting vaginal metastasis, we should pay more importance to pulmonary metastasis. And
correct, very rightly pointed out. Next slide, please.
So investigations in our case was beta HCG was 250,000. Ultrasound showed just enlarged uterus with a heterogeneous mass, increased with clarity, and on chest X-ray it was rounded opacity is present. And CCT abdomen was WNL. So what do you suspect in this case, Dr. Shine?
Dr. Shine, I think it's clear.
Okay.
Post-molar choriocarcinoma, yes. Post-molar GN, it's so we have to do the proper staging as well as risk scoring. So for staging, we have to, like, it is outside the lung, so it's involving the lung, and for scoring the age of the patient, and as the beta HCG is more than 1 lakh, more than 1 lakh, so it is under 4. It comes, opacities are there, number is not mentioned, so according to the number we can go for 2 or 3. So it is more than 7, that means it's a high risk, it is under the high risk group. So for high risk,
7, then low risk, high risk, and then if it is more than 12, then it is very high risk.
There is a risk of mortality within, actually.
More than 12, there is a, because of heavy bleeding. So do you think if for confirmation biopsy is required? Always?
No, it's not essential to go for biopsy. Actually, the case is like there is a HCG is so much high. If the patient may sometimes, if you go for biopsy, torrential bleeding may occur, and patient may. So,
and I think I would like the audience to note it that specifically that vaginal mass which is there and which is bleeding, please never touch for it for biopsy. It will might like torrential hemorrhage can be there. So do not touch it. You have very rightly, Dr. Shaheen said, very high level of beta HCG which are clear. You also have in X-ray round opacities. So it's a clear thing. There's no need ki we have to confirm chahiye biopsy se. Okay. So next. Typical pulmonary findings, I think show it quickly, Dr. Pavika. They can be alveolar, discrete, rounded densities, pleural effusion, or embolic pattern. Next, you can see here the diagrams. And, you can see in the brain also metastatic deposits. I'm hurrying a little bit so that this staging has also been. Dr. Alka, would you like to add something into staging? Dr. Alka, would you like to add something in the staging, or we move ahead?
I think we can move ahead. It's stage 1 to the uterus, stage 2 within the pelvis, and stage 3 lungs. It may or may not be with genital tract, and both stages extended to distant sites. So we've already.
Once again, I request to organizers that please see that others mute themselves. There is some phone which is Galvanishi J something which is not muted and disturbance is coming. So what are the prognostic factors exactly?
So it is.
I've already discussed. I think let's move ahead.
This is already discussed.
Yeah.
According to the
this also has been talked to. So treatment protocol.
Ma'am, low risk GTN, as we have already discussed, it's a scoring less than 6, or if the staging of the disease is 1, 2, or 3, the FIGO staging. So once we have a low risk GTN, what we should do is, apart from if required hysterectomy, we should go for a single agent chemotherapy. It could be methotrexate, actinomycin, etoposide. We should shift over to the next higher one, or we should change it only if there is some resistance, or despite the treatment, there is increase in the HCG, or the patient is showing some intolerance or allergic reactions, not tolerating. In that case, we should shift to the higher one, or if we see any other metastasis has developed in this time, then we should go for multi-agent chemotherapy. But single agent chemotherapy should be the first choice.
Yeah, and follow up, Dr. Alka, we can take the follow up. We had missed. Dr. Alka,
we have to do serial HCG examination. We have to do serial HCG examination every weekly for 3 weeks. Then, just as is said before, then for 6 months, then annual. Patient has to be counseled for proper follow-up, that she should come for follow-up. Otherwise, we lose the patient. So that is, counseling is also very important in the treatment part.
Right. So HCG every 2 weeks you keep on doing, and once it is normalized, then 2 weeks past. I mean, 2 weeks past normalization also you have to do levels, and then follow up has to be done every month for 12 months. This is for low risk GTN. And Dr. Shalini, you can take up the high risk GTN quickly?
Well, ma'am, yeah, it's very simple for choriocarcinoma. Low risk, we go for a single agent, and for high risk, we go for a multiple agent. Imaco regime is the commonest one which is used. And this needs to be given every week to the patient till the time HCG levels normalizes. And for 6 weeks after the HCG levels have become normal, we continue to give the regime of Imaco. And usually it's a good regime and most of the patients do respond to it very well.
And how do you follow up these cases?
Like I said, ma'am, up till 6 weeks, till the time HCG has normalized, we will go on giving Imaco. And after that, every 4 weekly, that is every month, we will keep on doing it for up to 12 months to make sure that the HCG levels stay normal.
But if they do, well, supposing the response is plateaued or remission is there, then we have to change the
then we have to change
chemotherapies or incomplete treatment. Then we have to change. So next slide. Next slide, Papika.
Yes, ma'am. So coming on to last case of our panel discussion.
Very short, we'll take it quickly.
A 33-year-old patient, primary with amenorrhea for 2.5 months, came to our OPD with ultrasound showing vesicular appearance, suggestive of H-mole, and report of beta HCG was 250,000. She underwent suction evacuation. Then she was followed up with beta HCG, and beta HCG also became normal within 6 to 8 weeks. But again, after 4 months, she came with on and off slight vaginal bleeding. Her ultrasound lower abdomen was done. There was no abnormal findings. So beta HCG was done. It was found to be 100 international units per ml. Then she was followed up with serial beta HCG. It was 68 and then 54. So what is the most probable diagnosis?
Dr. Vinita?
Ma'am, it's a secondary rise of the HCG, and it is not very high in the level.
Very low level.
Very low level. So this very low level HCG is normally said as the quiescent type of GTT, ma'am.
What can be the other also causes of sometime? Will you be what causes are the increase in beta HCG to such a low level?
Ma'am, secondary HCG level, maybe there can be a new pregnancy or the ectopic, somewhere the persistent trophoblastic tissue at the ectopic site, or there may be activity at the placental area that or the invasive or the tissue that remained was active. So the low level of
yes, right.
Ma'am, it could also be, I think, a false positive HCG.
We can have phantom HCGs. We have phenomena like phantom HCG. We have because of pituitary secretions, because of which we can have HCG rise. Also, we must keep in mind other tumors which give rise to HCG.
Actually, just this was the point we wanted to point out this case, that sometimes pituitary increase in LH and FSH can manifest, or sometimes the other tumors, as you rightly said it. So next slide, please. Pavika, keep on increasing GTN. So what do you understand? Aage badh jao. Let's finalize. So explain it.
So persistently very low levels of HCG, which usually remain static with no evidence of any lesion on extensive radiological and clinical evaluation. It occurs due to small focus of dispersed differentiated syncytial trophoblast cells and do not progress to invasive disease unless there is reappearance of cytotrophoblast or intermediate cells. So,
so Dr. Alka, would you like to do anything into this or just wait and watch? Dr. Alka, unmute yourself if you're there.
Sorry. As I've already said, here lies the importance of the glycosylated HCG. And that can only distinguish between choriocarcinoma and a low-grade quiescent form. That is most important. So
actually, the basic thing is, as you are rightly saying, rule out the evidence of any metastatic or malignant disease. है ना? Levels are less, so other things. I think. Hello. Too much disturbance. Dr. Shaheen, is there any? Would you like to treat this patient immediately or do what?
Who is speaking? Please, सब अपने को म्यूट कर लीजिए. कोई लगातार मेल वॉइस आ रही है. Please mute कर लीजिए अपने को.
Thank you, madam. So, Dr. Shaheen, would you like to?
Yes, in these type of patients, we should follow up doing the beta HCG, but no treatment like chemotherapy or surgery should not be done. We should do keep on watch on the beta HCG level if there is any rise or there is appearance of any symptoms or there is any problem. Most of these patients usually beta HCG may take 6 months to subside, and there are so many case reports the patient may get pregnancy even with the these levels of beta HCG. So I think there is no need, only the beta HCG estimation, serial beta HCG level should be done.
So I think just for the benefit of audience, what we wanted, ki these, supposing you get this type of picture, very low level of beta HCG is coming, nothing to get worried immediately. There may be other causes, but of course, investigations has to be done to rule out the other pathologies and to, as Dr. Alka said, if facility is there, then you can do glycosylated HCG to rule out between the active lesion and the quiescent lesion. And unless and until the level rises, you don't have to immediately start the treatments. Is there anything more, Pavika?
इसमें false positive almost सभी ने थोड़ा थोड़ा बताया.
हाँ, I think Dr. Alka has already told.
Yes, ma'am.
Yeah.
And what is glycosylated beta HCG
we discussed.
Yes.
So what is the only last question important is what is the long-term outcome for these women? Dr. Vinita, you can take it. Or anyone else can want to take it.
Ma'am, long-term outcome in women with GTM nowadays, they say the treatment is almost, cure rate is almost 95%, provided we diagnose them early. And we have a regular follow-up and we don't lose the patient to follow up with regular treatment.
Yeah,
ma'am, the outcome is normally good, because if we will able to save the uterus, then the patient can remain conceive, its fertility is maintained, and even after the hysterectomy, the chemotherapy is, if the patient is of choriocarcinoma, the prognosis is very good. So we have a very nice response after chemotherapy.
So best thing about is that we have a good fertility rate also. So I think that's the last one. Pavika, is there anything?
Yes, ma'am. Yes, ma'am.
So thank you very much, all the panelists. You have given excellent answers and very clear messages. I would, Dr. Archana, organizer, she wanted, I think we have been able to finish it at 2 o'clock, which she wanted. And once again, on behalf of my co-moderator and panelist, I would like to say thank you. A big thank you to each and everyone who has taken pain. Thanks, Dr. Usha Sharma, madam, you are here.
Thank you so much, ma'am.
Ma'am, thank you for giving me this opportunity.
Thank you, everyone. Thank you, ma'am. Thank you, ma'am.
And madam, our
Thank you,
panelists have given very clear-cut messages. Everyone was very good. In fact, they knew everything. We don't have to tell anything.
Thank you, ma'am.
Thank you so much, ma'am.
Thank you very much, ma'am. It was really a very concise panel. Very, very.
अलका यहाँ पर है. अलका सेठी.
जी मैडम.
Congratulations. तुमने कितना बढ़िया डांस का भेजा था वीडियो. Very nice. I was impressed.
जी मेरे पास फैकल्टी लिंक नहीं था, तो मैंने आपकी आशीर्वाद ले लिया. कल मैंने अटेंडी लिंक से ज्वाइन करके.
बिल्कुल, बहुत सुंदर, बहुत सुंदर.
Thank you, madam.
Thank you. And we tried to keep the very simple, straightforward cases so that we can give the right messages.
Yes.
Thank you. Thank you. No
excellent moderation, ma'am. Kiran ma'am and Pavika.
Thank you so much, ma'am. Thank you.
Thank you. Thank you, Kiran.
Okay. Thank you.
Bhavika, hello.
Thank you, everyone.
Thank you.
उषा शर्मा मैम प्रणाम। मैं नूतन बोल रही हूँ सहारनपुर से। आप हम लोगों को याद कर रहे थे, हमें बहुत मजा आ रहा था। आपका आशीर्वाद मिला तो बहुत ही मजा आया मैम।
बहुत बढ़िया, तुम लोगों की परफॉर्मेंस बहुत अच्छी थी। मैंने कहा
थैंक यू मैम, थैंक यू।
इसी में अपने नाम भेजो ना, दो एग्जीक्यूटिव
मैम। ठीक है,
हाँ
ठीक है मैम। किसको भेजना है, किसको भेजना है, हमें बता दीजिएगा।
डॉक्टर नूतन मुझे भेज देना।
ओके मैम, भारती मैम को मैं भेज दूंगी। बिल्कुल
भारती को भेज देना।
ठीक है मैम, ठीक है। और मैम आपका आशीर्वाद पाके ना ऐसा लगा कि बस सारी मेहनत स्वार्थ हो गई। सच्ची
इतना सुंदर था प्रोग्राम।
मैम आपके कमेंट्स भी
नमस्कार
बहुत ही
मैम,
ज्यादा सुंदर थे।
मृदुला बरेली से बोल रही हूँ।
हाँ मृदुला
मैम, यहाँ देखकर आपको इतना अच्छा लग रहा है कि इतने टाइम हो गया था नहीं मिले हुए, बट ये डिजिटल प्लेटफॉर्म इतने अच्छे हो गए हैं मैम कि फिर से हम लोग सबको देख सकते हैं।
That's true. और घर बैठे
जी मैम, जी मैम। और सबसे अच्छा एनकरेजिंग और सबसे ज्यादा एनकरेजिंग होता है कि मैम आप हर सेशन को उतने ही इंटरेस्ट से और उतनी ही एनर्जी से देखते हैं कि इट इज वेरी वेरी एनकरेजिंग फॉर ऑल ऑफ अस।
नहीं नहीं बेटा, ये तो मुझे लगता है इट इज मी ऑल द टाइम। आई कांट मिस इट।
एंड यू हैव ऑलवेज एनकरेज्ड अस। जब भी आप जितनी बार भी बरेली आए हैं, इट हैज ऑलवेज बीन एन ऑनर एंड प्लेजर मैडम।
थैंक यू सो मच।
हम लोग को आशीर्वाद सबको मिला हुआ है। थैंक यू मैडम।
अरे किरण
जी मैडम, और वेबिनार से मतलब सब मिलते रहते हैं और ये मंथली वेबिनार भी होते हैं। डॉक्टर मृदुला, डॉक्टर रीना इज कंडक्टिंग वेरी नाइस। एंड जनवरी में शी हैज गिवन द रिस्पांसिबिलिटी टू कानपुर, मतलब तो वी विल बी कंडक्टिंग अ वेबिनार, मंथली वेबिनार, एंड दे विल कीप इट। सो
जी मैडम, we'll certainly join that also because they are great opportunity। घर बैठ के आप इतना कुछ सीख रहे हैं।
नहीं, यहाँ पॉसिबल नहीं हो पाता है। मैं ये भी कहना चाहूंगी कि हमारा अभी मिड टर्म जो है वो मुरादाबाद कर रही है। 2021 में हम लोग एनुअल कॉन्फ्रेंस मेरठ में कर रहे हैं। 2021 का मिड टर्म का आज 22 में 2000 के अगर कोई मिड टर्म करना चाहता है तो हमें बता दे, क्योंकि नरेंद्र ने कल मथुरा के लिए कहा था। तो अगर सहारनपुर या एनी, क्योंकि हम छोटी प्लेसेस में मिड टर्म कर रहे हैं, जो भी हो, मऊ हो, सहारनपुर हो, बिजनौर हो, कोई भी अगर चाहता है तो 2022 का मिड टर्म वी कैन गिव टू देम। I don't think I should take much time because अब तुम लोगों का अगला सेशन होने वाला है। Thank you so much.
Thank you once again to the organizers and panelists and Bhavika.
Yeah, thank you so much मैम, किरण मैम। मुझे बहुत अच्छा लगा आपके साथ को मॉडरेट करके मैम। थैंक यू सो मच। थैंक यू, दिल से आभारी हूँ। थैंक यू उषा मैम, आप मुझे
थैंक यू।
ओके, थैंक यू।
Bhavika is a very मतलब अपकमिंग बहुत ही मेहनती लड़की है, वेरी इंटेलिजेंट।
नहीं मैम, पेशेंट आपने बोला था ना मैम के थ्रू एक पेशेंट देखने के लिए, तो मैम का दोबारा रिस्पॉन्स आया था तो मुझे बहुत
भाविका बोल रही है ना।
जी
थैंक यू। मुझे उस समय मैम दोबारा रिस्पॉन्स करके फोन किया था मैम, मुझे लगा भगवान, मुझे तो बस भगवान ने फोन किया।
यार भाविका, you took such a wonderful care of that patient. I am really grateful.
मैम उस समय किरण मैम नहीं थे तो किरण मैम का नहीं, तो मैं इनका स्पेशली ध्यान रखना। मैम आप परेशान नहीं हुई।
किरण बॉम्बे गई हुई थी ना बिटिया के पास।
मैंने इसको बोल दिया था, मैंने कहा बिल्कुल भी कुछ कहने की बात नहीं होनी चाहिए।
Thank you so much.
Thank you ma'am.
The next session.
Thank you ma'am.
We hand over the mic to organizers.
Yes,
thank you ma'am. Thank you for such an informative panel. Now I hand over Dr. Manisha Agrawal for the next panel discussion.
Usha ma'am, pranam. With due respect and from your permission, I will start the next session. So we come to the last panel of this 3 days long conference with none other than our own charming, hardworking Dr. Bharti Maheshwari on the topic which is the need of hour, that is safe abortion and contraception in difficult situation. Dr. Bharti Maheshwari, she is Professor HOD in Muzaffarnagar Medical College. She has done her diploma in IVF from Germany. She is chairperson of FOXY MTP committee and governing council member elect ICOG.
She is currently Joint Secretary UPCOG and VP Merit Society. She has delivered Kamini Rao Oration and uncountable number of talks, publications, and paper presentations, and what to say all about. Dr. Bharati, welcome. And your panelists are Dr. Divya Agrawal. She has done her fellowship in reproductive medicine from Germany. She is director of Ayushman Multi-Speciality Hospital. She is VP of Varanasi Society. Next panelist is Dr. Meenakshi Gupta. She is Secretary Gorakhpur Society and a fellow guide for Down DGO. She is attached to Annapurna Child and Maternity Home. Next, Dr. Mridula Sharma. She is Secretary Bareilly Society. She is Manata Assessee and recipient of President Appreciation Award and PSE Appreciation Award. She was Organizing Secretary Midterm UPCOG 2019. Dr. Ruchi Srivastava, alumni of Agra Medical College, received gold medal for obtaining maximum marks. She is senior faculty in Sharda Hospital and current founder secretary of Greater Noida Society. Dr. Nutan Upadhyay, जिनको हमने कल पतंग उड़ाते हुए बहुत देखा था. She is director of Santosh Hospital and president of Saranpur Society. She is chairperson of Mission Pink Health. Received Nari Shakti Champion Award. Dr. Poonam Yadav, associate professor, Ascent Medical College, Agra, recipient of Foxy Korean Award and at AICOG 2016. And Shri Prabhu Dayal Baveja Medal for Best Paper. She has also received Best Paper Award in 9th Suffolk Conference. And last but not the least, Dr. Amita Yadav. She is Associate Professor in MLN Medical College, Prayagraj, and member of Organizing Committee in UPCOG 18. She is recipient of APJ Abdul Kalam Award in Medical Excellency. With these galaxy of panelists, Dr. Bharati, this platform is all yours.
Thank you, Dr. Manisha. I am sharing my screen. And that is that, first of all, thanks that I am given this topic directly, that panel in the different condition on the safe abortions and contraceptions in difficult situations. First of all, thanks to all organizers that giving me opportunity, and thanks for the UPCOG and its founders that we are together at this platform for last 2 days and attending such a good academic programs. So you know that this is the Nari Suraksha that we have started from January in this sessions, and I am going to start my panel when I am whatever I have bought in this panel, the information by the last few years with active participation in some international WHO workshops. You can see the value clarifications and attitude information, and this is also a WHO workshop what I have gained the knowledge through that why we are not still able to handle the unsafe abortion. This is the MOHFW director Dr. Sumita Ghosh, that what our government are doing effort. And this is really our Foxy. So you can say that Merit Society's UP chapter, they together, Government of India, they are doing the efforts that how we have to overcome the hurdles that are coming to provide the safe abortion services. And you can see that how all obstetricians, they are involved when working on every aspect related to unsafe abortion. So now I start my panel with the gratitude and pranams to all my mentors, well-wishers. By their guidance only, I'm able to moderate this panel, and at this stage I am that I could gain such much of information and I can share with you. And from this prestigious platform, UP chapter of Obs and Gynae, which is the brainchild of Professor Padam Shri Usha Sharma Madam, that she is a live legend. And you know that I have seen the only few live legends. They are so approachable. You have talked and everyone have talked, and she is involved not only for the senior person, but every juniors and every doctor's activities, not only cultural, academics, and every issues. So we are blessed that we have a leader and we have a mentor like Padam Shri Usha Sharma Madam. So now I come to the issues, and I know that all of our time is very precious. So I will discuss only the clinical issues, what actually we obstetrician has to work in day-to-day practice. So why we are discussing this unsafe abortions again and again, and reason is that despite a liberal law, You know that in Asia, only India is the country has a liberal law and a so good law related to abortion, but still every day 10 women in India die as a relation of abortion-related causes. So it is really a very pathetic and worrisome situation. So now I come directly to the question. All panelists, they are very experienced and they are working actually. So Dr. Divya Agarwal, that what do you think that what is actually means of illegal and unsafe abortion? How common and why? And can we safe abortion providers also give services that is called illegal unknowingly? Dr. Divya.
Thank you, Dr. Bharti. Thank you for inviting me as a panelist. Any type of abortion or termination of the pregnancy, which is not unintended pregnancy, which is being done with all those personnel, medical professionals who do not have any type of necessary skill, or in the environment which does not have proper medical equipment or particular medical standard, then that is called as the that is called the unsafe abortions. And any type of abortion, there are certain type of the criteria which has been given according to the MTP Act 1971. And all these criteria, like who can perform the abortions and at which place the abortions can be done, and what are the gestation age in which the abortion can be done. There are certain criteria. That criteria has to be fulfilled. But when these criteria are not fulfilled, and then those type of abortions is called illegal abortion. In spite of having the law, we are still saying there are so many unsafe abortions which are being done in our country. And that is a very important factor because it is very life-threatening, and it is one of the third commonest cause for the maternal mortality rate. And in our country, we see it is responsible for about 8% of the maternal mortality rate is because of the unsafe abortions.
So, Dr. Divya, yeah, true. So that you have said that if any unsafe abortion in the unsafe conditions that either by a person who is lacking necessary skill or who is not eligible or by the logistics which are not proper. And besides that, if there is even we are safe eligible providers, we are not knowing or we are doing improper methods, no, without any counseling advice, unhygienic conditions, our sites are not approved, and even we are doing, but though we are eligible provider, but we are not caring properly, that is also illegal abortions. And status is, we all know that India, Dr. Alpesh also has said yesterday that we are the largest country, we are the largest number of abortions are occurring over the world. And 15 to 16 million pregnancies terminated every day in India. But unfortunately, third leading cause of maternal death is still we have unsafe abortion, and that is totally preventable according to WHO. And you already said that the MTP Act in 1971 was formed to decriminalize abortion. But for last so many years, we are still having the unsafe abortion. And now the current status is that National Population Policy, RCS2 and MTP Acts together, we are all looking after comprehensive abortion care. So why still unsafe abortion, Dr. Divya?
Various factors, especially the social factors. We see, especially in the lower socioeconomic group and in the rural areas, still the people are not aware that the abortion has been legalized. They can go to the centers and they can go for the abortion. And there are also various types of social stigma associated with the abortion, still, especially in cases of the unmarried women or in cases of the abortion due to pregnancy which has been caused by the rape. The people, because of the social stigma, they try to hide those abortions. And for that, they go, instead of getting to the safe options, they go to the unsafe options and untrained staff, and then they go for the abortion and resulting into so many complications. Then also there are economical factors also there. Sometimes the people, they don't know that the government sectors, they are having this all types of facilities, and they are go to the because they are poor, they don't know about the things, and they finally turn up into the unsafe abortions. There are still the scarcity of the centers which are giving the safe abortion of facilities, and also there's a lack of the proper trained personnel who can give the provide proper safe abortions.
So very true, and I want to share all of you that evidence says that in studies 80% of public, they don't know that abortion is legalized in our country. So they are going to unsafe abortion services, and beside that, of course, lack of access to safe abortion provider. And here, for last few years, the conflicts with PCP and DT Act. So providers, safe abortion providers, they are not in fact keen to give the abortion services. This is the WHO Geneva 2012 that it is dictated that access to safe abortion depends not only on the availability of services, like we all are trying to provide the services, we all are the providers, but also on the manner in which these services are delivered and the treatment of women within the clinical context. Services should be delivered in a way that respect women's dignity, guarantee her right to privacy, and is sensitive to her needs and perspective. So that women-centered services should be there. And I want to tell you that in studies, it is also highlighted that abortion services, those women who are getting in our country, only 20% in the government sectors and 80% in the private centers are illegal. So women, they don't want to come because of there are certain lackings that women's dignity and their safety, their privacy, they has to be taken care. And attention should be given to special need of the poor adolescent, as she has said, that there are sometimes financial constraints, sometimes the adolescents or unmarried girls, because of social stigma, they don't come to safe services provider and other vulnerable and marginalized women. So we have to take care of all these factors also in consideration if we want to decrease mortality due to unsafe abortion. So here the other again the thing is that anyone can answer is abortion is right for every woman. Legal status, Dr. Divya already has shared. So how we obstetricians are concerned. So I think this is already known that it is not, of course, right. Only in the certain conditions we can terminate, and we all know that what are these conditions. Beside these conditions, we cannot terminate the pregnancy, and even up to 20 weeks, and after 20 weeks, even in these conditions, we cannot terminate the pregnancy without court order. And sex selection is not an indication for termination pregnancy. Every place it should be highlighted and emphasized. So how we obstetricians are concerned, that is only that, of course, we should give abortion services. We have to give abortion services. This is our part. This is our field. So what we can do, why we are concerned, because we had to know about the law. We have to maintain the proper documentation. We have to improve our clinical skills. We have to improve our communication skills so that patient can follow our instructions. She can come and she can have a follow-up with us. And we have to give her proper follow-up. That's why these are the 4 acts we have to know. And in FOXY, different societies activities, UP chapters, I think I have gone to each and every members and all panelists. I have discussed with all of you in previous last so many activities about these. So even if we have some doubt, we have to know in detail of all these things. So and I want to share this thing that this is, I have picked this slides from the online internet, and for UP I want to tell you that I have seen such a beautiful online system development for the MTP services on the UP portal. So we should proud on UP, and here I have seen, you can see that online you can go, you can just click and you can approve your center, you can download your form, you can see that all forms are there on the UP's portal, and you can see that how you have to do all step MTP flowchart, form 1, form 2, form 3, these all are available on the online. And here the approval of private clinic for comprehensive abortion care, this is all on the UP portal. So you can get all these things from here. And this form, all of you should see it very clearly. Those who are attending, please take a picture of this form. This certificate of approval should be displayed at every center, every site where you are providing the abortion. Now, Dr. Ruchi, what is the approach if woman asks for termination of 8 weeks pregnancy? She called to your health worker and you that, madam, I have got, I was not knowing I have a irregular period. And yesterday I have done the test and it is 2 months I have no menses and it is pregnancy positive. And COVID, I am in the containment zone. So can you give me some medicine so that I can avoid to come to you? So Dr. Ruchi, what should be your approach? Dr. Ruchi? Can you hear?
Yes, ma'am. Thank you, ma'am, for the question.
Yeah.
This is kind of a telecommunication, maybe probably because of the corona pandemic. Otherwise, most of the time we call the patient to a center and we examine the patient and do the further management. So once she has called me, one time, if we are talking about the corona pandemic, then we have to, once the patient has to come to the center, that is to fill up the form. And if definitely she has said UPT positive and I cannot examine the patient, the ultrasound cannot be done at this moment. So once the patient has to come to the center so that I can examine her and make sure she is pregnant, it's intrauterine pregnancy, and we can manage her with the different methods. So the best method for 8 weeks pregnancy, if it is less than 9 weeks, we can go in for the medical management, and the forms have to be filled up, because the documentation is very important, whether it is a medical management or a surgical management. In both the cases, all the formalities have to be the same, except the given in the first one, and the second we are going to go in for the suction and evacuation. So the first and the foremost thing, as an obstetrician, we should remember that we have to respect the client's or the patient's right to confidentiality. We never discuss these cases unless we have to need some opinion from our seniors or our colleagues. So we have to go in. It's a very sensitive issue. All the documents, the patient has to be, a proper history has to be taken, and whenever we are taking the history, we have to counsel the patient as well. So when we are counseling, make sure that you counsel the patient, take out some time that the counseling is done in person with the patient, so that the relatives are not there. We can ask her certain details, whether the abortion is she wishes for the abortion, or she's being forced to get it done, and whether if certain issues are there, like the medical problems which she has not told to her in-laws, she can just share with the doctor, and it becomes more easy for us to manage these kind of patients later. The counseling part should be supportive and empathetic for the patient. We have to be all the time, even the staff should be supportive, and we have to respect the dignity, even if the patient is unmarried. It's not necessary all the time the patient, because these days we are getting a college girls who are pregnant and they come for the termination. They also have the right for this, if it is done under the legal consideration. So the do's list, I have already discussed that what we need to do. We have to take a proper history, including all the medical problems, the surgery done earlier, if basically on the uterus, the previous cesareans, previous abortions, whether she was using contraception, and the examination part is very important. These days we feel very comfortable that get ultrasound done, and then all the patients.
It is clear that here what the purpose of question that in the corona, can we first thing, can we deny the pregnancy that you come after the lockdown is over and all? So here I want to tell you that first day, yes, we can't deny even from the lockdown that abortion and contraception, they are essential services and should be continued first thing. Second thing, what you can do in the COVID as a special precaution for MTP, that you have given the clear message that MTP should be provided according to MTP Act, and all documentation has to be maintained even in corona or in lockdown. So at least one visit of the patient is important. Now what you can do that as like in the 8-week pregnancy, and first you have to confirm that pregnancy and confirm that gestation is clinically, or if it requires ultrasound. What we can do that we can plan that only in single visit we can do that after proper planning. On the telemedicine, the teleconsultation, we can do counseling, we can help her in taking the decision, and we can fix the visit, and we can know the corona. And if it is can call.
अच्छा फिर जा रहे हो हाँ किसके साथ
Second thing, already you have told that of course in every case you have to do all these things. That would be discussed in the further question in the detail, the proper clinical method. Like ultrasound, you have already said that it is not mandatory, but if it is required in the corona times, we want that women should stay at home. So we should try to do all things in the one visit. And this is what I want to highlight. The all cases should be all comprehensive abortion care. It should be according to that. It is not only that our purpose is only evacuation. Counseling, what Dr. Ruchi has said, that it will be discussed in further questions in next few minutes. And then clinical assessment, Dr. Ruchi already told. Pain management, this is also important part. We have to all have to think that what we have to plan for that particular patient to minimize the complication, and then evacuation, and then again managing complication if any, post-abortion counseling and post-abortion contraception. So today by this platform I want to give message to all of you that please adopt all components of comprehensive abortion care. Now Dr. Ruchi has told, can you give medical method from OPD if your OPD is not approved for MTP? Dr. Ruchi, can you give?
Ma'am, the approval, as you said in your earlier slides, that the Form B has to be there and it has to be displayed. That would be the best thing. Unless we are not going to fill up or we do not get the approval from the government, we cannot give medicines. Either anyway, we cannot do MTP this either by medical method or surgical method. Not even the medicines cannot be given unless we get it.
Yeah, here, Dr. Ruchi, I want to add one thing, that this slide what I am displaying, please all of you can take a picture of this, that if for the medicines if you are giving, then you can give from the OPD. If even OPD is not approved, have to display a affiliation certificate from some approved center, and it should be signed by the owner of that center, where you can manage the if evacuation is required at that center. So you can give medical methods from your OPD, which is not approved, but that of OPD should have a display of the established linkages to an approved site. So this is very clear. Second thing, all the records of MTP for medical methods, they have to be fulfilled, and I have I'm not going in detail, but I have shown many times, but please see that this is a Form C consent form, either by medical method or by surgical method. All consent has to be taken only on this Form C, and this is the opinion form. You can have a click of this, and this whole PPT I have shared to our panelists as well as organizer of this conference. Anyone wants that, they can take from them. And this is the Form 1 opinion form. You can see that this has to be filled even in the medical method, and this is the Form 2. This is the reporting forms to the CMO. This has to be sent by the owner of the hospital at the end of the month to the CMO. And this is the admission register. In the medical method, this has to be filled, as well in the surgical method, this is to be filled, and this is the most important document. And it is a confidential document, has to be kept with a proper almirah. No entry of MTP should be made beside that. In this admission register, beside that, MTP should not be made in case sheet, operation theory register, follow-up card or document or register other than admission register. You have to enroll, give certain number to your case, and that case number should be mentioned in all these places, and all details has to be mentioned in the admission register, and it need to be preserved for a period of 5 years. And here I want to tell you, I don't know about the logic and the non-logic, because we are not anyone to think about that. This is act, so we have to 100% follow it. And then this is the, for you, this is the summary, that mandatory documentation that Dr. Ruchi had to taken the form in the consent form, Form 1, Form 2, Form 3, these all has to be filled. And please remember that incomplete abortion, missed abortion, and if woman has taken the pills outside, she comes to you for the follow-up, then it doesn't come under the MTP purview. And here you are not supposed to fill all these forms. So my next questions to what is the anyone can take this question, that is PCPNDT affecting abortion services, or is PCPNDT and MTP Act is related? How we should handle these things? Anyone? Dr. Meenakshi, you want to say something? Or Dr. Amita?
Yeah.
Amita Yadav, yeah. So I want to tell you, all of you, that the essential protocol of safe and legal, these are the 4 points we all have to remembering that already should be performed by our MP who is eligible. We all know, we all obstetricians are eligible. Your site should be approved. That is the most important thing. Even you are tertiary, you have a very good hospitals with the OT services, but it has to take approval either till 12 weeks of termination or 20 weeks of termination. And if your center is approved for the 20 weeks termination, only then you can do MTP there. And third thing, that you have to fill all these documents I have already told, and the pregnancy should be within gestation limit approved by the law. So only when these things would be there, then you would be covered and you will be protected, and it will be said legal abortion. Otherwise it would be a criminal or illegal abortion. And now the one very important issue is PCNDT affect abortion, because many of us, they are very much scared about the PCPNDT monitoring and their MOs and authorities when they are coming to you. So here I want to tell you that PCPNDT, it is designed only for the prohibition of sex determination or sex selection before and after conception. It does not restrict access to safe abortion or require monitoring of abortion services. These lines I have taken from the government guidelines. At times it is assumed that most abortion are for sex selection, but this is untrue and not supported by any study. So PCPNDT and MTP Acts both have different objectives. And they are not, MTP is nothing to do with PCPNDT Act. So PCPNDT's abortion services delivery is to be monitored under the MTP Act, and PCPNDT Act does not regulate abortion services delivery rate issues. So whenever we are scared about the abortions and what can cause litigation, so whatever I have told you, that if you maintain the proper documentation and if you check that your site is approved, you are approved, then nothing to be worried about litigation. Now, what is the violation of MTP Act and punishment, Dr. Mridula Sharma, madam? Dr. Mridula Sharma is here, madam. Please.
Yeah, I'm here. I'm here. Thank you, Dr. Bharti Maheshwari and the organizers for giving me this opportunity. Well, with the passage of time, the laws are becoming very stringent and very strict, and any violation is not taken very lightly. The violations under MTP and the penalties that they attract is if the termination is being done by a person who is not a registered medical practitioner.
Please, all of you unmute your beside.
प्लीज अनम्यूट करिए. कोई बहुत हंस रहे हैं, क्या बात है? अनम्यूट करिए that group, please. Yes, continue.
So if the termination of pregnancy is by a person who is not a registered medical practitioner, then this attracts a very heavy penalty of minimum 2 years to 7 years of imprisonment. And these are supposed to be cognizable offense, which is where a police officer can arrest a doctor for violation without a written warrant also. The other one is if the termination, the place where the termination is being done is not recognized. Now here, if any person is the owner of a place that is not approved by the government and it is doing or allowing the termination in such places, even this is not acceptable, and this is a violation under the MTP Act. And this also attracts the similar kind of penalty, minimum 2 years of imprisonment up to the 7 years. And again, this is a cognizable offense. Then if there is a irregularity in the registered center, that is the certification of that center is not displayed. So we need to display the certificate, these certificates in a place where they are easily visible by the person visiting it. Then, as Madam Bharti said, that the record keeping has to be very updated. So the forms of certifying, the custody of these forms, and these maintenance of these admission registers, and whenever any authorities come to our place and they want to look at these records, then they should be easily available. We should not be saying it is in this almirah or that almirah, or that person is not here to give us those forms. So we have to be very careful about that. Then the admission register, all the entries in these admission registers of the hospital, they have to be, we have to be doing in an approved place. So if they are not done, then all these offenses under the Act are cognizable, they are non-bailable, and they are non-compoundable. Non-compoundable meaning that these are very serious offenses where the parties, they cannot compromise with each other. Once the offense has been registered, it is absolutely, the penalty will be levied on the person who ever breaches these penalties. Thank you.
Thank you, Dr. Mridula. But simultaneously, on the other half, I want to ask that, of course, I want to in fact say that this is, of course, these are the law and we have to follow it strictly. Otherwise, punishment is 2 to 7 years and some monetary punishment also there. But here, simultaneously, all these laws are for the woman's benefit as well as for doctor benefit. Sometimes if we are in some emergency situation, therefore, the saving of the women, we have to violate any law. So we can do, and we have to inform immediately to CMO. But in anyhow, women's life should not be in danger. So that is the message. That is the we have to know, we have to follow the laws, and we have to interpret it properly. But in emergencies, always we have to think first for the women's health. It is also mentioned in the law. So clinical methods of termination in the first trimester, Dr. Nutan Upadhyay, madam, that what you will like to, what are the options, and in current era, what is the preferable?
Good afternoon, ma'am. We are all enjoying the sessions. Yes, the methods of termination, we have, whether they are in the first trimester or second trimester. In the first trimester, we have the medical method, which can be easily given up to 9 weeks of pregnancy. Then we have the surgical method, that is the vacuum aspiration. And in the second trimester, we have the can we go back to, yes, it's surgical up to 20 weeks by dilatation and evacuation, by hysterectomy, or by medical methods as per the WHO protocols.
So very true, Dr. Nutan. So here we already discussed that for the medical method, these all documentation has to be completed. But please remember that if a woman has taken the medical pills, as it is in many cases, outside that doesn't come under the MTP purview. Here you record as you do the emergency cases. And for the medical method, Dr. Nutan, can you tell me that what are the important protocols and how it should be taken in short?
Yes, ma'am. We start with the day one when the 200 mg of mifepristone is administered orally, and on the day 3, 400 to 800 microgram of misoprostol is given, which can be given orally, vaginally, sublingually, or through the buccal route. And this patient has to be counseled about the pattern of bleeding. She has to be asked for follow-up, and on day 15 she has to be evaluated to see whether the medical abortion has been evacuated completely or not.
Very true, Dr. Nutan. And here I want to highlight that in the COVID, if you choose the medical method with the help of women, always women should be participated in selection of the method. Then please, you can minimize, instead of 3 visits, you can minimize it 1. But at least 1 visit is important, where you can do all consent, you can maintain all documentation. And otherwise also in the first visit, you have to do things what you have to ensure that you have to give contact address. If you can't give contact address or you can't give emergency facility, please, you are not supposed to give medical method. This is very clear message. And second thing, that every woman should be follow up with this follow-up card. And you can say that here it is the contact name of that facility or the person in emergency that is written here, and this is the all important symptoms after the misoprostols, and here you can say all 15 days total details. And this card can be shared on the WhatsApp. You can monitor it digitally. And on the 15th day, please remember that it is not necessary that ultrasound is done to confirm. You can do it clinically. If you are satisfied, then ask the woman after 6 weeks, if there is no period, she has to come again. And in the second visit, when third day you call the patient, please remember 2 things. First, when you give the misoprostol, observe for 4 to 6 hours, preferably at your place, and ask the patient if she doesn't bleed in 24 hours, she has to comes to your place, and then you rule out that topic or incomplete start, and then you manage accordingly. And keep filling the follow-up card. This is very important. And this is if the patient doesn't bleed within 24 hours of giving the misoprostol, then this is the important thing that you have to reevaluate. And again, you can start the contraceptive method from the second visit or when you give the misoprostol. And then, as Dr. Nutan has said, that in the first trimester, second very important method is that is surgical manual vacuum aspiration. This is a gold method, and I want to give message and the WHO and all that please accept and practice this method maximum. Reason is that even in Corona, it is now much advantageous because it needs less anesthesia, less analgesics, and less painful, and it is a very simple method. Least resources are required. So we all must develop the practice to do it in our clinic. Now, Dr. Divya, the question to you that 24 weeks pregnancy with congenital anomaly or Down syndrome come to you that she's having the previous 2 cesarean and now she wants treatment. So what would be your approach? What issues you have to be taken care of?
The 24-week pregnancy, according to this MTP Act 1971, the 24-week pregnancy if we have to go for the abortion, we have to take this medical board. We have to apply for the patient has to write a petition to the medical board at this stage, and if the permission is granted, then only she can go for the abortion. But according to the new amendment which has been done in 1920 March, then according to that, this abortion can be granted to the patient for 24 weeks also, but with the advice of the 2 doctors. And but if it is more than 24 weeks, then they have to apply a written petition and they have to take the grant from the medical board of the state.
So here, Dr. Divya, it is very clear that some of our obstetricians, they are confused. It is done till 24 weeks, so it is proposed, but not done till 24 weeks. If we have only 20-week gestation limit, if any woman, even the congenital anomaly is documented, that is not compatible with life, then even you have to take court permission. And Down syndromes, and you have to check whether there's the important issues, whether you need termination and what is the chances of what is the prognosis, and with the consent of the fetal medicine person's patient its own views and whether it is a screening method confirmation. So you have to see, and whatever the patient wants, you have to take all documentation. This is very important. And regarding that, if it is clear that you have to terminate this pregnancy, then there are clinical method. What clinical method you will like to do, Dr. Divya? And in the start, you tell special things.
Two types of method. The medical method of abortion, that is best. We should go for even in the scarred uterus. Now, the studies have shown that the medical method of termination is quite effective, but we have to be a little bit careful. We have to counsel the patient at every level that there is a risk of the abortions. There are complications. The chances are much more in the second trimester abortion than in compared to the first trimester abortion. There are the chances of the uterine rupture. There can be chances of the secondary hemorrhage. All these patients, all these things, and the counseling has to be done, and there should be proper documentation is very important. The written documentation and all the consent forms should be properly filled. The patient, the abortion, if we are going for the abortion, then it has to be indoor. The patient has to be admitted in the hospital. The patient should be given proper antibiotics. And if it is patient is RH negative, then they have to given this anti-D injections also. And we can go for this, either we can give the mifepristone, then followed by the misoprostol, or we can do this misoprostol. It could be given, which causes the cervical ripening. But the dose of this misoprostol, it has to be tailored. And the dose of the misoprostol should be a little bit lower than in compared to the non-scarred uterus. And it has to be repeated. It has to be repeated. It can be given either sublingually or the vaginally. And it has to be given every 3 to 4 hours. And maximum dose, we can go up to the 5 doses. And instead, there should always be a team of like nurses and the anesthetists and the proper the OT staff. They should always be ready, because though we are going for the medical termination of the pregnancy, but there are chances of the uterine, although the various studies have shown that the risk of the uterine rupture is quite low. It is around 0.4 to 0.6% only, even after the 2 previous abortions.
Very true, Dr. Divya, you have told very nicely. So I hear the message is first thing that all second trimester termination should be done as an indoor patient. This is I'm telling you the government guideline, Comprehensive Abortion Care 2018. That and prophylactic antibiotics and injection anti-D if required has to be given. Second, I want to share that second trimester abortion are a very small percentage of all abortion worldwide, but only 9 to 11%. But please remember that these are a cause of 2/3 of all major complications. So to avoid this, it is essential that all it is performed under MTP Act, because if it is not done, no one is coming to save you. And by appropriate method and taking proper documentation, and all these should be site eligibility criteria is very important. Whenever you are doing, please check whether that particular center, if it is private center, then it is approved or not, certificate is displayed there or not. Otherwise, it has to be done in all tertiary level healthcare centers. And second thing, as Dr. Divya has told, that medical method as per WHO protocol, this is a good method. And besides that, if you are evacuation, the cervical preparation is very important to minimize the complication. And misoprostol, it is an infant magic drug which is used either vaginally or sublingually 3 to 4 hours prior to procedures. And administration of misoprostol leads to contraction of uterus even before the actual process is initiated. So reducing the amount of blood loss, possibility of formation, and time taken for procedure. Because you know that Dr. Divya has told that it is really can lead to many complications in the second trimester. So we should prepare the cervix well. Then other questions come, that is scarred uterus. It is a previous to scarred. Can we use the misoprostol safely? Here I want to tell, yes, we can. There are many studies has been done where the dose is little bit decreased and time duration is increased. Like in the previous one, cesarean, the studies where the use the 400 milligram with 6 hours interval, and they have said that there is a no uterine rupture. Besides that, the one have used the misoprostol 200 milligram vaginally in 6 hours on the first day, and then double the dose on the second day. Then 90.3% success rate without any adverse outcome. And besides that, so misoprostol tailored use, and it is not contraindicated, but again, rule out the cesarean and scar pregnancy. Always use ultrasound, effective pain management, and close monitoring and follow-up. And complication has to be kept in mind, and all arrangements should be done to manage it properly. And Dr. Poonam Yadav, that patient we are managing, come to your OPD, that she tell you that she has taken some medical method outside, and she is having a heavy bleeding. What would be your approach in COVID era and documentation? What you have to say and treatment? Dr. Poonam Yadav.
Thank you, ma'am, for making the part of this panel. Such type of clinical scenarios are very common, and we frequently encounter these type of cases in our emergency. As this patient is in hemorrhagic shock and COVID era, but we won't deny that emergency treatment as patient is in hemorrhagic shock. We just quickly go for the clinical assessment and management. Usually, in this case, go side by side. As the patient is in shock, we just take in history in short and go for the little clinical examination just to evaluate pulse rate, her blood pressure, temperature, and consciousness level of the patient, and just to take a little view of that amount of blood loss, just to ensure what amount of blood she had already bled. Immediately, we have to ensure go for the management of hemorrhagic shock, which is in the lines of universal guidelines that we have to ensure her airway, check the vitals, pulse rate, blood pressure, respiratory rate, temperature, and consciousness level. Keep the patient warm with the use of blankets, and lateral position is preferred. No fluid by mouth until we make the diagnosis, and Foley's catheterization to measure her urine output. Immediately put 2 whiteboard cannulas and start with the crystalloid, that is normal saline or ringer lactate. We have to give around 1 liter in 15 to 20 minutes. The total amount of fluid that patient required in shock is around 3 times the estimated blood loss. Initially, we start with the crystalloid. Later, we reassess the patient after 15 to 20 minutes that what amount she may need more or not. And we start with the oxygen inhalation, that is 6 to 8 liters per minute, either by the nasal cannula or the mask. Along with that, firstly, we have to stabilize the patient and send the patient blood for lab investigation to assess the hemoglobin level, hematocrit, and blood cross-match analysis. After just initial stabilization of the patient, we just go to the detailed history and clinical examination of the patient. In history, we should make a special note of the gestational age and any amount of blood loss that she had, and any amount of pain, shoulder pain, any known drug allergy, or any intervention, whether she had already taken in other setup or not. Quickly, we move out to going to do the general examination, record the pulse rate and blood pressure, assess the general condition of the patient. What are her previous general conditions, so that we can make a decision on whether she further need blood transfusion or not. After quick systemic examination, we move on to the, here we look for any abdominal distension or any size of the uterus, any mass in the pelvis, tenderness, rebound tenderness, or any signs of inflammation. By manual examination, we just look for the amount of blood loss, whether she's pouring with the passage of clots, whether the linens are stains or not, and any pelvic mass, mass or tenderness, either there is presence of cervical tenderness. If we have facility of ultrasound in our setup, we must go for that to properly ensure the gestational age of the patient and site of the pregnancy. We must make the diagnosis, confirm the diagnosis of site, whether it is intrauterine pregnancy or we are dealing with the case of ectopic gestation. This is very important because the definitive management depends on that. After taking, if patient is having the intrauterine pregnancy, we must thoroughly evacuate her uterus. She might be a case of incomplete abortion, either by the vacuum aspiration or by instrument, whatever facility we have, and along with the uterotonic, uterine massage, or temporal. Along with that, give her prophylactic antibiotic, proper analgesic support in form of either paracetamol or pethidine. And we should take a note on RH status of the patient, that is or not. And history of tetanus toxoid vaccination, we should take from the patient whether she had taken tetanus toxoid immunization in past 5 to 10 years or not. If there is incomplete immunization in past few years, then we should give the dose of tetanus toxoid in present. After the initial assessment, then evacuation of the uterus. Then we reassess the general condition of the patient. If it after cessation of the blood loss, patient now might be improving. Then we settle the rate of fluid and oxygen level according to the status, and we have to make a decision whether patient needs blood transfusion or not. If patient is around bled around 20% blood, that patient don't need blood transfusion. At this blood transfusion has his own disadvantages. But if the patient had blood loss around more than 20 to 30% or rapid blood loss more than 50% of the blood volume, patient might need blood transfusion and we have to give there.
So, Doctor Poonam, we have to talk only the specific abortion because we all know about the general things and all. So you have told in very details each and every step that the patient, this is a very common condition. This is the most important cause of mortality and morbidity, hemorrhage. That's why we have given a much time to this condition. And as she has said that this is a very common, the patient come with the profuse bleeding. Here 2-3 points I want to highlight that whenever a patient comes, this is like an incomplete abortion, so it doesn't come under MPP purview. So don't worry about the documentation. Only think about the patient's clinical condition, and because this is a COVID and your center is not COVID identified center, and you think whether patient is COVID positive or not. So if patient come in such a condition, hemorrhage, that please you treat as a, if she is from containment zone, you can treat as a COVID positive and you take all precautions and send an investigation, but you can't deny the patient's emergency management. You have to do all emergency resuscitative management. Simultaneously, you have to find out what is the cause, whether it is incomplete or it is only it only needs some additional dose or it needs some surgical management. And simultaneously, as she has told, we have to identify and we have to manage accordingly. But we can't deny we have to manage emergency situation and we have to bring the patient in a stable thing. And then comes to this is another question, Dr. Ruchi, that 16-year girl, this is a very common that she comes to you, 16 girls with 7 weeks pregnancy, want termination. She come with some person, his known to his relative. So what would be your approach and what are the important issues in brief specific because we have limited time?
First of all, ma'am, any girl, we have to take the age proof, whether it is a school certificate, Aadhaar card. So we need to know the age of the patient. If at any time she is less than 18 years of age, in our case, she is just 16 years, according to the POCSO Act, she is unable to give the consent for the sexual intercourse. That is the reason. Therefore, this pregnant girl who's minor is a victim of sexual assault in any case, whether she is married or unmarried. So marital status does not stand anywhere here. The case has to be reported to the appropriate authorities, and it is our liability as a doctor. We have to treat the patient as well as we have to report according to NCPCR, that is the National Commission Protection for Child Right. They state that MLC, that is the medical legal certificate, is sufficient enough to give the consent for this to go in for the abortion for the girls who are under 18 years of age. Definitely we have to take the consent, we have to counsel, and the second thing comes with the consent. So who is responsible to give the consent for this girl? Because we all know unless 18 years she cannot give consent for herself. So any person who is taking care of this girl who's above the age of 18 years. So it, in a wider sense, MTP Act says that the guardian is not just the parent who is responsible to give the consent. Anyone who is above 18 years and is taking care and is taking the responsibility of this case, they can give the consent for this girl. We do not have to wait for the patient, or we do not have to wait for the police to come and take some action. Just the MLC is sufficient enough, and we have to proceed with the treatment of this girl.
We have a limited time, so you have told very clearly, because this is a warning situation. We have to report the police, but we are not supposed to make a FIR. We have to just report that we are doing such case come to us and we are going. So we should not hinder our clinical part or procedure part. And consent is important and age has to be proved in any case. And then come to the next question, Dr. Nutan, please, very specific 3 or 4 point post-abortal contraception, how you prefer to choose what contraception you should take and how you counsel and what is the message for the audience. Dr. Nutan, in short.
Yes, ma'am. Ideally, the counseling for contraception should start pre-abortion when the patient has first visited you. But after the abortion has been conducted, it should be a more reinforcing counseling. And we have to tell her all the available methods and how successful they are, right from temporary methods to permanent methods. We have to tell them that withdrawal and using any spermicide jelly are not effective, and almost 1 in 3 are going to fail. Almost 30% failure rate. So we have to tell them that even barrier contraception is not so effective. But and this is the time when patient has come on the third day that we can start her give her an injectable contraception, start her pill. We can also counsel her pre-abortion for IUCD insertion along with pre-abortion. And if she has completed her family, we can also counsel her for permanent family planning methods also. Side by side, if the husband is available, we can counsel the husband also for vasectomy also.
Poonam will tell about the different counseling. Important 3-4 points what you will cover in the pre-procedure counseling. Why pre-procedure counseling is important? So Poonam Yadav, why you will do before abortion counseling? Why not only after abortion?
Goal of counseling is we should help the woman in making the decision and assist in maintaining the woman's emotional and physical health throughout the procedure. Pre-procedure counseling should help the woman to decide the mode of termination of pregnancy and choose the method of termination, whether it is medical or surgical, and type of contraception that she may adopt after the procedure. There are wide range are available and quite acceptable on that. Pre-procedure counseling is also helpful to take the informed consent from the woman in a very comprehensive way for the healthcare provider, and it should be in the method should be detailed to the woman, each and every aspect and any type of complications she may face after that, and what proposed management for such complication that should be well informed to the woman before we are taking her to any procedure. If the woman could not agree for the contraception just after the procedure, we should not deny her medical termination of pregnancy, as she might go for any unsafe or illegal abortion. We should offer her for termination and try to counsel her for contraception after the procedure or even the follow-up visits.
Thank you, Dr. Poonam, and this is very important slide because this is one of important cause by Government of India mentioned that women are not coming to government or the state provider because they force for the contraception. So we can change our practice here that in pre-procedure counseling, we have to tell the woman all contraceptive options, and we have to tell that she can get pregnant again and she can get ovulation or fertility after 10 days, even a first trimester abortion. So she has to adopt immediately the contraceptive method. But even the woman doesn't accept, then please do not refuse MTP and assure the woman that she will not be refused MTP when she doesn't accept the contraceptive. This is a very important take-home message. And you continue to counsel again and record all documentation and assessment finding procedure and contraception or refusal to accept contraception and advice given during there. And this is the important post-abortal contraception counseling. And here, as Dr. Poonam Yadav and Dr. Ruchi both tell that all modern contraceptive methods can be safely provided immediately after the first trimester abortion. And IUCD, it is a very good and not associated with a high risk of expulsion, infection, or bleeding. Of course, laparoscopic ligation should be done only after the first trimester. Now, Dr. Amita, how one should help to select contraception offer for the woman in general, and when, by which method, in short?
Ma'am, with the woman, we have to start from the adolescent group in that cases, in which there we have to give them on the basis of cafeteria basis, and they can choose their contraception in their own. The first we have to with the adolescent group, we have to send we have to say them for the mini pills and OC pills are the best for them, and the transdermal patches and the vaginal rings, and also with the IUDs can be given if she is sexually active, and with the post-abortal also. As the chances of infection is more in IUCD, then we have to give the additional antibiotics for that.
So, Dr. Amita, here I want to just give a message to our audience that we have to tell about all contraceptive methods. Cafeteria approach, you can see that we have to efficacy, side effects, and how they have to come for the follow-up. And we should all use this. I mean, there are different guidelines. You can see in the book with NDC, WHO, and global handbooks, and there are many guidelines. And Government of India is also, and most commonly used, that is MECV, and this is latest 2015 update. It very clearly tell about these contraceptive methods in 1, 2, 3, 4 categories. And in one category, that these contraceptive methods can be given in that particular. And it is said that it cannot be given. So we have to choose, like when a woman is hypertensive, we have to see what MACVL criteria says. That if it is the IUCD, it is written 1, then we can give that. So it is very simple to use. It is so all of you, this is the sites, and you can use this by on-site on your phone, and you can keep a hard copy in your OPDs, and this should be used ideally. And then comes to Dr. Madhula Sharma, 40 years woman, hypertensive and diabetic. What are the optimal contraceptive methods for her? Dr. Madhula, you are here?
Yeah, I'm here.
Yeah.
In this particular woman who's a 40-year-old diabetic and hypertensive, so at this age, we believe that she has completed her family and she doesn't want any unwanted pregnancy. So we have to seek for a contraceptive method which is safe in her condition where she has hypertension and diabetes also. We have to see that it meets the WHO medical eligibility criteria. And here, there's not a single one method we can talk about, but we can only say that the criteria which are met, whether she's meeting the MEC criteria 1 or 2 or 3. So in the MEC criteria 1, if she's a simple hypertensive and a diabetic where she doesn't have any complications, then copper IUCDs are a better options which can be used without any reservations, and they have been recommended because they fall under the MEC criteria 1. Even the LNG IUDs have been preferred and have been advised in those patients who have good control of their hypertension and diabetes, and they do not have any associated complication, and they fall under the MEC category 2, which says that a condition when the advantage of using a method is generally outweighs the theoretical or the proven risks. So here we can go for it, but wherever she has vascular disease or she is not controlled, then of course these hormonal contraceptives have to be avoided.
Very true, Dr. Madhula. That here I want to share with all audiences that we have to maintain this MEC, and in this is that very clearly written that all ages that you can give the COC less than 40, very preferably POP, that all ages, implant at all ages, barriers at all ages, of course injections and IUDs at less than 18 and less than 20s with category 2. And otherwise can be given at all ages. And hypertension, as has told, is uncomplicated hypertension. IUDs, copper IUDs, they are the 1 category, and combined PCs, OCs, they are in the 3 categories. And same in the diabetes, if they are having only history of gestation diabetes, all options are available with the number 1 category. So, or if there is a diabetes with some complications, then of course copper IUD is the safest LNG IUD you can use. And if you have complications, then COC should be avoided. Then again, Dr. Nutan, if the woman having the abnormal uterine bleeding, high risk of endometrial cancer, how you choose a contraceptive method for that woman?
Again, ma'am, there are limited options for this, but yes, we have good options. We have to understand the take because patient is having abnormal uterine bleeding and she is at high risk of endometrial cancer. So we would like to keep our combined OC pills on the back side. If we have nothing else, if the patient is nothing else, only then we have to consider. Our first option would be even progesterone IUD, that is Mirena, that would be a first option. If she's having abnormal uterine bleeding, that will help her in controlling that also, and it will act as a contraceptive also. She can also be counseled for progesterone only pills, and more importantly, the injectable or implants, which has only the progesterone as the active ingredient. She can also be counseled for barrier contraception, and other than that, intrauterine IUDs directly may not be preferred because of the abnormal uterine bleeding pattern. So these will be the things, and combined OC pills because of her age also we should avoid in this age group. Ma'am, there's a disturbance. I can't hear you. Hello?
Dr. Amita Yadav is here.
Yes, ma'am.
Yes, what is the choice of contraception?
In heart disease, ma'am, we can say there is, we can tell them about the barrier method, the calendar method, and mainly COC, as there is level of estrogen is high, and it can lead to vascular thrombus. So we can prescribe her progesterone only pills, and mainly there is we can ask for the husband to do the vasectomy and the copper IUD with antibiotic coverage, Levonorgestrel IUCD like Marina, it's a very good for that heart disease patient. Progesterone only pills, we can say the trans-cervical approach of tubal ligation we can do in by his Sorry, ma'am, your voice is not clear.
Is it clear now?
Ma'am, there's a lot of disturbance somewhere from some.
Yeah, this is the disturbance. Right?
Can we just check where the disturbance is?
Am I audible?
बहुत बार मैंने कहा है कि सेंट्रली सबको म्यूट कर दिया करो, बहुत डिस्टरबेंस आ रहा है। भारती अभी कितनी देर है? भारती
जी
अभी कितनी देर है बेटा?
खत्म हो रहा है मैडम, एक स्लाइड है
बस ठीक है, ठीक है।
We should know that these are the conditions where all methods can be used, and here I want to give you just message that IUD, they are a safer mostly in many conditions except gestational trophoblastic disease and endometrial carcinoma where the hormonal methods are contraindicated. So you can use proper IUDs at the maximum places. So right choice is important, and Vision Family Planning 2020 for India is not just about providing to an additional 48 million users. But please remember, there is a version of 23.9 million births, 1 million infant deaths, and over 42,000 maternal deaths by 20. So this is the important issue, and I want to say that LAM and LAR, because IUD is important, and the lactational anemia method and postpartum IUCD, these are the two effective, affordable contraception that can change the India's situation, and this is a could be game changer for the shining India. So that's why this is my poster made by me, LAM and PPIUCD. So we all can emphasize in our condition. And the last take home message, because this is a very common condition, because we don't know if it is selective abortion or if it is
कौन बोल रहा है पीछे? बहुत मुश्किल कर दी भाई। I don't know who is continuously talking.
So, in the last, I just end that we all have to work together to provide the safe abortion services and contraceptions in the safe manner and prevent unsafe abortion. Through comprehensive sexuality education, access to affordable contraception, and safe abortion care. Thank you very much. You can have my mail ID, my phone number. By clicking this and any presentation, any documentation, you can ask for this. So thank
Madam,
you.
I want to add about the LAM. It's a lactation.
Please.
The lactational amenorrhea method is a modern temporary family planning method that has been developed as a tool to help and support both breastfeeding and family planning too. And LAM is family planning method which support improved breastfeeding, healthy child spacing, and child survival and women's health.
Thank you.
And for LARC, it's a long-acting reversible contraceptive defined as any method of contraception that does not have to use or applied for more than once a month. And these are the non-hormonal and hormonal contraceptive methods. IUCD.
Yes. I end my panel. And thank you very much for the panel, and now to the organizers. Thank you again for my all esteemed panelists.
Thank you, ma'am.
Thank you so much, ma'am.
It was a pleasure being in
all
the
panelists for
Thank
this
you, ma'am.
wonderful panel. Now I hand over this platform to Dr. Archana Sharma for valedictory.
Bharti, very nice. I must congratulate you.
Thank
on
you.
The panelists and the moderator.
Thank you, ma'am.
Thank you, ma'am. Thank you.
हाँ जी अर्चना।
डॉक्टर अर्चना शर्मा।
हाँ जी।
रीना है? हाँ रीना तो दिख गई। कीर्ति? कीर्ति?
हाँ जी मैडम बैठी हूँ।
अच्छा अच्छा। तू जरा छुपी ऊपर आजा, छुपी। हाँ अब ठीक है, अब ठीक है।
वो ऐसे रखा था, चार्ज हो रहा था वो।
हाँ यार मेरा तो चार्ज ना खत्म हो जाए ये डर लग रहा है। फोन पे कर रही हूँ ना, सवेरे से लगा हुआ है। हाँ चलो भाई, तेरे पास लिस्ट आ गई कीर्ति?
हाँ जी मैडम आ गई। अल्पना शुरू करेगी कि मैं ही शुरू कर दूं?
नहीं मैं शुरू कर रही हूँ।
अल्पना करेगी।
ओके ओके।
A very good afternoon
to one and all present here. Education is the most powerful weapon for changing the world. Madam, I am really happy to tell you that our conference registrations and viewership has crossed over 2000.
Wow! Very good. Very good, भाई.
Good, भाई. Very good.
भैया ये गाजियाबाद कीर्ति इन्हें तो एक स्पेशल प्राइज देना पड़ेगा गाजियाबाद को.
बिल्कुल बिल्कुल.
Thank you, madam. As we all are enjoying this prestigious UPCOG conference for last 3 days.
Yes.
So now it is the time to have a valedictory function. First of all, on behalf of UPCOG 2020, I welcome our motherly figure, beautiful, charming chief patron, Madam Padam Shri Professor Usha Sharma, madam. I welcome you, madam.
Thank you.
Now I take the privilege to welcome my teacher, very humble, helping personality. पता नहीं अभी इधर है कि नहीं है. Our UPCOG patron Professor Chandravati, madam.
चंद्रा जी को फोन करा था.
I welcome you, madam. I am really honored. मैडम है नहीं, मुझे लग रहा है.
हाँ है नहीं.
चंद्रावती मैडम नहीं है.
तुमने फोन किया था?
I am really honored to welcome. हाँ किया तो था मैडम.
अच्छा चलो ठीक है.
I am really honored to welcome our ever smiling, beautiful president, Dr. Reena Srivastava, madam.
Thank you, thank you.
Wonderful pillar of UPCOG, our own UPCOG secretary, Dr. Kirti Dubey, madam. Namaskar, madam.
Thank you. Namaste, namaste.
Our learned joint secretary and treasurer, Dr. Bharti Maheshwari, madam. Last but not the least, I also welcome our sweet and cute president-elect, Dr. Tarni Taneja, madam. मैडम सबको लिंक हमने भेजा था लेकिन आई डोंट नो.
तारनी दिख नहीं रही है, लॉक्ड इन तो है पर दिख नहीं रही है. हाँ
दिख नहीं रही है. For this valedictory function, I welcome and thank our esteemed faculty who is present over here. GOG's organizing team members, मुझे सीमा दिख रही है, डॉक्टर शशि दिख रही हैं, कई लोग दिख रहे हैं और अल्पना कंसल और अग्रवाल तो हमारे साथ नहीं है. All the winners, paper poster presentation, GOG's winners, delegates who all are present till the end of the conference. Thank and welcome you all. Now I will request Dr. Usha Sharma madam to shower her blessings, please.
Okay. आज शायद अर्चना वर्मा नहीं आ पाई है. सुनाई पड़ रहा है?
हाँ जी मैडम.
हाँ मैडम.
सुनाई पड़ रहा है.
अर्चना शर्मा, अल्पना अग्रवाल, अल्पना कंसल, सीमा वार्ष्णी और जितने भी टीम के ऑर्गेनाइजर हैं सबको बहुत 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 बधाई. मुझे इतनी खुशी हुई ये सुनकर कि करीब 140 पेपर और पोस्टर्स आए थे जो रियली इट इज ए क्रेडिटेबल थिंग यूपीसीओजी कॉन्फ्रेंस. और अभी अभी अर्चना ने बताया कि 2000 से ज्यादा डेलीगेट्स आज कल और परसों में हमारे पास थे. I can't express I can say my pleasure, my happiness that I actually never expected that in this virtual digital conference we can have so many delegates. It is all the efforts of the organizers, especially Archana, Alpana Square and Archana Square, that they were ringing up every time to everyone that there was so much of participation of many societies who are not even the members of UPCOG in the executive committee. So it was a real pleasure. मैं क्या बताऊं, जितना तुम लोगों को धन्यवाद दूं उतना कम है और जितना तुम्हें बधाई दूं वो बहुत कम है. मैं बस ये कह सकती हूँ रीना और कीर्ति से जो मेरे दाएं और बाएं हाथ हैं और भारती महेश्वरी से कि कुछ न कोई मेरी तरफ से एक एक्स्ट्रा प्राइज इन लोगों के लिए जरूर बनवा दो जो मैं इन लोगों को भेज सकूं. थैंक यू वेरी मच. मैं दिल से तुम सबको बहुत बहुत बधाई, बहुत बहुत प्यार और बहुत बहुत अफेक्शन उसके साथ मैं ये सोचती हूँ कि हम अपना वैलिडिटी का प्रोग्राम शुरू करें. और कीर्ति मेरे ख्याल से रीना अगर 2 शब्द करना चाहे तो बहुत अच्छा रहेगा. बट रियली तुम लोगों ने एक रिकॉर्ड बना के दिया है और मैं सोचती हूँ आगे आने वाली जो यूपीसीओजी की कॉन्फ्रेंसेज होंगी उनके लिए थोड़ी सी मुसीबत खड़ी कर दी है, क्योंकि सबको लगेगा कि अरे भाई इतने ही हम भी मेंबर्स रखे कि इतने लोगों ने ज्वाइन किया। Once again, I express my gratitude. I express my thanks. I express my all love and affection for the whole Ghaziabad organizing team. वो कहते हैं ना, किसका नाम लूं और किसको भूल जाऊं, सब एक से एक बढ़कर हैं। और जिस तरीके से तुम लोगों ने एकजुट होकर ये काम किया है वो बहुत ही सराहनीय है। बहुत बहुत धन्यवाद। अब मैं सोचती हूँ कि रीना कुछ 2 शब्द कहे, तब फिर उसके बाद सेक्रेटरी साहिबा को मैं प्लेटफॉर्म दे दूं। अर्चना, रीना है ना?
हाँ हाँ डॉक्टर रीना है। अनम्यूट कर लीजिए अपने को। डॉक्टर रीना अनम्यूट कर लीजिए अपने को, अनम्यूट।
रीना कहाँ है?
हाँ मैं हूँ मैडम।
है तो बोल ना।
मैं बोल रही थी, म्यूट हो जा रहा था। So first of all, I would like to thank you, madam, for your motherly guardianship and mentorship to all the UP chapter members and all the societies. Your throughout presence for last 3 days is commendable, and everybody is taking inspiration from you. We too cannot fall back. We have to follow you, and we have to be active like you to keep the UP chapter alive. We'll be doing our best for UP chapter. And first of all, I would like to say that the Ghaziabad team, Archana Verma, Vinita, Alpana Agarwal, Alpana Kansal, and Archana Sharma, they have worked very, very hard, and they have been busy throughout. I think they have not taken care of their looks also, that used to be there in every conference. They were so very busy, but then commendable work they have been doing, and you need a big round of applause for all this. We can't pat you from this virtual platform, but take it as patted, and definitely special prize will be there for you in the next conference. We will be giving you.
Thank you, ma'am.
Yes, because the people who have जी मैडम।
रीना, सचने संवरने की तो उसको जरूरत है जो सुंदर ना हो। ये तो सबके सब इतने सुंदर
मैंने
हैं।
इसलिए कहा कि every conference everybody these people have not taken care of it, and they have been working throughout this. This I'm observing for the last 3 days. Anybody who is there is coming and sitting and doing the work properly. That is definitely commendable. A woman who is not taking care of the makeup, that is very, very important. So thank you all, and you have been very, very good in organizing this conference. We'll remember it forever, and that is going to be a landmark for the coming conferences also. And what I think, day to day, day by day, UPCUG is growing, and we are happy, madam is happy, and all the salvas are happy.
Yes.
I say my gratitude to Dr. Madam Gina is somewhere here in the sitting over here. All the past presidents have brought the UPs. All the presidents of the past have brought UP chapter forward, and this is a lesson for all of us to work for it, whether be on chair or not on chair. So we are there to work for UPCUG. Long live UPCUG. Thank you, madam.
Thank you. Very good.
I think Kirti should take over.
ओके
अर्चना
हाँ जी मैडम, मैं तो थैंक यू दिल से है। अब आप सब लोगों ने इतना थैंक यू कर दिया है कि वो रेपिटेशन मैं नहीं कर पाऊंगी, बट वो दिल जो है ना, वो थैंक यू से ही भरा हुआ है। डॉक्टर अर्चना शर्मा के लिए, डॉक्टर अल्पना अग्रवाल के लिए, डॉक्टर अल्पना कंसल के लिए, डॉक्टर अर्चना वर्मा के लिए, और पूरी गाजियाबाद टीम के लिए। So following the tradition now, it is time we acknowledge and encourage the talent and hard work of our postgraduates for their academic excellence in paper presentations of their research work and also the poster presentations.
So I would request Honorable Chief Patron Padma Shri Dr. Usha Sharma to honor the postgraduates with the medals and certificates.
कैसे करेंगे?
मैडम आप ना ये लोग को मैंने कहा है कि ये फोटोग्राफ पुट करेंगे उस लड़की की।
हाँ।
और हाँ, और आप बस बोल दीजिएगा मैडम।
ओके ओके,
हाँ बस बोल दीजिएगा। तो मैं ऐसे शुरू कर रही हूँ। सबसे पहले वो जब मैं कह रही हूँ कि मैडम उनकी एकेडमिक एक्सीलेंस, ये बेसिकली कॉन्फ्रेंस पोस्ट ग्रेजुएट्स के लिए हम लोग करते हैं, तो मैं सबसे पहले पोस्ट ग्रेजुएट्स के ही अवार्ड से शुरू करूंगी।
बिल्कुल।
तो पोस्ट ग्रेजुएट्स के लिए मैडम वी हैव दोस पोस्टर दीज पेपर प्रेजेंटेशंस, and इसमें the award of in the name of Dr. Usha Sharma for the best paper presentation goes to Swati Shukla of Subharti Medical College.
ये तो दूसरा नाम आया।
अच्छा डॉक्टर अर्चना, मैं क्या अच्छा सीनियर कैटेगरी से शुरू करूं? अच्छा मैडम सीनियर शुरू कर देती हूँ।
दुष्यंत जी जरा नीचे जाइए।
कोई बात नहीं, शुरू कर देती हूँ, कोई बात।
यस कंटिन्यू कीर्ति, सीनियर कैटेगरी से शुरू करते हैं।
ओके, so we have few awards in the senior category, we have and few awards in the postgraduate category.
Yes.
So in the senior category, madam, we have a Dr. H.S. Maheshwari Gold Medal for the best clinical research paper presented by the young faculty.
पीछे से कोई ना बोलिए। I will request everyone, मेल वॉइस आ रही है बहुत, प्लीज चुप हो जाइए। हाँ कीर्ति प्लीज।
Best clinical research paper for less than 40 years.
Internet connection is unstable,
faculty, and this goes to Dr. Vaibhav Kanti of Sefai. अरे she is not Vaibhav Kanti, she is Shikha Singh.
हमारी वैभव है ना,
Vaibhav Kanti.
Vaibhav Kanti
from Sefai Medical College. Madam, she has been a student of LLRM. Now she is an associate professor.
तभी तो खुश हो रही है, तभी तो खुश हो रही है।
हाँ जी।
Congratulations, Vaibhav Kanti. Do you have her photograph?
Vaibhav, where are you?
नहीं,
पता नहीं होगा, शायद इन्फॉर्म नहीं।
Congratulations, Vaibhav Kanti. आगे चलो।
And GOGS, actually, Madam, Ghaziabad Organizing Society is overwhelmed by the young faculty presentations. And so they want to give prizes to also those faculty who had presented papers. And
more than 40, more than 40.
Okay, I would say young faculty. I didn't say less than 40.
अरे यार तो more than 40 young है।
Okay.
हमने क्या कहो?
Okay, so this young faculty and this award goes to Dr. Ritu Khanna.
Oh, Ritu. Congratulations. I was really proud कि गाजियाबाद की टीम तुम्हारे इस पेपर प्रेजेंटेशन से इतनी ज्यादा प्रभावित हुई कि मुझे रात में फोन करती है, मैडम बताइए क्या करें। उन्होंने बहुत बढ़िया बोला, वो अंडर 40 में नहीं आती। तो मैंने कहा जब तुमको इतना अच्छा लगा है तो फिर क्या बात है, give her some prize. So Ritu, congratulations. We all will appreciate your work and your talent.
Thank you so much,
Dr. Ritu.
Thank you so much, Dr. Bharti.
Okay.
Okay, madam. Then of course we next one. Acha. So madam, actually the posters were also made by the seniors. It's not only the postgraduates made the posters, but the seniors also participated in them. And so Ghaziabad Society wants to encourage and applaud the seniors. And this is Dr. Meenal Jain who gets a first prize for poster presentation.
Meenal kahan se hai?
Meenal Jain. She is from which place?
Agra.
I think she's from Ghaziabad.
SM Medical College, Agra. Medical College, Agra.
Yeah.
Okay. Meenal, congratulations. God bless you.
And the second prize.
मैं तो आधी आगरा की हूँ और आधी मेरठ की हूँ. हालांकि जिंदगी मेरठ की गुजारी पर पढ़ी आगरा की हूँ.
मैम आप पूरी आगरा की हैं. मेरठ तो बहुत बाद में
कह रहे हैं पूरी आगरा को.
So the second prize also goes to Agra.
Oh.
Dr. Niharika Malhotra for her poster presentation.
Oh, Niharika, congratulations. Already you are the person who is looking after Young Talent Committee, and I really appreciate your hard work and ever smiling face. Congratulations, and I really wish you the best and very, very bright future.
Congratulations, Niharika. So now we come to Madam postgraduates. So in the postgraduate category, let me see what they are putting up. They put up Dr. Chandravati's gold medal for best paper presentation, and she is Parul Sharma from which medical college?
कहाँ की है?
They have not written here.
Archana, कहाँ की है Parul Sharma?
She's from KGMU, ma'am.
Okay.
So give her a big clap.
तुम KGMU की नहीं, हम सबकी हो. बहुत 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 बधाई.
And the next paper presentation prize, Madam Dr. Usha Sharma gold medal goes to Swati Shukla from Subharti Medical College.
Oh, Swati, great. Congratulations. ईश्वर तुम्हें और आगे बढ़ाए. Wish you all the best.
And Dr. Naval Kishore gold medal, this goes to Shiny Mathur from Santosh Medical College.
Okay. मतलब गाजियाबाद फिर आ गया. Very good. Congratulations. God bless you.
बहुत प्रिपेयर कराया मैडम कि नाक मत कटवाना, अच्छे से बोलना.
हाँ, तभी बहुत अच्छा करा.
अल्पना बोली.
Krishna Mukherjee gold medal for best paper goes to Astha Gupta from KGMU.
Astha, congratulations. इस समय चंद्रा जी भी होती तो बहुत अच्छा लगता. मैं तुम्हें बहुत बहुत बधाई देती हूँ. Wish you all the best.
Then CS Dawn gold medal for the best paper presentation goes to Disha Bansal from Rohelkhand Medical College.
Oh, Disha, congratulations. तुम सब बच्चों ने इतना अच्छा किया है कि ये अर्चना और सीमा सब लोग बड़े खुश हो रहे हैं. पर मुझे बड़ा अच्छा लग रहा है. Especially अर्चना, अल्पना, I can tell you, ये तुम लोगों ने जो presentations बनाए हैं ना, मैं तो सोच रही तुम list project करती जाओगी, but it is really very good. Once again, Disha, I congratulate you and wish you all the best.
Ji, madam. But Ghaziabad society also wants to encourage these postgraduates.
Yes,
and so
yes.
They are also going to give them 2 medals. One is for Mrinalini from GSVM. Mrinalini, I think it's not her name. Is her name there? Yes,
Mrinalini.
Yes, she's from GSVM Medical College, Kanpur. She gets a consolation prize for the paper presentation.
ये कानपुर से है. Mrinalini, congratulations. Wish you a very, very bright future. तुम बच्चों ऐसे ही आगे बढ़ो तो हम सबका कहते हैं ना सम्मान और ऊंचा होता जाएगा.
And another prize goes to Shifali Agarwal for her paper presentation, and she's from KGMC Medical College.
Okay.
This is another one.
Congratulations, Shifali. Congratulations. God bless you.
Now we would come to the poster presentations, madam. This was as regards paper. So in the poster presentation category for the postgraduates, we have Samiksha Kumari from Allahabad who gets Dr. Veena Mathur gold medal for best poster presentation.
Very good. Samiksha, congratulations. बहुत बहुत बधाई. Wish you a very, very bright future.
Then Ghaziabad Society, of course, बहुत बड़े दिल के लोग हैं, madam. They have special prize, 2 more special prizes for poster, and this will be given to Suraya Anjum from Santosh Medical College.
Oh, good. Suraya, congratulations. बहुत बहुत बधाई बच्चों. मुझे बड़ी खुशी है कि तुम उस सोसाइटी के जगह को बिलोंग करती हो जिनका दिल वाकई बहुत बड़ा है. तभी तो 2000 डेलीगेट आ गए. अगर दिल नहीं होता तो कैसे 2000 आ जाते. बेटा. और
Third prize for the poster presentation goes to Yati Tiwari from Rohelkhand Medical College.
Congratulations, Yati. God bless you. Keep it up.
Hello, Kirti.
Hello, who's there? I can't see. Oh, Anshu ji, namaste.
Namaste.
How are you? You had been sleeping on the bed with your earphones. I could see.
Thank you.
Could see. I thought you're not well.
Yes. I'm not well. So that's why I was lying down and listening.
मैं समझ गई थी. May you have good health and recover soon.
Okay, Kirti. I'm feeling very nice to see you here as secretary.
Madam, she is my senior from GSVM Medical College, a gynecologist practicing there at Kanpur.
Very
and she
good.
Was not well. I saw her that she was on the bed with her earphones and with closed eyes.
May God bless you. Quick recovery.
Thank you, madam.
Okay, beta. Thank you.
Madam, may I interrupt for a second? हम लोगों ने अपने गॉक्सियंस के लिए भी कुछ प्राइजेस अनाउंस किए थे.
Sure.
यार एक बात बता दे अल्पना, जरा ये बता दे तूने पैसा कैसे इकट्ठा किया? और तुम्हारा इवेंट मैनेजर कौन था? भाई I give him all the credit. हर की अलग अलग उसने लिंक बना दी, हर के हॉल के उसने अलग अलग कर दिए. And no, it went off so smoothly. मैंने तो कभी सपने में भी नहीं सोचा था.
डॉक्टर अल्पना शेयर करिएगा इस आदमी का नाम.
बार पूछती थी कौन इवेंट मैनेजर है, कौन है. मैंने कहा कोई फार्मास्यूटिकल वाला है.
बताएंगे.
अरे हमारे बच्चे हैं.
मैडम हम लोगों ने सारे गॉक्सियंस को इन्वॉल्व करने के लिए, गियर अप और चीयर अप करने के लिए.
यस, तुमने जो इवनिंग में क्विज रखा. यस.
हाँ, तो रोज शाम को हम उन्हें एक क्वेश्चन देते थे और जो सबसे पहले आंसर करता था उसके लिए हमने एक छोटा सा प्राइज रखा था.
वो कहते हैं ना कि तुम्हें आता है कि कैसे कान पकड़ के सबको बुलाया जाए और इन्वॉल्व करा जाए. सबको सिखा दो.
तो मैम हमारे एक लिस्ट है, आप कहें तो क्वेश्चंस के साथ लिस्ट बताऊं या ऐसे ही बता देती हूँ?
अगर कितने क्वेश्चंस हैं?
8-9 है मैम.
तो कोई बात नहीं, क्वेश्चन भी बता दो, क्या फर्क पड़ता है.
हमने पहला पूछा था विच ऑफ द फॉलोइंग सिटी इज नोन एज गेटवे ऑफ यूपी.
अच्छा.
आंसर वाज गाजियाबाद. एंड डॉक्टर कीर्ति वाज द विनर ऑफ दैट क्वेश्चन.
Oh, good.
मैडम हमारी इंग्लिश टू एडोलेसेंट कैप्सूल की वो कोऑर्डिनेटर भी थी.
Okay, congratulations.
Next question था all are risks of premature delivery except HDP, chickenpox, previous preterm and obesity.
ये कौन बनेगा करोड़पति वाला कर लिया.
So Dr. Vijayalakshmi gave the right answer, chickenpox.
Oh, good. Congrats, Vijay.
Third question was Bartholin gland lies in relation to vaginal orifice, anterolateral, posterolateral, anterior, posterior. And Dr. Anjana Sabharwal gave the right answer, anterolateral.
Congrats, Anjana.
Sorry, posterolateral.
Posterolateral.
Then who is the founder and CEO of Save Life Foundation? This was a difficult question. Mr. Piyush Tiwari is the right answer and Paridhi gave the right answer.
Congrats.
Another question was all are category C drugs in pregnancy except aspirin, hydroxychloroquine, cyclophosphamide, and tacrolimus. So, cyclophosphamide was the right answer, and Dr. Sarita Goel gave the right answer.
Good. Congrats, Sarita. Congrats.
Name of the scientist who discovered that plants do have life, they feel pain also. So Dr. J.C. Bose was the right answer, and Dr. Saranju gave the right answer.
Oh, good. Congrats, Jyoti and Taranju.
Who has designed new ₹20 coin recently?
Yes.
तो थोड़ा सा लोगों को मेहनत तो लगी, फटाफट गूगल किया और आंसर पता लगाया. स्वप्निल.
Smart world में smart people with smartphones.
एक और क्वेश्चन पूछा था कि which is true regarding RU 486. It prevents sterilization. It has affinity for estrogen receptors. It is a single dose of estrogen, prevents pregnancy in 90% of patients, and it causes delayed menstruation. So, Dr. Aparna gave the right answer, and Dr. Aparna also got the bumper prize क्योंकि उन्होंने most of the questions सबसे पहले आंसर किए थे.
Oh, congrats, Dr. Aparna. क्या वो यहाँ है?
Is she here?
Dr. Aparna
में होंगी.
अच्छा. Okay. भाई बहुत बढ़िया. सच मैं तो बस ये समझ में नहीं आ रहा है मेरे कि मैं तुम लोगों की कैसे तारीफ करूं, क्या करूं जो तुम लोगों को बहुत सेटिस्फेक्शन दे. और आज की रात जाके बहुत अच्छी तरह सोना. अर्चना, आज तो तुझे अस्पताल में भी नहीं जाना है और अब यहाँ का काम भी खत्म हो उसका. अल्पना स्क्वायर और अर्चना शर्मा, आज तुम लोग रात में बड़ी अच्छे से सोना, क्योंकि शायद जो भी तुमने किया है वो काबिले तारीफ है. तुम सब बधाई के पात्र हो. और ये मैं इतने दिल से कह रही हूँ कि शायद अगर तुम मेरे सामने होती तो मैं तुम सबको गले लगा के बहुत
ऐसे प्यार भी करते मैडम. इन लोग को एक देते पुछ.
अब रीना
नहीं मैडम ऐसे कर दीजिए.
अब रीना और कीर्ति का टेस्ट है कि मेरे इन बच्चों के लिए क्या तुम स्पेशल प्राइज बनवाओगी. जो हम अगली यूपीसीओजी में जब मेरठ में करेंगे तो भगवान ने चाहा कि दैट में बी फिजिकल कॉन्फ्रेंस, तो हम इन लोग चारों लोगों को वहां पे फेलिसिटेट करेंगे.
बिल्कुल श्योर
मैडम.
बहुत बढ़िया.
मैम अब मैं दो शब्द मैं भी कहना चाहूंगी थैंक्स के.
जरूर
अर्चना जी को छोड़ेंगे नहीं, इनसे ट्रीट लेकर रहेंगे.
जरूर.
मैम मैं शुरू करती हूँ, कुछ इन पंक्तियों से शुरू करती हूँ. आप लोगों का साथ पाकर मन मुदित हो गया. आप लोगों के स्नेह से अंतर्गत मन पुलकित हो गया. बनते बिगड़ते हैं जीवन पथ पर रिश्ते बहुत, मगर आप लोगों का साथ और प्यार पाकर रास्ता सरल हो गया.
Wow.
Thank you.
Thanks to UPCOG office bearers, Dr. Usha Sharma ma'am, Chief Patron UPCOG, Dr. Chandravati ma'am, Patron UPCOG, President Dr. Reena Srivastav ma'am, President-elect Dr. Tani Taneja ma'am, Secretary Dr. Kirti Dubey ma'am, Joint Secretary and Treasurer Dr. Bharti Maheshwari ma'am. We were troubling them day and night since the last 1.5 months, but their help and support was available round the clock. Thanks to all the delegates who have logged in. Thanks to all the speakers and who made the sessions enjoyable, and all the chairs who were available for us all the time. Thanks to Guvic Pharma, ma'am note kariyega. Thanks to Guvic Pharma for providing us the platform, and Mr. Dushyant, Ritu, and all the team for giving us continuous IT support. And thanks to Zydus, Torrent, Abbott, GSK Vaccine for their financial support. Also Mankind Pharma. And last but not the least, thanks to all the Goxians who took part as coordinators and chairs in all the sessions and make it all this successful. And least but not the last, Dr. Manisha, Dr. Nilima, Dr. Shashi Arora ma'am, Dr. Shanli Agarwal, special thanks to you. And Seema Vashne for making the inauguration so beautiful. And
बहुत बढ़िया थी मैम,
for
बहुत
the
बढ़िया
cultural program. And I should not forget Dr. Archana Verma ma'am, Dr. Vinita Divakar for their guidance and support throughout. Dr. Archana Sharma ji, Dr. thanks for keeping faith in me. मैम अभी क्या हुआ है, तीनों कंप्यूटर पे इसलिए बैठे हुए हैं क्योंकि नेट का कनेक्शन बहुत स्लो हो गया. So we have joined with hotspot.
तुम तीनों बहुत प्यारी लग रही हो, तीन देवियों की तरह लग रही हो सुना.
Alpana keeping faith in me and making part of this team. And long live UPCOG. Hip hip.
Hooray!
Three cheers for God.
Alpana, I would like to say a few words for cultural program people. Vinita, Mittal, Meenakshi and Nupur. They have conducted it and they have organized it very nicely. Nice programs were there.
Thank you, ma'am. Thank you.
For making us a part of it. Thank you very much.
Thank you.
Ritu madam, मेरा भी कप अभी ड्यू है. We'll take it in merit last year का.
तुम्हारा तो है वो, मैंने कीर्ति वो तुमने कीर्ति नहीं रखी.
डॉक्टर रितु की ना.
हाँ, मेरठ में लेंगे मैडम.
हाँ ठीक है,
बनारस भिजवा दूंगी.
नहीं, मेरठ में ले लेंगे मैडम.
मैंने कीर्ति से कहा था
नहीं मैडम, एक्चुअली
क्या फोटो दिखा देना.
अच्छा डॉक्टर रितु को कल दिखा दूंगी.
वो यूपीसीओजी भी एक मेमोरेबल इवेंट था.
बहुत memorable. And this one was also so memorable. They worked so hard. Congratulations.
I give credit especially because it was digital virtual.
Very nice.
Physically तो फिर भी तुम दौड़ भाग के सब काम कर लो, इसमें तो समझ में नहीं आता है. मैं तो बड़ी घबरा रही थी पर मेरा मन नहीं कर रहा कि खत्म हो ये कॉन्फ्रेंस.
डॉक्टर रितु, आपकी शील्ड हम मेरठ की वैलिडिक्ट्री में देंगे. ऐसे भिजवाएंगे तो मजा नहीं आएगा. देंगे मेरठ की वैलिडिक्ट्री में.
पर कीर्ति रितु को भी प्राइज देना है.
जी मैडम,
रितु को भी स्पेशल प्राइज देना है.
मैडम अपने
बनारस को कॉपी बना दिया था.
अपने वैलिडिक्ट्री में देंगे, ऐसे नहीं कोरियर से नहीं मिलेंगे, मजा नहीं आएगा.
हाँ जी, वहीं आके करेंगे.
बिल्कुल बिल्कुल.
Thank you so much.
Okay.
So all the best. God bless you.
Thank you so much.
Good night. Thank you all.
और मैं कहना चाहूंगी, बाय बाय. सब लोग एक दूसरे की कमियों को नजरअंदाज करो. कभी कभी किसी से कोई गलतियां हो जाती हैं, उसको पकड़ के मत बैठो, क्योंकि हम सब आपस में एक, कभी किसी के दिल में किसी के लिए बुराई नहीं है, सब को एक अच्छाई के रूप में लेते हैं. तो आई विल रिक्वेस्ट यू, अगर किसी को लगे कि किसी ने गलती करी है तो आई टेक द रिस्पॉन्सिबिलिटी ऑफ दैट गलती, पर प्लीज सारी गलतियों को हमेशा नजरअंदाज करो और हमेशा पॉजिटिव सोचो, क्योंकि हमें आगे बढ़ना है, हमको पीछे नहीं जाना है. मेरा बिल्कुल मन नहीं कर रहा अल्पना स्क्वायर अर्चना स्क्वायर कि मैं अब खत्म हो. ये क्यों खत्म कर दी तुमने कॉन्फ्रेंस?
वो सब थक गई थी मैडम, इसलिए खत्म कर दिया.
इसीलिए रोल मॉडल हो आप, इसीलिए रोल मॉडल हो. हम सब आपको फॉलो करना चाहते हैं.
We want to have a stamina like yours.
Yes, that is definitely creditable.
बिल्कुल, you are an inspiration to all of us. You are a role model. We all. I have been following you.
Okay. God bless you. I really congratulate all the winners. और जो विनर्स नहीं है कोई बात नहीं, हर आदमी जीतता थोड़ी है. अगर एक है जिसको प्राइज नहीं मिला है, उसमें कोई बात ही नहीं है. It what counts is your effort and your will. तो विश यू ऑल द बेस्ट फॉर द फ्यूचर। खूब अपने काम में जो कुछ भी कर रहे हो उसमें बहुत तत्परता से करो। Always be dedicated, be devoted, and be honest and be sincere to your profession. God bless you all.
किसी का नाम थैंक्स नोट में रह गया होगा तो प्लीज मुझे एक्सक्यूज करना।
ना मुझे एक्सक्यूज करना, अगर किसी को बुरा लगा हो या किसी को कुछ हुआ हो तो मुझे एक्सक्यूज करना। God bless
आपने
you.
मेरा एग्जाम लिया था
Okay,
मेरा
Kirti. Okay, Reena.
Bye, madam. Bye, bye. Bye, Anshul.
रीना मैम
Bye, bye.
नमस्ते।
उषा मैडम, आपने मेरा एमएस का एग्जाम लिया था।
हाँ,
आपने मेरा एमएस का एग्जाम लिया था।
बहुत अच्छा लगा तुम्हें देख के, अभी कीर्ति ने बताया। इट वॉज रियली ए प्लेजर, बट जल्दी जल्दी ठीक हो बात करें तो।
हाँ, ये आई एम डेली अटेंडिंग वेबिनार्स।
चलो, ओके
Okay, bye, 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 bye.
Bye, all of you.
Bye, 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 bye.
बाय बाय।
एक स्क्रीनशॉट ले लेते हैं। आ जाओ अंदर, आ जाओ अंदर। बता देना, अभी तो मैं इसको कर लेती हूँ। एक्चुअली वो आ जाता है, बट आई थिंक ना कभी कभी मुझे लगता है मेरी माई फोटोज वाला फोल्डर। हाँ, मतलब मुझे फोल्डर नहीं पता ना, इसलिए मैं रिस्क नहीं लेती।
मीटिंग बंद कर दी।
हाँ जी बिल्कुल, हमें जुदा करने का मन नहीं कर रहा है, बट ठीक है, करना तो पड़ेगा ही। थैंक यू रितु।
थैंक यू मैम।
रितु एंड क्रिस्टियन, वेरी मच थैंक्स।
थैंक यू मैम।
फिर अभी किसी का जाने का मत चला।